अस्सलाम वालेकुम डॉक्टर मुमताज, आपको मेरी आवाज आ रही? अस्सलाम वालेकुम सर।
वालेकुम अस्सलाम। मेरी आवाज आ रही?
जी, आपकी आवाज आ रही।
ठीक हो गया। अच्छा, अब ये थोड़ा सा
अच्छा,
मुझे
आपने
गाइड कर।
पीपीटी जो है वो की हुई है, ओपन की हुई है सर?
हाँ जी, अब मैंने ओपन की हुई है।
जी सर। अब सर पीपीटी मिनिमाइज की हुई है ना अब आपने?
हाँ जी, खुली हुई है ये। इससे पीछे वाले उसमें खुली हुई है। छोटा कर दूं इसको?
हाँ बिल्कुल ठीक है। हाँ, इसको मिनिमाइज कर दें पीपीटी को।
मिनिमाइज हो गई।
अच्छा, अब जूम पे आ जाएं।
जूम पे हम आगे।
अच्छा, अब इसमें ग्रीन कलर का बटन होगा नीचे शेयर का सर।
स्क्रीन शेयरिंग कर दूं?
जी जी।
मल्टीपल चीजें खुल गई हैं अब इसमें। इसमें कहाँ है?
पीपीटी आई होगी, एक विंडो खुल गई होगी उधर, आपको आपकी पावर पॉइंट दिख रही होगी सर।
इसमें मेरे वाली नहीं आ रही।
सर वो ओपन है ना पीपीटी बैकग्राउंड?
क्या कह रहे हैं साथ?
मैं कह रहा हूँ सर, बैकग्राउंड में आपकी जो प्रेजेंटेशन है आज की वो ऑन है ना? अनशेयर कर लें आप, पहले तो आपकी शेयर नहीं हुई भी ना। अभी आप वो वाली सारी पीपीटी बंद कर दें और सिर्फ
ठीक है।
वही वाली खोलें जो कि आपको प्रेजेंट करनी है बस। बाकी सब बंद कर दें।
अच्छा जी, एक सेकंड। ये मैंने खोली तो हुई है लेकिन ये इस पे आ नहीं रही।
सर बाकी सब बंद कर दें, सिर्फ वो वाली खोल के मिनिमाइज कर दें। जब पूरी तरीके से खुल जाए उसके बाद मिनिमाइज कर दें।
आ, खुली तो वही हुई है यार।
खुली हुई है।
हाँ, खुली हुई है।
अब उसको मिनिमाइज कर दें।
मिनिमाइज कर दिया।
अब जूम पे आ जाएं।
जी, आ गया।
अब शेयर के बटन पर क्लिक करें।
शेयर कंप्यूटर साउंड।
नहीं नहीं, सिर्फ शेयर स्क्रीन पे आ जाएं।
अच्छा, मेन उस पे आ जाऊँ, जूम पे आ जाऊँ?
जी जी, जूम पे आ जाएं।
फिर हाँ जी।
अब देखें ग्रीन कलर का बटन आ रहा होगा शेयर का।
न्यू यूर स्क्रीन शेयरिंग, हाँ जी। न्यू
हाँ, इस
शेयर।
पे आ जाएं।
न्यू शेयर जो लिखा हुआ है।
जी सर, शेयर स्क्रीन जो भी है। आप आपने ना डेस्कटॉप शेयर कर लिया है, इसको वापस अनशेयर करें।
स्टॉप शेयरिंग लिखा हुआ है।
हाँ,
यूर
स्टॉप शेयरिंग करें आप इसको।
स्टॉप शेयरिंग कर दिया। ये ना एक विंडो खुल गई है जिसमें ये कोई 4, 8, 12, 13, 14 चीजें
ऑप्शन
हैं।
आ रहे होंगे, हाँ उसके अंदर पीपीटी को आपने सिलेक्ट करके ऑन करनी है, आपने डेस्कटॉप को ऑन कर लिया है।
मेरा
वही प्रोसीजर।
जो मेरा डेस्कटॉप है उसको।
हाँ, अभी मुझे आपका डेस्कटॉप दिख रहा है जिसपे मोर देन मीटिंग्स लिखा हुआ आ रहा है, लिम्फो एमसी।
मोर देन मीटिंग्स। अच्छा, हाँ, ये बिल्कुल यही आ रहा है। नहीं तो अब इस पे उसको खोलूं? वेबसाइट अपनी प्रेजेंटेशन को खोलूं? اب ٹھیک ہے؟ ہیلو 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 میری آواز آ رہی؟
جی سر مجھے آ رہی ہے آپ کی آواز. پی پی ٹی آن ہو گئی ہے سر اب آپ کو؟
ایکچولی مجھے میں نے تو کھولی ہوئی ہے یہ، ابھی فل اسکرین تو نہیں کی ہوئی، لیکن یہ پی پی ٹی میں نے کھولی ہوئی جس میں
ہاں
یہ
فل اسکرین کریں سر ذرا.
سوری
سلائڈ شو کر دیں سر اس کا.
سلائڈ شو کر دیں. یہ ہوگی سلائڈ شو.
جی سر ہمیں دکھ رہی ہے آپ کی پہلی اسکرین.
اوکے ٹھیک ہو
آگے
گیا.
چلائیے.
اچھا یہ آگے چلتے ہیں ہم. یہ ایک دفعہ ساری گو تھرو کر دیں.
جیسا آپ کو سہولت ہو سر.
بس یہ مطلب میرے یہی تھا کہ
ہاں
اب یہ
benign tumors and tumors like lesion in hand and upper limb بھی آ رہی ہے.
ٹھیک ہو گیا. لیکن
بالکل
یہ
فرسٹ کلاس.
ٹھیک ہو گیا تو اب ٹھیک ہے ایک دفعہ گو تھرو کر لیتے ہیں. اگر کوئی ویسے اس میں ویڈیو کوئی نہیں ہے، پکچرز ہی ہیں،
کوئی مسئلہ ہی نہیں.
کوئی ایشو نہیں. تو اب یہ میں واپس کیسے جاؤں گا؟ اسٹاپ شیئرنگ کر کے.
جی جی اسٹاپ شیئرنگ.
اچھا اس کا مطلب ہے اس کو میں بیک گراؤنڈ میں پھر آن رہنے دوں، اور پھر جب وہ
جی جی
ہوگا تو اس وقت میں پھر شیئر کر لوں اسکرین، ہے نا؟
بالکل ایسی.
چلیں ٹھیک ہو گیا، ٹھیک ہو گیا، تھینک یو. اچھا جی اور اب اسپیکر بھی ہو. ابھی کوئی اور بندہ بھی ہے ہمارے ساتھ؟
سر بریگیڈیئر صاحب ہیں ہمارے ساتھ. سر
یار یہ
السلام
ادھر
علیکم.
ہیلو.
السلام علیکم
وعلیکم السلام.
سر، ڈاکٹر ممتاز بول رہا ہوں.
ممتاز بھائی کیسے ہیں؟ بڑی خوبصورت تصویر آ رہی ہے آپ کی.
اچھا سر یہ ایکچولی میں نے وہ تھوڑا سا چینج کیا تھا لیپ ٹاپ، مجھے تھوڑا سا سمجھنے میں مشکل ہو رہی تھی اس کے
کوئی
سیٹنگ
بات
وغیرہ.
کوئی بات نہیں، کوئی بات نہیں. اور
سر
ٹھیک ہیں آپ؟
کیسے؟
بالکل صحیح ہیں.
الحمدللہ سر، الحمدللہ بالکل ٹھیک ٹھاک سر.
ماشاء اللہ آپ کا ڈپارٹمنٹ بڑا زبردست چل رہا ہے جی.
سر بس
بڑی شاندار قسم کی فیڈ بیک آ رہی ہے.
تھینک یو سو مچ سر، تھینک یو سو مچ. آپ کو بھی سر ہم نے تھوڑا سا وہ تکلیف دینی ہے اس وقت. تھوڑا یہ ذرا کووڈ والا مسئلہ ذرا سیٹ ہوتا ہے نا سر.
کیوں نہیں، کیوں نہیں، بالکل بالکل جناب
آپ
ہم حاضر ہیں.
کچھ ریڈیل کلب ہینڈ اور اس کے بارے میں نا سر آپ کی بھی تھوڑی سی گائیڈنس ہم نے لینی ہے.
بالکل ٹھیک ہے، بالکل ٹھیک ہے. چلتے ہیں کراتے ہیں. نہیں آپ کو تو ہم نے وہ جو ہے نا سنا ہے کہ ٹھیک ٹھاک کر رہے ہیں آپ کلب ہینڈ وغیرہ، رپورٹیں مل رہی ہیں تو ہم تو بڑے خوش ہو رہے ہیں. ہیلو.
السلام علیکم ڈاکٹر ذیشان.
ہلو ساتھ کی آواز غائب ہو جاتی ہے درمیان میں.
السلام علیکم.
سر السلام علیکم.
السلام علیکم ممتاز، کیا حال ہے؟ السلام علیکم ڈاکٹر خالد.
وعلیکم السلام.
کیسے ہیں سر آپ؟
میں ٹھیک ہوں بالکل. آپ سنائیں آپ کیسے ہیں؟ ٹھیک ہیں؟
اللہ کا شکر ہے سر، بالکل ٹھیک ٹھاک. میٹنگ یو آفٹر آئی تھنک 2008
دیکھ رہے ہیں.
یا اس طرح کچھ.
ہاں بس جب آپ کو ہم نے تکلیف دی تھی تو اس وقت آپ تشریف لائے، ورنہ آپ کی تو لفٹ کراتے ہیں ہم.
نہیں سر، تکلیف کیا وہ تو ہمیں عزت دیتے ہیں ہم. آپ بلائیں اور ہم نہ آئیں گے کیسے ہو سکتا ہے؟
زبردست زبردست. بس اب یہ دیکھیں یہ کورونا آ گیا بیچ میں، ورنہ تو ہم نے بڑے پروگرام آپ کے لیے رکھے ہوئے تھے.
چلے سر انشاءاللہ ویل میٹ. زندگی رہی تو یہ ملاقاتیں ہوتی رہیں گی.
جی انشاءاللہ انشاءاللہ. اور سنائیں کیسے ہیں
بالکل
بچے، کیسے ہیں گھر میں،
اللہ
سب
کا
خیریت
شکر
ہے؟
ہے. بس وہ 3-4 دن اسکول گئے ہیں، پھر اسکول بند ہو گئے ہیں.
یار بس یہ اسکولوں والے بھی جو ہے نا، جو آنکھ مچولی لگی ہوئی ہے اس نے بچوں کو تو کیا ڈسٹرب کرنا ہے، پیرنٹس کو زیادہ کیا ہوا ہے.
پیرنٹس کو بہت ڈسٹرب کیا ہوا. بالکل
ہاں
agreed.
ٹھیک ہے نا. ادھر سے اسکول والے، یونیورسٹیوں والے، اسکولوں والے تنگ کرتے ہیں، گھر آ کے بچے تنگ کرتے ہیں.
بالکل سر. رول
اور
رول جو رہے ہیں سر وہ ماں باپ ہیں.
لیکن یہ وہ رول نہیں ہے نا، رولتے گئے ہیں، اس میں چاس نہیں آ رہی نا. ہوتا وہ ہے نا ایک تو وہ رولتا ہے نا بندہ جس میں چاس آ رہی ہوتی ہے وہ،
جی سر
لیکن ہاں اس رولنے میں چاس نہیں آ رہی.
نہیں آ رہی.
ہاں
میں سر ایک منٹ میں آتا ہوں. 1 منٹ میں
جی
دو کام ہے سر جلدی کر کے وہ آ رہا ہوں.
اور سر آپ؟
اور ممتاز بھائی
جی سر
بچوں کا
بالکل.
سنائیں
اللہ
کیسے ہیں، ٹھیک ہیں؟
بس سر چل رہا ہے، جس سے نیا یونٹ کوئی لیتے ہیں نا، اس میں چھوٹے چھوٹے سے مسئلے مسائل کچھ.
ہاں نہیں یہ چھوٹے چھوٹے مسئلے مسائل چلتے رہیں گے، بس
جی
ان کو جو ہے نا وہ آپ کے راستے کی رکاوٹ نہیں بننا چاہیے. بس یہ تو آپ
ہاں
جب تک رہیں گے مسائل چلتے رہیں گے.
ایسے ہی ہے سر، مجھے بھی ایسے ہی لگ رہا ہے کہ یہ ختم ہونے والی چیزیں نہیں ہیں.
ہاں بالکل بالکل. تو نہیں نہیں وہ
برداشت
ماشاء اللہ
برداشت.
ماشاء اللہ ہاں بہت 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 اچھا چل رہا ہے جی آپ کا. وہ مطلب ہے کہ وی آر فیلنگ، حالانکہ میں گیا نہیں ہوں لیکن یہ کہ وہ خبریں ملتی رہتی ہیں،
سر
تو وہ کیا کہتے ہیں نا وہ بہت گراس چینج لگ رہی ہے، گراس چینج فیل ہو رہی
انشاءاللہ سر. وہ ایکچولی سر میرا تو ایم یہی ہے کہ لائک کہ جیسے اب یہ فورم ہے یا آپ ہیں یا یہ ذیشان صاحب ہیں، تو ہر بندہ اپنے اپنے فیلڈ میں ماشاءاللہ ایکسیلنس کام کر رہے ہیں. تو اس میں یہ ہے کہ ہم تھوڑا سا، چونکہ ہم ذرا جنرلی ہر چیز کو تھوڑا تھوڑا ٹچ کر رہے ہیں،
ہے.
تو
ہاں
میں
بالکل
اپنے
بالکل
جو میرے جونیئرس ہیں، ہم اس طرح کی چیزیں رکھیں جس سے آپ لوگوں سے بھی ہم گائیڈنس لیں پرٹیکولر معاملات میں، پرٹیکولر کیسز میں. تو میرا خیال ہے
نہیں
سر ترقی کا تو یہی طریقہ ہی ہے، چینج
آپ کا
لانے
تو جو پیریڈ، وہ جو فیلڈ ہے وہ تو بڑا وسیع ہے.
ایگزیکٹلی.
تو ہاں اس میں تو اصل آرتھوپیڈکس کی تو وہ ہے ہی نہیں نا، یہ تو کچھ ڈفرینٹ
جنرل.
چیز ہے.
جی
ہاں
بالکل ایسے ایسے.
تو یہ
اب تو سر
اس
میں
میں
تو
وہ
لڑکوں کو یہی گائیڈ کرتا ہوں نا کہ مطلب جو بندہ جس میں انٹرسٹیڈ ہے وہ اس میں آگے جائے. لائک اگر ہینڈ میں ہے تو وہ لائک آپ کے ساتھ کرے، یا ٹیومر میں ہے تو وہ پھر ان لوگوں کے ساتھ کرے. جنرلی تو ٹراما تو سب لوگ ہی کرتے ہیں، لیکن باقی ہر بندہ ہپ میں ہے تو بندہ کوئی ہپ میں لے، یا اسپائن میں انٹرسٹیڈ ہے تو وہ میں تو ان لڑکوں کو اس طرح انکریج کرتا ہوں کہ اپنی
بالکل
اپنی
ایسے ہی
فیلڈ.
ہے اور ہونا بھی ایسے ہی چاہیے. ابھی تو یہ اسپیشلٹی کا دور ہے تو وہ جنرلٹی تو ختم ہو گئی نا اب. تو
ایگزیکٹلی
ہاں
جنرلائز والا کام ختم ہوتا
بالکل
جا رہا
ہاں. تو وہ تو آپ تھوڑا بہت کر ہی لیں گے جب بھی آپ کو ملے گا وہ بھی. لیکن
ہے.
وہ
جی سر.
اپنی جگہ ایک اسپیشلٹی ہے، لیکن یہ کہ یہ اس کو بھی لینا چاہیے، ہمیں ضرورت ہے، ہمارے معاشرے کو بھی ضرورت ہے، ملک کو بھی ضرورت ہے، اور اپنے فیوچر کے لیے بھی چاہیے نا.
ایسے ہی
مطلب ایک
ہے.
ہاں جس فیلڈ میں آپ کو اپرچونیٹیز ہوں بندے کو ادھر جانا چاہیے.
یہ بھی تو سر بہت بڑا مسئلہ ہے نا. اب کافی سارے لوگ جو میرے ساتھ آتے ہیں نا، وہ اس چکر میں بھی آ جاتے ہیں کہ جی ان کو اور اپرچونٹی نہیں ملی تو چلو وہ ادھر آ گئے.
ہاں یہ نا وہ
اب وہ
شوق والا کام نہیں ہوتا ہے نا،
جی
شوق
جی
والا کام نہیں ہوتا جو چیز جو
کل
ہے نا.
کام ہے، ان کو
کیونکہ
موٹیویٹ
وہ
کرنا ہے.
جب شوق کی بات ہوتی ہے تو جہاں کہ میں بیٹھتا ہوں میں آپ کا ذکر ضرور کرتا ہوں. میں نے کہا جی ہمارے پاس بھی آتے ہیں نا بندے، ہمیں تیسرے دن پتہ چل جاتا ہے کہ یہ بندہ شوق سے آ رہا ہے یا مجبوری سے آ رہا ہے.
ایسے ہی.
ہاں میں نے کہا جنہوں نے شوق سے سیکھنا ہوتا ہے نا وہ نظر آ جاتا ہے کہ یہ جو ہے یہ واقعی ہی وانٹس ٹو لرن.
ایسے ہی.
تو ہاں تو اس کو پھر بتانے کا بھی مزہ آتا ہے، یہ بھی مطلب ہے کہ پڑھانے کا بھی انجوائے بندہ کرتا ہے.
بالکل سر بالکل.
ہاں
میں سر وہی، آپ تو ماشاءاللہ کافی عرصے سے نا، اب جب سے میں تھوڑا سا کنٹرول لیا نا تو وہ میں یہ چیز بڑی فیل کر رہا ہوں کہ آپ کی وہ ٹیم ہے 10-12 لوگوں کی ٹیم ہے، تو اس کو آپ اب اس میں کچھ ہیں جو بڑے شوقین ہیں جو انٹرسٹ سے ہیں، کچھ ہیں جو بس 8 to 2 والا کام ہے یا بس حاضری لگانے والا کام. اب ان چیزوں کو ایکولیٹ نہیں کیا جا سکتا، وہ
ہاں
ہو نہیں سکتی. وہ
ہاں نہیں
چاہتے
وہ
ہیں
تو
کہ ان کو
وہ
ایکولیٹ رکھا جائے لیکن
نہیں وہ
interest-
ہاں ہاں نہیں ان کا وہ جب بھی آپ سے ہوں گے نا ان کا گلہ یہی ہوگا کہ جی آپ جو دیکھو جی وہ تسی ਉਹਨੂੰ ਉਹ ਕਰਾਉਂਦੇ ਹੋ ਸਾਨੂੰ ਇੰਨਾ عرصہ ہو گیا تو
Exactly.
سانو تا اجے ہمیں تو ابھی تک اس چیز کا موقع نہیں ملا. یہ آپ کو یہ چیزیں سننے میں ملیں گی لیکن یہ کہ اس میں وہ چلو ایکولائز نہیں کر سکتا تو ان کو بندہ بیچ میں نا ان کی میں ایگزامپل دیتا ہوں تو کہ اس طرح کے لوگوں کو چھوڑنا بھی نہیں چاہیے. ان کو بیچ میں گھسا لینا چاہیے جس طرح اپنا یہ جو حرم میں طواف کے دوران جو ہے نا بندہ بیچ میں گھس جاتا ہے تو خود بخود دھکوں سے چلتا رہتا ہے.
چلتا رہے.
تو اس طرح یہ دھکا سٹارٹ پروگرام جو لوگ ہوتے ہیں نا ان کو بھی چلانا تو چاہیے. یہ بھی جو آ گیا ہماری ذمہ داری تو بن گیا ہے نا ہمارے پاس. تو
صحیح کہا.
وہ چلو کم از کم باہر جائے حاجی تو کہلائے نا، وہ الگ بات ہے.
صحیح کہہ رہے ہیں.
وہ الگ بات ہے کہ جو طواف اس نے پچھلے والے کے دھکے کے ساتھ کیا ہے. تو
بڑی زبردست ایگزامپل ہے سر.
تو یہ جو ہے نا ان کو بس آ گئے وہ پوچھ لیں ان سے بھائی صاحب آپ نے رہنا ہے کرنا ہے سیکھنا ہے کہ نہیں سیکھنا ہے. اگر وہ شوق کرتا ہے تو بس پھر اس کو کچھ ایسے ہوتے ہیں نا آپ کے بھی 3-4 بچے ہوں تو ایک دو بچے ذرا کھڑ قسم کے ہوتے ہیں اس طرح کے، ان کو اس حساب سے ساتھ لے جانا پڑتا ہے.
ایسے ہی
چھوڑ تو نہیں، ہاں چھوڑ تو نہیں سکتے نا، جو آ گئے ہیں بس وہ آ گئے ہیں. بس وہ
کوشش یہی
بہرحال
کرنا
یہ تو ہے کہ جی وہ سیکھتا بندہ اپنے شوق سے ہے. سکھانے والے کی تو ایک ہلکی سی ایفرٹ ہی ہوتی ہے، سیکھنے
بالکل
والے
بالکل
کی آپ ہاں وہ اپنے شوق.
یہی سر فرق ہے نا. وہ ایکچولی یہی چیز میرے خیال اینڈ میں ڈفرینس ڈال دیتی ہے. وہ
بالکل
جو
بالکل
اپنی ول سے آیا ہوتا ہے وہ پھر بہت آگے چلا جاتا ہے، تھوڑے سی شاید ایفرٹ کے ساتھ ہی بہت آگے چلا جاتا ہے. لیکن سر جو میں چیز فیل کر رہا ہوں وہ یہ ہے کہ ایکچولی جب آپ ٹیم ورک کے طور پہ سوچتے ہیں نا تو پھر آپ کی کوشش تو یہ ہوتی ہے نا کہ آپ ذرا ویلنگ ورکرز کو پک اپ کر لیں اور پھر باقی ادروائز شاید اسپیڈ سلو ہو جاتی ہے جو آپ جس
نہیں
جس پہ چلنا
وہ
چاہتے
ان کی وہ ویلنگ ورکر جو ہوتے ہیں نا ان کو آپ نے اپنی ٹیم کا میجر پارٹ بنانا ہوتا ہے. وہ آپ کے جو ہوتے ہیں سلپس میں کھڑے ہونے والے کھلاڑی ہوتے ہیں. باقی جو ہوتے ہیں ان کو باؤنڈری پہ کھڑا کر دیں لیکن استعمال کریں ان کو بھی. جب کبھی گیند آئی تو پکڑ لیا انہوں نے بھی. تو ٹیم آپ نے خود بنانی ہے، ٹیم آپ نے خود بنانی ہے. آپ کو ہر بندہ وسیم اکرم تو نہیں ملے گا نا.
میں وہی سوچتا ہوں نا کہ جیسے اب ذیشان صاحب نے بھی میرے خیال ہے اسٹارٹ میں تو وہ گورنمنٹ سیکٹر شروع کیا لیکن اب انہوں نے شاید اپنے پک اینڈ چوز کر کے اپنی ایک ٹیم بنا لی.
اب آپ کا بھائی بھاگنے والا ہے نئے پاکستان میں سے.
نہیں یار بھاگنے نہیں دینا. ایسے بندوں کی ضرورت ہوتی ہے، جب ضرورت پڑتی ہے تو آپ لوگ بھاگ جاتے ہو. یہ کیا بات ہے بھائی؟
نہیں سر وہ گورنمنٹ جاب بہت اب اس کا کوئی مزہ نہیں رہا سر. وہ اب آپ کو یہ کہہ رہے ہیں کہ بس جو ہم کہیں گے وہی کرنا ہے اور کوئی فائدہ نہیں ہے. وہ ابھی آئی ہوپ وین یو گائز آر ایکسپوز ٹو اٹ سر آپ تو نہیں، آپ کی تو وہی جب وہ نہیں رہے آپ کا وہ اسٹیچر بھی اب نہیں ہے. ہم تو جونیئرز ہیں. ممتاز کو شاید یہ فیل ہو کہ جب یہ وہ ایم ٹی آئی ایکٹس فلی طرح سے لاگو کریں گے then practice becomes absolutely impossible and it's a shame کہ آپ نے ایک چیز شروع کی ہو. لیکن سر ادارے تو چلتے رہتے ہیں، انڈیویجولز امپورٹنٹ نہیں ہوتے، انسٹیٹیوشنز رہتی ہیں. انشاءاللہ اپنی یہ پریکٹس کسی اور ادارے میں جاری رکھیں گے.
ہاں بالکل یہ ہے کہ جی دیکھیں اگر کہیں آپ کو پرابلم ہو رہی ہے تو بندہ اپنی وہ ٹریک چینج کر لیتا ہے، لیکن یہ کہ وہ اپنی ڈیسٹینی تو نہیں چھوڑتا نا.
نہیں سر ہم کشتیاں
تو
جلا
ہمارا
کے
پہلا
واپس
ہاں بس وہ جو کشتیاں جلا کے آ گئے ہیں نا تو بس اب جو آبجیکٹو اپنا رکھیں کہ جی ٹو سرو دی ہیومینٹی. میں آپ کو یقین دلاتا ہوں آپ کا آبجیکٹو یہ رہے گا نا، باقی چیزیں بھاگ کے آپ کے پیچھے پیچھے آئیں گی. یہ میں آپ کو لکھ کے دے دیتا ہوں.
بالکل سر، اس میں کوئی
ٹھیک
شک
ہے نا.
نہیں.
ہاں تو وہ آبجیکٹو جو ہے نا وہ یہ رکھیں. ہمیں بڑی ضرورت ہے جی، ہمارے ملک کو بڑی ضرورت ہے. مجھے بڑا دکھ ہوتا ہے، افسوس ہوتا ہے، بڑے اچھے اچھے سمجھ وہ کرنے والے لوگ جو ہمیں چھوڑ کے چلے جاتے ہیں. while مطلب وی نیڈ مطلب پیپل لائک یو ہیئر. وہ کہ کیا کریں گے لوگ ادھر کے جب
سر
سب ہی چلے جائیں گے.
ہم تو
ہاں
سب کو چھوڑ کے
ٹھیک ہے.
واپس آئے.
ہاں بالکل بالکل.
ویسے میری
تو
ایک فیلنگ ہے ذیشان بھائی کہ یہ ایم ٹی آئی آنے سے نا ایک اور جو چیز ڈیولپ ہوگی نا وہ لائک جیسے انڈیا میں ہے کہ جو یہ پرائیویٹ سیکٹر ہے وہ شاید ان ہوگا ان دی فارم آف کوئی ہاسپٹل نیٹ ورک یا اس طرح کی چیزیں نا، کوئی بڑی سیریز جو ملٹیپل ہاسپٹل ڈفرینٹ جگہوں پہ بنائے، مے بی کہ اس طرح کی کچھ چیزیں ان ہوں گی پیرلل ٹو گورنمنٹ.
یہ ultimately this is what is going to happen. I think this is my feeling. شاید یہی ہو. لیکن دیکھیں نا آپ کو 8 سے 4 بجے تک گورنمنٹ ہاسپٹل میں جاب کرنی پڑتی. میری سیلری ایز اے سب اسپیشلسٹ سرکار کی کتابوں میں ایز اے گریڈ 18 آفیسر اور میرے ریزیڈنٹ کی سیلری میں 9,000 روپے فرق ہے. اب اس سیلری میں تو میرے گھر کے بجلی کے بل اور میرے ساتھ جو چند ایک لوگ کام کرتے ہیں ان کی تنخواہیں پوری نہیں ہوتی، تو میں گھر کا خرچہ کیسے. پھر 4 بجے کے بعد یہ ایکسپیکٹ کرتے ہیں کہ میں گورنمنٹ ہاسپٹل میں اپنی پرائیویٹ پریکٹس کروں، which in my books is the major conflict of interest unless آپ ایک سیپریٹ انڈیپینڈنٹ بلاک بنائیں، اچھی جگہ بنائیں. دیکھیں انہوں نے ابھی کیلکولیشن کی ہے کہ ایک ڈی ایچ ایس جو ہے ایک سمپل سا آپریشن پرائیویٹ سیٹ اپ پرائیویٹ پریکٹس میں جب آپ گورنمنٹ ہاسپٹل میں کریں گے تو مریض کو تقریباً 90,000 سے 100,000 روپیز تک پڑتا ہے. اور وہی آپریشن میں پشاور کے جس ہاسپٹل میں پرائیویٹ پریکٹس کرتا ہوں which is a very posh hospital of KP، وہاں پر وہ 1,25,000 1,30,000 روپے کا پیشنٹ کو پڑتا ہے. تو کسی پیشنٹ کا دماغ خراب ہے کہ وہ اپنی بےزتی کروائے جہاں پہ گورنمنٹ سیٹ اپ میں آپ کو کوئی فیسلٹی اویلیبل ہی نہیں ہے کہ وہ 1,00,000 روپے وہاں پہ دے. جو 1,00,000 روپے افورڈ کر سکتا ہے وہ 1,20,000 بھی افورڈ کر سکتا ہے. تو ایشو جو ہے وہ اس پیشنٹ کو ہوگا جو کچھ بھی افورڈ نہیں کر سکتا. وہ ابھی یہ صحت کارڈ والا جو قصہ بھی ہے اس میں بھی انہوں نے جو رینیومریشن آف کوڈز یا پیکیجز کیے ہیں وہ اس طرح ہے کہ وہ انسین ہے. مطلب اب آپ میجر ٹیومر سرجری کا انہوں نے ایک بلاک بنا دیا، ایک نام دے دیا کوڈ. لیٹ سپوز آپ ریسائکلنگ کر رہے ہیں، اس کا ٹوٹل پیکج جو ہے وہ 40,000 روپے. 40,000 روپے میں تو اس کی تو فارمیسی بھی پوری نہیں ہوتی. تو وہ بھی ایک مذاق ہی ہے. تو you have to be clever and ingenious. جیسے ڈاکٹر خالد کہہ رہے تھے you have to think about our patients and try and make up some ways. ڈاکٹر مسعود عمر کا ماڈل بڑا اچھا ہے، یہ چیریٹیبل جو ڈونیشن جو کلیکٹ کرتے ہیں، یہ بھی ایک اچھا ماڈل
وہ
ہے،
بنا لینا.
اس پہ بھی کام کرنا چاہیے.
میرا خیال یہ ہے کہ آپ کی بات بالکل صحیح ہے، آپ بالکل درست کہہ رہے ہیں. یہ سچویشن جب یہ بنی ہے اس کے اوپر کوئی غالباً انہوں نے پراپر ورک اپ نہیں کیا اور اس کو وہ لگ دی ہے. ورنہ تو یہ ماڈل تو بڑا سکسیسفل ہے کیونکہ یہ ہمارے اپنے سیٹ اپ میں یہی ماڈل چل رہا ہے. اور جو پہلی بات ہے وہ تو میرا خیال ہے کہ وہ یہی ہونی چاہیے. آئی ٹوٹلی ایگری ود یو کہ فرسٹ یو ہیو ٹو پرووائڈ دی فل سپورٹ اینڈ فل سپورٹ ٹو دی ڈاکٹرز اینڈ فیسیلیٹیشن ٹو دی پیشنٹس. جب تک کہ آپ یہ چیزیں پرووائڈ نہیں کریں گے آپ کر نہیں سکتے. یس اس کے بعد ٹھیک ہے جو پیکیجز ہیں وہ ریوائز ہوتے رہتے ہیں. وہ یہ نہیں ہے کہ جی جو آج بنا ہے وہ اب پوری زندگی کے لیے یہی ہے. بہرحال اگر اپنے آپ کو پرائیویٹ سیٹ اپس کے ساتھ کمپیئر کرتے ہیں تو ہمارے منہ بھی کھلے رہتے ہیں کہ یار یہ ہمیں یہ کیا ملتا ہے، ادھر یہ ہوتا ہے. لیکن یہ ہے کہ یہ میرا خیال ہے، میری جو اپنی اوپینین ہے وہ یہ ہے کہ جی یہ ایولیوشن میں ہے. پروبیبلی اگلے کچھ عرصے میں یہ جو ہے یہ چیزیں سیدھی ہو جائیں جب ہماری طرف سے بھی ان کو پازیٹیو انپٹ جائے گی. ایک چیز ہوتا ہے جب چیز کو ایکسیپٹ کرنا، جب آپ ایکسیپٹ کر لیتے ہیں تو پھر آپ پازیٹیو ان پٹ دینا شروع کرتے ہیں. جب چیز آپ ایکسیپٹ ہی نہیں کرتے ہو اور اس کے اوپر آگے ریئیکٹ ہوتا ہے تو وہ پھر چیزیں پرابلم میں چلی جاتی ہیں.
السلام علیکم.
السلام علیکم ڈاکٹر.
السلام سر کیسے ہیں؟
Thank you for joining everybody. I think we are over time. اطہر صدیقی کا میں انتظار کر رہا تھا کہ وہ جوائن کر لیں. آئی ڈونٹ نو، میں نے ان کو میسج تو کیا ہے لیکن آئی تھنک اٹس 9:05 تو وی شوڈ اسٹارٹ. ہم بسم اللہ کرتے ہیں. تو پروگرام تو بنا ہی ہوا ہے، ہمیں پتہ ہے ہماری ٹاکس آئی تھنک اطہر کے ادھر بہت صبح ہوگی اس وقت، شاید 4 بجے ہیں.
جی ڈاکٹر مسعود عمر، السلام علیکم.
والسلام.
ادھر ابھی 5 بج گئے.
5 آپ بھی ہاں یو کے میں ہیں نا، ٹھیک ہے. تو اطہر کو ذرا فون تو کھڑکا دیں ادھر سے، کدھر ہے وہ پرائیویٹلی. تو آئی تھنک وی بگن ان دا نیم آف گاڈ. سعد تھوڑا ریسیٹیشن فرام ہولی قرآن آپ پلیز چلا دیں. زیادہ آپ کی آواز کلیئر نہیں آ رہی.
جی السلام علیکم سر. سو 9 بج گئے سر، تو ہم بلکہ 9:05 ہو گئے. I'm not seeing Dr. Athar over here, so maybe probably he can give an introduction after Dr. Mumtaz's talk.
جی ڈاکٹر عائشہ آپ ماڈریٹر ہیں، پلیز گو ہیڈ. دیٹس واٹ آئی واز سیئنگ وی شوڈ اسٹارٹ دا پروگرام. میرے خیال سعد نے تلاوت کی ہے لیکن وہ مجھے نہیں سنائی دی. تو بہرحال وہ ہم بھی بسم اللہ الرحمن الرحیم. انا اعطیناک الکوثر فصل لربک وانحر ان شانئک هو الابتر. اللہم صلی علی سیدنا مولانا محمد وآلہ بارک وسلم علیہ. Thank you all again for all participants and faculty members for joining. This is part of the pre-Orthocon symposium, the Oncology symposium today. Hopefully it will have some good useful take-home messages. We selected the theme of upper limb tumors for today, kind of narrowing ourselves down and then expanding ourselves on a narrowed, smaller theme, rather than taking oncology in general, which is a much broader theme. So I think Dr. Athar Siddiqui, as Dr. Aisha said, would soon be joining us in due course of time. But I think let's get going. Over to you, Dr. Aisha, please.
Okay, thank you very much, sir. So welcome everyone. And the first session is going to be on the general principles of our upper extremity tumors. And I will request Dr. Mumtaz Hussain, who works as assistant professor and head of department at Children's Hospital Pediatric Orthopaedic Unit, to give his talk on benign tumors and tumor-like conditions of hand and upper extremity tumors. So over to Dr. Mumtaz.
Thank you very much. Is it okay? Everybody can see. Saad? Visible
Yes,
for
sir.
everyone?
Yes, sir. Visible.
Achha ji. Bismillahirrahmanirrahim. Thank you very much, Dr. Aisha. I'm Dr. Mumtaz from Children's Hospital and University of Child Health Sciences, Lahore. This is a wonderful aerial view of the Lahore, Bashai Mosque, Shahi Qila and Minar Pakistan. This is my situation, the Children's Hospital Lahore at the main Firozpur Road, Lahore. So the topic today assigned to me is the benign tumors and tumor-like lesions. Okay. Before detail of according to classification of bone tumors, there are benign tumors, there are benign aggressive tumors, malignant tumors, and non-neoplastic tumors. So my topic is regarding the benign tumors, bone tumors. Benign bone tumors are divided into fibrous lesion, cystic lesion, and miscellaneous benign tumors. In fibrous lesion, we will see the fibrous cortical defects, non-ossifying fibroma, cortical desmoid, fibrous dysplasia, unicameral cyst, and in cystic unicameral aneurysmal and joint ganglion cyst. And in miscellaneous bone tumors, vascular tumors, bone forming tumors, and cartilage forming tumors. Okay. So my first case, just a minute, please. So 7-year-old boy presented with a 16 to 8 meter swelling of the right proximal humerus. It's a firm to heart swelling, not associated with any systemic illness and lymph nodes, and mild tender swelling. On investigations, it's come to be a hard bony swelling that's intermedullary cavity is communicating with the cavity of the bone mass. Clear margins, and on MRI there is a well encapsulated this is swelling. So looking benign, so anterior approach is used, and the lesion is excised. There is lower down is the specimen with the clear smooth surface and the clear encapsulated margin. On histopathology report, it's a exostosis. So this is the post-operative radiographs, and recovery was uneventful. So simple exostosis, and or other word called the osteochondroma. It's a benign chondrogenic lesion derived from the aberrant cartilage from the perichondrial ring. There are two types: solitary osteochondromas and multiple hit exostosis. It's the most common benign tumor, common in adults and young adults, occur usually on the surface of the metaphyseal area of bone and the size of tendon insertions. Common locations are around knee, distal femur or proximal tibia. Proximal femur and proximal humerus are also common. These can usually arise secondary to Salter-Harris fractures and after surgeries, and it's also after the radiotherapy. It's the most common benign radiation-induced bone tumor. So associated condition is its transformation, malignant transformation into chondrosarcoma, although chances are less than 1% in simple chondroma, but chances are increased with the multiple hereditary exostosis. Multiple exostosis are involved, then chances of malignant transformation increase by 5 to 10%. So this is important. So every lesion that's excised, surgery done, it must be biopsied for the capsular thickness for its malignant transformation point of view. On radiographs, there are two types, sessile and pedunculated. The upper one picture is showing the pedunculated and osteochondroma, and lower is the sessile. CT and MRI are of little use just to see the detailed geometry or the size of this. This is the picture of the same one patient showing the multiple lesions. This is the multiple picture of multiple hereditary exostosis. As I work at an institution that have viewed drainage areas, sometimes we come across the unusual presentations of multiple hereditary exostosis. This child presented to us with the exostosis of the ribs area or scapular area without any apparent symptoms except cosmesis and pain due to pressure. But they left without surgery. Another unusual presentation, this is a female of 15 years old. She presented, she belonged from KPK, and she presented with no previous taking consultation and opinion. This is a hard swelling, and after investigation, the other it turned out to be exostosis of the right scapula. Simple excision was done, but it was not possible to extract this in a single piece. Multiple pieces have been removed, but surgery was uneventful. My next case is a 9-year-old girl presented with multiple deformities in the lower limb as well as in the upper limb. Their long bones, metaphyseal areas are involved with multiple lesions, and there is a genovalgum at the right knee and the genovarum at the left knee, but the valgus deformity at distal labia on the left side is compensated a little bit, and there is also cubitus valgus. So the patient main concern was about the lower limb first. So if we address the correct the genovalgum, but later on we have planned to address her cubitus valgus deformity. So this is the case of Ollier disease, multiple enchondromatosis. Enchondroma is a benign chondrogenic tumor composed of hyaline cartilage located in the medullary cavity caused by the abnormality of chondroblast function in the physis, and it's the second most common benign cartilage lesion. Male to female ratio 1:1, and the most common locations are the hands and feet. Hands are more involved as compared to feet, and when there are presentation when multiple enchondromatosis, hands and feet and multiple metacarpal and metatarsals can be involved. Important thing is the Ollier disease is skeletal dysplasia with failure of normal enchondromal ossification and chondromas throughout the metaphysis and diaphysis of the long bone, and the risk of malignant transformation is less. So the important thing is association with the soft tissue angiomas. It's called Maffucci syndrome, and on radiographically enchondromas in the Maffucci syndrome markedly expand bone and angiomas are seen in the small round calcific fibrillings. The risk of malignant transformation is near 100%, and there are also chances of visceral malignancies. So images are advised different views, but if it is multiple enchondromatosis, then the skeletal survey is mandatory. Bone scan also is not so helpful, but it can differentiate. It's usually used to differentiate it from osteochondrosarcoma and to identify polystotic diseases. And these MRI is also again usually used for identification of size and the extent of the soft tissue extent of the lesion and differentiate it from chondrosarcoma. So next case is 8-year-old girl presented with swelling of her right distal radius. This with a history of 1.5 years. This is progressively increasing size. It's expansile, tender swelling with no soft tissue involvement, but the size is increasing, and there are investigations on MRI. There is subtations and including the erosion of the bone. So this was aneurysmal bone cyst. And biopsy was planned, but this is a recent radiograph, so biopsy is planned. Biopsy is usually necessary to differentiate it from the telangiectasic osteosarcoma or the joint cell tumor. To differentiate it, biopsy is needed, and later on we will go for its extended curettage. So aneurysmal bone cyst, they are common below the 20 years of age, eccentrically located within the cortex. Any bone can be involved. Usually appearance is honeycomb appearance, and biopsy is usually necessary. CT and bone scan and angiogram can help for surgery planning. Wide resection, extended curettage with and without reconstruction, there are for. This is a 4-year-old boy presented to me with a relapse of his hand swelling. Previously 2 times was operated and so not successful. I could not retrieve his radiographs. Bones were normal, but there is the swelling and is AV malformation, and I have no choice other than amputation. I consulted the plastic surgery people and referred to them if they have any other options for this cute boy. Now, a few words about the other topics. Fibrous cortical defects. These are common between 2 to 20 years, dominant in male, and occur in the metaphyseal region of long bone. This is eccentrically located radiolucent areas near the physis of long bone. Defect usually resolved without any treatment. Non-ossifying fibroma, these are osteolytic, eccentrically located, and oval multiloculated appearance of the erosions of the cortex, and surgery needed for impending fractures or significant pain. Cortical desmoids, irregularity in the metaphyseal area of the bone, and erosion of the cortex with the sclerotic link usually do not need any treatment. Next is the osteoid osteoma, very common in young males. Usually have a pain that is worse at the night and relieved by aspirin. This is the typical history. And investigation of choice is a CT scan, where we found out double density rings or called a ring into ring formation. So the main focus is to remove the nidus. The ideal treatment is the radiofrequency ablation therapy, which is cost a little bit on our setup. So the by surgery, and the main principle is removal of nidus. Fiber dysplasia, there are two forms, monostotic and polyostotic, and there is usually replacement of normal tissue by fibrous tissue. So can be epiphyseal, metaphyseal, or diaphyseal, but usually it's a diaphyseal or metaphyseal junction. So the lucent area appear, and then later the treatment is usually curettage, open reduction, internal fixation, and with grafting, and without fixation. In cystic lesion, we have two topics: unicameral cyst. It's common in first 2 decades. Proximal humerus, proximal femur, and neophysis. Curettage with and without bone grafting is the treatment. Now I have a series of 3 cases. This child, 7 years old, 8 years old, presented with a swelling of the left proximal humerus. This is the DN septation, although there is septation, but it's a simple cyst. So it treated aggressively with extended curettage and with fibula stud graft and idioclast and bone substitute. And after 2 months, there is very good healing and complete development and uneven surgery. Same is the swelling of the right proximal humerus. This is again 5 years old boy, and done the extended curettage along with the bone substitute. And after 3 months, there is good healing and no issue. Another case, again, this is this left proximal humerus swelling with, although there seems some septation, but it was turned out to be a simple cyst. And here we only did the aspiration and the injection of the local anti-inflammatory. So after 4 months, this is the lower down radiograph is the 4 months follow-up, and there is good healing and no issue. So multiple things to treat the simple cyst, but if we do the less invasive procedure, the results are almost equivalent. So this is all about. Thank you so much. Go to the question.
Thank you very much, sir. And it was a really enlightening talk, and we came to see a lot of the cases that you showed really made us more aware of the benign lesions. Now I will request Dr. Jahangir Riaz. He's an orthopedic surgeon from Multan, and I believe currently he's on a fellowship in England. So I'll request him for his talk on malignant bony tumors of hand and upper limb.
Ji, thank you very much, Dr. Aisha. I'm just sharing my screen now.
So as Dr. Jahangir is sharing his screen, I will request the participants to kindly post their questions in the chat box so that at the end of the session, we can take answers from the faculty.
Dr. Aisha, can you see my screen?
Not right now.
Okay.
It will be better if you share your presentation rather than the whole desktop.
Okay.
So, since we have some time before Dr. Jahangir sorts it out, so I have a small question from Dr. Mumtaz. Sir, I wanted to ask you, whenever we come across a benign lesion, especially in children, it's really very tricky to set the bar, like when, if or not you're going to do an excisional biopsy or you're going to make an incisional biopsy, because many of the times the very benign looking lesions, they turn out malignant. Where do you put that bar? Like when you are exactly sure that this is a very, very benign lesion?
Actually, many things we learn with the experience. So, in my opinion, biopsy is very mandatory. Where that we see in literature and we have a textbook. Then when we were in learning phase, that meant. But we just skip, or I think we're thinking about the patient point of view that he will do first time we will come for surgery, biopsy, and then second time we will come for definitive treatment. But I have learned that that why we will discuss a case in our discussion later on. That sometimes very benign looking tumors, they come up with the sarcomas and other thing, and that and we are at no way when we first time treat it aggressively, and later on we come to know that we are the what we say, we are the reason.
It turns out like tumor, or it turns out malignant.
So now I am clear that we must do surgery, although whatever it's physically it's looking or anything, just do surgery, do biopsy, and then plan for definitive treatment. Even though it's looking benign or whatever your radiologist is saying, just just don't listen.
Have faith in the radiologist. Yes. Okay, so Dr. Jahangir, if you're unable to share, you can just send me your presentation over email quickly, and I will share for you. Are you using an MacBook?
Yeah.
Yeah, so sometimes it does happen. The Zoom settings in the MacBook are not compatible, so sharing is not possible. So you can just quickly send me your presentation and I will share on your behalf.
Yeah, it's coming to you.
Thank you.
Dr. Aisha, if I can make a comment.
Yes, sir.
Lesions which are very typical of a UBC in the upper humerus.
Jahangir, can you hear me?
Yes, Dr. Asthar, I can hear you.
हेलो डॉक्टर जहांगीर अभी स्क्रीन की पोजीशन क्या है आपकी? हेलो.
Okay, Saad, so what we are doing is, I am going to project the presentation on his behalf. So meanwhile, Dr. Masood Umar is going to make a comment. So it's sorted out.
I was saying lesion which typically appears like a UBC on a proximal humerus X-ray, would you still do a biopsy?
Sir, UBC completely confused with the aneurysmal bone cyst. So personally, yes, I'm in the opinion, because I have started to doing the biopsies with the needle, and I'm trying to we take it just 10 minutes only with my anesthetist. So I'm in opinion that yes, we should go for biopsy, because in ABC, biopsy is very important to differentiate it from other things. So in my opinion, yes, either it's a unicameral or ABC. If there is any logistic problem, is not, so I would preferably go for biopsy.
So in my practice currently, I have stopped doing biopsies for lesions which are very typical of the proximal humerus, look like a UBC. Not for ABC, but for UBC, unicameral bone cyst, like a fallen leaf sign and multiseptate appearance, and the site itself, which is proximal humerus. So I guess we counsel the patients, the parents actually, and we observe. We do serial X-rays, maybe on a 2-monthly basis for the first 2-3 visits, and then once the parents also gain confidence, that the lesion is not growing and the pain is settling, even if there is a pathological fracture sometimes of a cortex, you just blend them and they heal well. I may be slightly going away from the book, but over time practice has told me that once you biopsy them, we need to learn from the radiology, and if experience tells us that enough radiological features are there, I have personally stopped doing, it may be controversial, but I have stopped doing biopsies for proximal humerus UBCs. Thank you.
So thank you, sir. We can now see Dr. Jahangir's screen. So kindly make it slide share and we go about.
Okay, can you now see my screen, please?
Yes.
Okay, that's great. So thank you very much for inviting Dr. Masood Umar and Dr. Attar. And it's great to have among you all of the faculty. So my introduction is, my name is Jahangir Riaz, and basically I belong to Multan, and I had my fellowship of sarcoma from Singapore, and now I'm working in Royal National Orthopaedic Hospital, Stanmore in England, which is one of the major referral center in England, and which is basically a part of London Sarcoma Service. The presentation today is a malignant tumors of the hand and forearm, which is assigned to me. As we know, malignant tumors of the hand and forearm, it's quite rare, which is some of the literature, it reports at less than 1% of the upper limb malignancies. It's the most common primary malignant tumor of the hand is chondrosarcoma. Most common soft tissue sarcoma is a malignant fibrous histiocytoma in this particular region. Most common malignancies is very strange. It's a squamous cell carcinoma. Then there are cases reported osteosarcoma. There is a reported cases of Ewing sarcoma, and there are metastatic tumors. So we will go through all of these, and at the end, I will show a few cases that we did for the last few months. If we talk about the chondrosarcoma, which is the most common primary malignant tumor of the hand, and it can arise from the pre-existing enchondroma, which is benign, which Dr. Mumtaz just showed us a few cases. The most important is sometimes it's very difficult to differentiate between enchondroma and a low-grade chondrosarcoma in hand, and we have to correlate clinically and then radiologically to make assumption that what it could be, and if it depends pain, whether there is a fracture or not, and whether there is a recurrence or not, and then we can correlate all of these clinical and radiological findings, and then obviously with the biopsy as well. But the problem with low-grade malignancy, especially the chondroid tumors, is even sometimes on the biopsy it's difficult to differentiate whether it's a low-grade or it's a benign. Radiographs will show lytic expansile lesions, mostly is in the phalanx or in the metacarpals. There can be extension into the soft tissues. Majority, they are low-grade, and metastasis is very rare, especially with the low-grade malignancies, which is a low-grade chondrosarcoma or enchondroma. The treatment, it can be curettage or it can be wide resection. It depends. So this, I was looking at the literature, and this was one of the papers that I found, is a wide resection really necessary in hand for the chondrosarcoma. So not many patients, they did 8 patients intralesional curettage, 5 patients wide resections, all were grade 1, and had a mean follow-up of 99 months. No patient had a relapse who underwent wide resection, who underwent curettage. 1 patient had a relapse after 18 months. And then at 18 months after the relapse on the biopsy, it was similar to the first one, which remained the low grade. And after that, he had another curettage. And after 9 months, again, there was a relapse. And then he had this resection. And then after that, there was fine. And none of the patient has been reported having mets with this low grade chondrosarcoma. So I think for the low-grade chondrosarcoma, maybe curettage still is a considerable option, but again, it's a clinical and radiological correlation along with the biopsy, and then we can plan accordingly. But the options we can go for the curettage, we can go for the resection. It just depends on how the situation is. There are few cases, reported of the osteosarcoma as well, which is very rare, and mostly is being reported age above 50 years, lytic or mixed pattern on the X-ray. Treatment is the wide resection. Chemotherapy should be or should not, and then the prognosis. So I was again looking at the literature, and there was one of these experience shared. It's quite old, but I could not find any up-to-date paper on this osteosarcoma. There were 39 patients, low grade had only resection. So the low grade only had resection, and high grade had a resection and chemotherapy. And then they had a mean overall survival rate of 88% in patients treated by wide or radical tumor resection, and was 75% in patients with a non-wide margin of resection. So again, the one of the main the difference was whether we were able to achieve wide resection or not. 6 patients died, 8 patients have metastasis, 4 died due to the tumor, and 2 died due to the complications of the chemotherapy. There are metastatic tumors are reported in this particular region, which is rare, about 0.1% of all metastatic lesions. When we see the metastasis in the hand and forearm, mostly the disease is already widespread. So we most of the time we know what the exact diagnosis is. Malignancies from bronchogenic carcinoma, carcinoma of the kidney, prostate gland, breast, uterus, and colon can metastasize to this region as well. Sometimes it's been confused with the infection because there is a tenderness, redness, swelling. So the differential always will be gout, joint cell tumor, enchondroma, aneurysmal bone cyst. And if we know the malignancy anywhere else, obviously we will think of having the mets. Prognosis is poor. Then there are soft tissue sarcomas. I think next talk will cover about most of the soft tissue sarcomas. The most of the time in this particular region, soft tissue sarcomas are painless mass, and they are there for some time. And if there is a recent growth, that should be taken up and should be investigated further. Most of the time, the malignancies in this region, either they have been misdiagnosed as infection, as a ganglion, or as a lipoma. And if anything on the indeterminate on the MRI scan, I think it should be investigated with either the biopsy. If it's a small, it should be excisional biopsy. Soft tissue sarcomas are reported: malignant fibrous histiocytoma, liposarcoma, leiomyosarcoma, synovial sarcoma, rhabdomyosarcoma, epithelioid sarcoma. Epithelioid sarcoma and the rhabdomyosarcoma, sometimes they erode the bone as well, and they look like the tumor is coming from the bone. And then again, the treatment is resection, chemotherapy or radiotherapy. It depends which type of tumor it is and what is the biological behavior. This was one of the paper, is a combined limb sparing surgery and radiation therapy to treat sarcomas of the hand and feet. Basically, it's a soft tissue sarcomas of the distal extremities, and on the hand, they included about 35 cases. And with this 5-year local control was 86%, overall survival was 89%, and disease-specific survival was 89%. By combining conservation surgery with the limb salvage surgery and a radiotherapy. Again, there is not much data available in this particular region, and it's difficult to say how much it would be to have this multimodality. But again, if we conclude at the end, the main treatment will remain the wide margin resection. Then there are a few carcinomas reported: squamous cell carcinoma, basal cell carcinoma, malignant melanoma in the hand, and squamous cell carcinoma, which is most common overall malignancy in the hand. And we recently come across a patient where the patient has a squamous cell carcinoma of the little finger, had amputation, had the axillary lymph nodes, had a radiotherapy for the axillary lymph nodes, and after a few years he presented with a fungating tumor in the axilla, which was basically a radiation-induced secondary sarcoma, and had a 4-quarter amputation. So things can go on and on. This was one of our case. Ewing sarcoma is this was a 17-year-old child who came to us with a swelling and pain in the forearm, and he came actually in December last year. And if you look at the proximal ulna, whole of the proximal ulna is involved, and there was a quite huge extraosseous soft tissue component. And at the initial presentation, we had a discussion of having the amputation, and then he had neoadjuvant chemotherapy. There was a very good response, and after that, he had a preoperative radiotherapy to the forearm. As you can see, it was about 16 centimeter. Approximately about 20 millimeter was spare on the olecranon side, and distally 80 millimeter was spare. And we resected it after neoadjuvant chemo and radiotherapy, and is being reconstructed with the bone after extracorporeal radiotherapy, and fixed with the fixed back. Wound healed well, is being protected with the plaster afterwards, and he's doing well at the moment. No infection, fortunately. This is another case of, if you look at the proximal ulna, there is an erosion in the bone. He had a 6 months history of pain and swelling in the proximal forearm. Did the biopsy, and it came out as an epithelioid sarcoma. If you can look at the MRI scan as well, and it's just eroding into the ulna. It was also about 6 centimeter extension, and is being excised along with bone, and then is being reconstructed with a vascularized fibular graft. This was already known malignancy of metastatic renal carcinoma, had a nephrectomy, had lung mets, came to us with a pain in the forearm, and had the MRI, actually got the pathological fracture due to this metastatic renal cell carcinoma. Not a very good prognosis, already had the lung mets, so we did the curettage and cementation, and then fixed it with a plate. We did it under tourniquet. We haven't done any embolization, and we know for the renal mets, they are notorious for bleeding, very highly vascular, and we had the same. Once we released the tourniquet, even after putting the cement, there was quite profuse bleeding, and we lost about 700 mils. But at the end, we packed it, and we able to secure the hemostasis. This is another patient of the wrist and hand, 1 year history, again, very slow growth. Patient late presentation, did the biopsy, and turned out to be epithelioid sarcoma. He's a 72 years old man, and then had quite a lot of discussion about saving the one or two fingers and making it a pincer mechanism with a plastic input, or the amputation. And at the end, the patient choice was transradial amputation. So we did the transradial amputation for this patient. And as we know, even if we in the epithelioid sarcoma, if there is a marginal resection, there is a very, very high risk of recurrence. So the challenges in this particular area are there's a little soft tissue, narrow compartments, very close proximity of the structures, and all of these anatomical constraints, they pose a challenge to achieve wide margin, and reconstruction along with preservation of function is challenging in the hand and in the forearm. Surgical margins should never be compromised to preserve function. And then it depends on the tumor biological behavior. It's a high grade or it's a low grade. How the local spread is, and how is it a metastatic or not, and what will be the response to the chemotherapy and radiotherapy, and all of these factors we have to put together to make an opinion and what would be the best possible solution at that particular situation. And again, it's always a MDT decision, and I think from where we can after discussion we can get something which is more favorable. And then the reconstruction options, which is always challenging. And I think next there are two talks which will be talking about the soft tissue sarcomas and the reconstructions in this particular area. Thank you. If there is any question, I'm happy to take.
Okay, thank you very much, Dr. Jahangir. Can you okay. So we will take the questions. You have aroused a lot of interest amongst the panelists for discussion. And I can see Dr. Athar on the screen, which is nice. So hello there.
Assalamu alaikum. I do apologize. Complete miscalculation and time conversion, which should not have happened from the host. But actually, you do continue as you were hosting, and then I can take it on from the next session.
Okay. So the next talk is really interesting, for which Dr. Jahangir already placed few hints. It's about soft tissue sarcomas in upper limbs and role of orthoplastics. And we are honored to invite Dr. Harun Rashid, who's Associate Professor of Orthopaedics with special interest in hand and upper limb surgery at Aga Khan University Hospital. So over to you, sir.
Assalamu alaikum, and thank you very much, Dr. Aisha, Dr. Masood, Dr. I think you people are unprecedented pandemic.
So there is some disturbance in the noise. If you're using some microphone or something like that, maybe you can disconnect it.
I think the speaker on your device is not working. So you might want to speak directly to the computer microphone.
Okay, assalamu alaikum.
Ji,
so are you hearing me now?
Ji, sir, very clear.
But now I don't hear. Hello.
Yes, we can hear you loud and clear.
Okay, so I'm sorry, I am not yet over this technology, though conducting webinars for the last 1 year. So I would like to thank Dr. Aisha, Athar, Masood, and whole his team to collect people and continue teaching people in this very unprecedented area of pandemic. So let me introduce myself. I am an orthopedic surgeon not a plastic surgeon. So I would like to share my very preliminary work done in association with our tumor team, mainly consisting of Dr. Masood. So musculoskeletal sarcoma are a very challenging problem, particularly in upper extremity because of the availability of very little tissue around. But certainly, there is a lot of improvement in survival because of the improved surgical technique, development of referral center, and multidisciplinary approach. And we can see the development of tumor society in Pakistan, at least my generation has seen, from a very anecdotal tumor surgery to a very good team, which is generated by you people, and you people are now conveying this message to the rest of the orthopedic surgeons. So this was a pre-pandemic area. The tumor board, Athar may remember it, I guess. So I hope we are back to this type of tumor board discussion again. So if you have a good team, good association, you can venture some difficult targets. And this was, if I remember, a 5,000 meter high Burjila Pass. So coming to my presentation, to optimize the oncological outcome and maximal functional restoration, surgical resection, particularly by a person who is trained in this type of work, adjuvant chemotherapy, radiation therapy, wherever indicated, and then wide margin resection with a reasonable good reconstruction of soft tissue defects will produce a good result. And certainly, all your reconstruction or tumor excision will go wasted if you do not have adequate wound coverage and you cannot preserve function, particularly in the upper extremity, where amputation and prosthesis are not yet up to mark even today. Considering coverage or reconstruction, there are two types. One is immediate after excision, which usually we follow at our center, and then second is delayed reconstruction for some reason, like you are not sure about the margin of resection. So you can have some sort of temporary coverage and then followed by reconstruction. So this is actually a battle where the defect is produced by my oncological colleague, and then I have to behave like a RB to do some strategy and tactics, of course, with the available logistic support, and use an appropriate weapon to kill that. So, considering the reconstruction, historically, there were 2 to 3 major developments. One was a great advancement in anatomical knowledge, particularly about the microcirculation, which actually led to the advancement in free flap and microsurgery. And this advancement has also taken us back to some local coverage, because now we know the vascular supply more adequately. And of course, you will work when you have good technical support, and of course, some sort of magnification will always be required. So I'm sure all of you are aware of this ladder of reconstruction. Just to add few, like for temporary work, vacuum assisted closure, again, not closure, vacuum assisted dressing, again for a case where you're not sure about diagnosis, or you are waiting for your margin to be declared clear, so you can have this temporary type of setup. This was a case from my fellowship in Hong Kong. I have not seen it here. And this was a tumor excised by hand surgeon. And then somehow the pathologist was not comfortable to give her a clear margin. So some sort of this biological dressing was done. And then later on, we were able to cover this with simple skin grafting. This was our case long ago, a case of soft tissue sarcoma. I'm sorry, please apologize me if I don't remember the actual histopathology, but this was a high-grade sarcoma. So our weapon for reconstruction in upper extremity is, which is the workhorse for hand coverage, is posterior introitious flap. So other options are like radial artery flap or ulnar artery flap, but this, for me, it is difficult to harvest a flap utilizing the axial artery. So most of the time we end up using posterior introitious flap, which does not sacrifice your axial artery. And after tumor excision, which involved excision of the extensor tendon and periosteum on the dorsum of the metacarpal, we raised, this is the scheme of raising the posterior introitious flap. The flap was raised. The extensor tendon were reconstructed again using graft as a foretail. And then this coverage was obtained. And this is a follow-up with adequate wound healing and radiotherapy. And I hope, oh yeah, okay, this will run. So this is her, I think, reasonable function at some follow-up. Sorry for not having the pre-operative picture. This was a malignant melanoma excision done by our tumor colleague, Dr. Masood Umar. And I think this is checking of the elbow lymph node with some device. And then again, we utilized the posterior introitious flap to cover this defect, which was tunneled through the skin from the dorsum of the forearm. So another way to reconstruct the upper extremity is to utilize osteocutaneous free vascularized fibular flap. There are perforator which originate from the peroneal artery and reach the skin just posterior to the fibula, and they reach the skin in the posterolateral intermuscular septum. So you can have a piece of skin along with the bone to reconstruct your upper extremity. Again, a very advanced case of a 50-year-old male, I think about 12, 13 years back. So involved resection of the tumor, I think 2/3 of the radius and most of the extensor tendonal, extensor muscles on the dorsum of the hand. So reconstruction utilizing the skin along with vascularized fibula and immediate tendon transfer as one stage. This is follow-up X-ray sent from somewhere in the Gulf by the patient. I do not know he followed with Dr. Masood, but he never followed up with me. And this is his photograph sent to him from Gulf. So this is a case of, if I remember, again, apologize me, I think this was a Ewing sarcoma, excising almost whole of the length of the humerus, and then reconstructed with the non-vascularized as well as vascularized fibula. There was a very little bone available distally as well as proximally for achieving a good stable osteosynthesis. And then both hand at proximal as well as distal, she ended up in non-union. And then later on, reconstruction for this non-union was done utilizing this long Philos plate. She has grown up now. She's covering her face. So this is very, very little hand function she has, though good sensation, but motor function is not that good, but she's happy with it. And she can raise her shoulder up to 90 degrees. I tried to reconstruct her biceps utilizing the latissimus dorsi transfer, did not work. So that is how she's now. So whenever amputation is not an easy option and sometimes leaves a very huge defect, particularly for the proximal tumor, like this. So one can utilize something known as spare part surgery. Please do not get annoyed with utilizing this term. This is a standard term used in literature. So case of malignant mesenchymal neoplasm, resection 4-quarter amputation was done for this case, and this was his distal part. So we used the tourniquet so that we do not have the spread of tumor distally, and then we sort of fillet the whole forearm and utilized the skin based on brachial artery anastomosed with the axillary artery to cover this huge defect. This is known as spare part surgery, and this is his follow-up after wound healing. I think this was first tumor course at Aga Khan University. So my whole work association for tumor is with these two persons. And this is, I think, first tumor course at our university. Thank you very much for your attention.
Thank you very much, sir. And this was really exciting and some very unique stuff, especially the spare part surgery. I had never heard of this term, and this is really exciting and great results, mashallah. So with this, we move on to our next talk, and I request the participants to kindly use the chat box to post their questions. So our next talk is on giant cells tumor of the wrist, and I'm going to invite Dr. Zishan Khan. He is consultant orthopedic surgeon at Hyderabad Medical Complex, Peshawar, and let's hear from him.
Thank you very much. I hope all of you can see my screen and hear me as well.
Yes, we can see this.
Okay, so I've been delegated the responsibility of talking about giant cell tumors of the distal radius, and mainly to talk about surgical options for reconstruction. So just briefly, it's a benign locally aggressive lesion of the bone. Most common in long bones, but it can present in flat bones as well. The commonest age for presentation is around 20 to 40 years. However, we do see them in the whole spectrum of ages as well. The main dilemma with giant cell tumors is a very high rate of local recurrence, and the reported incidence in the literature is up to about 70%. It is one of the two benign bone tumors where they do have a tendency to metastasize to the lungs along with chondroblastoma, but mostly in the recurrent cases, and the quoted incidence in the literature is around 2%. So usually, radiologically, they are expensile lytic lesions, mostly eccentric and juxtaarticular. However, we have seen them in the diaphysis as well. The workup is the same as for all musculoskeletal oncology lesions. You do start with local staging, and if needed, you do systemic staging. However, for the purpose of distal radius GCTs, a plain radiograph is almost always diagnostic. However, just continuing on the discussion part where we were having that chat, I always do a biopsy for GCTs. I never just go and curate them straight away. We have 3 cases in my short experience of working in Pakistan where we had primary malignant GCTs when we biopsied them. So I always biopsy them. In the recurrent cases, I always get a chest X-ray, and if there's any doubt, I do a CT chest. We always get a serum calcium level, and if it is elevated, we arrange for PTH level just to make sure that we're not missing a Brown's tumor. Acid phosphatase, unfortunately, isn't available in many labs. When we were training as house officers, it used to be available at the time. It has been proposed as one of the tumor markers for predicting local recurrence in a couple of papers that I came across, but unfortunately, low lab in Pakistan, at least the ones I've contacted, who are doing it now. But certainly something to ponder upon as a research project for future, and always a biopsy as discussed. This I find is the best tool and most commonly one used for grading these tumors, and it is not basically histological grading, it is a radiological grading, the Campanacci system, so 1, 2, and 3. Coming straight to what we enjoy the most, the surgical options. Our aim as oncology surgeons almost always is to try and clear the tumor as much as possible in giant cell tumor, do a bone preservation surgery, and aim for good functional outcome. However, this is associated with a high risk of local recurrence. And mostly this decision is based on the grade of the tumor. So for grade 1 and 2, it's a no-brainer. We almost always do a curettage. For grade 3, I think it's a personal variation, experience, and a discussion with the patient where you discuss with them the options of curettage with a slightly higher risk of local recurrence or a wide local excision with a lower risk of local recurrence, but at the cost of function. So what is intralesional curettage? Actually, we never use the word intralesional curettage. We do a detailed intralesional curettage where we aim for as near complete removal of the tumor as possible without any major morbidity. There are various adjuvants that have been proposed in the literature, and almost all of us who do oncology regularly will use a 1 or 2 or a few of the combinations. However, when you look at the literature, there's no independent evidence or data to suggest that one works better than the other. This is briefly what I do now. Mind you, I very rarely get to see a grade 1 or 2 GCT. I don't know where they go. So the picture that you're seeing on the right side is probably one of the 4 or 5 grade 2 or 3 GCTs that I've seen. So planning is paramount in any oncological procedure, and in my planning, I make sure that I have the tools that I need for my detailed intralesional curettage. So I make sure I have different sizes, different angle, and different shaped curettes. I make sure I have a high speed burr. My preference for adjuvant is a hydrogen peroxide because it's cheap and easily available. And the other or the last sort of adjuvant that I use is an electrocautery. So the cycle continues until we have 2 consecutive cycles where we don't get any more lesional tissue. In the case on the right side where you see that there was a collapse of the cortical bone. So in order to maintain the radial height or radial length, I had to use an intramedullary plate to make sure that we do not go into an ulnar positive variance. Just briefly on denosumab, I know we're not going to go into the remits of this because it's a big topic and we don't want to delve into that. But however, the role of denosumab continues to evolve along with some evidence with the use of zoledronic acid as well. When do I use it? Just briefly, I only use it when I am planning a wide local excision. So I don't use it for curettage, because there is some evidence that when it is used when a curettage is performed after denosumab, the risk of recurrence is high, not because of the denosumab, but because some of the stromal cells might escape the curettage. I use them when I'm planning wide local excision, so that automatically means the larger grade 3 lesions, and when the disease is not measurable or in pathological fractures. So when does it become big, or when do I decide that I need to go for a wide local excision? So it is cases like these where you can hardly see the distal radius. And what are our aims for resection and reconstruction in these is to do a complete excision of the tumor and then reconstruct the defect somehow that causes minimal morbidity to the patient, maximal restoration of the function, and leading to low complications. But most importantly, whatever form of reconstruction we do should be acceptable to the patient and the family. And more often than not, as Dr. Haroon said, that teamwork is dreamwork. And in these cases, I'll show you some where I have to regularly liaise with my plastic and microvascular surgery colleague for vascularized work or microvascular work. So the options for reconstruction, they are mainly either biological or non-biological, and whatever form of reconstruction we do, we have to decide whether we are going to do an arthrodesis at the wrist or an arthroplasty type reconstruction. So the options available are the autografts and allografts. Autograft, mainly the fibula can be vascularized or non-vascularized. Now the plastic surgery colleagues usually say that any fibula or any bone which is longer than 5 or 6 centimeters. If it's non-vascularized, it does not work. However, that probably isn't true in its practical sense. We have had cases where we've used longer than 8 centimeter non-vascularized grafts and they do work. But yes, given the option and acceptable, I would always prefer a vascularized graft. An ulnar centralization or a translocation, an iliac crest or a tibia crest graft are also options. Allografts, mainly osteoarticular. And when we talk about non-biological, we talk about endoprosthesis. So the challenges that we face around this difficult area are because of the patient expectations and demands are increased, which is why there are various options for reconstruction being explored and mentioned in the literature, and all of them have their own benefits and disadvantages. Arthrodesis generally provides us with a stable wrist, but at the expense of movements, whereas arthroplasty allows you that movement, but the main complication with that is instability. And if you use an osteoarticular graft, at 7 to 10 years, almost all of them will undergo degeneration, ultimately requiring an arthrodesis. So this is one such case of mine, probably the first GCT that I did when I came back to Pakistan. This was a patient where he had a third recurrence of his GCT. So he's had both his diaphyseal fibulae used, and at this time, this was the third operation where he had the fibula head taken out and an arthroplasty type reconstruction used. But if you look at the lateral view, you can see a big soft tissue elevation. And we did a biopsy and it confirmed that this was GCT. So because this was immeasurable disease, I offered this patient denosumab, and you can see very nicely around my cursor that the tumor was calcified and we could see and resect. Now, because we were running out of options and this patient didn't want me to take any more graft from his body because the poor soul had almost both his fibulae taken out, we decided to do an ulnar centralization, and along with that, we did an abdominal flap. And he is now almost 5.5 years down the line with no further local recurrence. An ulnar translocation is another option. This is where after resection of your distal radius, you do a resection of the ulna just about a centimeter half longer than your resection, along with the muscles, making sure you do not detach the periosteum or the muscles because they are the bits that supply blood to that part, and then you switch it over and fuse it to the remnant of the distal radius and perform an arthrodesis at the wrist. The basic advantage of this is that it acts as a vascularized graft, and in comparison to an ulnar centralization, you have a preserved proximal radio-ulnar joint allowing you rotation at the forearm. Now, my indications for doing ulnar translocation are in the younger dominant patients and where they have high demands. So in a non-dominant hand and where the demands are not high, I would prefer to do an ulnar centralization, which is slightly less technically demanding. So in cases like these, which we saw earlier, large GCT following denosumab, you can see that the tumor has consolidated, making resection for us easy with the disease being measurable. And as this was the non-dominant hand and low demand patient, we did an ulnar centralization with an arthrodesis of the wrist. However, at 6 months follow-up, I had a breakage of the implant. As we all orthopedic surgeons do, I blamed the implant, but instead the fusion had not taken place. So I put in a tricortical iliac crest graft and did a revision fixation with a recon plate. It healed nicely, but during my practice, I then saw that there were 3 other patients where 3 recon plate failures further happened. But mind you, these were the cases where the fusion had taken place. So since then, I've stopped using recon plates, and I now use small DCP plates. One can also use a tricortical iliac crest graft. The morbidity with this is slightly less than the fibula, as we know that the fibula autograft is associated with common peroneal nerve injury. But these defects can only be reconstructed with an iliac crest graft if the lesion or if the defect is not bigger than 5 centimeters, because the curve is too big around the iliac crest to reconstruct that. Endoprosthesis, they are used. They can either be in the form of an arthroplasty or an arthrodesis. I've only assisted in a couple of them. When you look at the literature, you don't find any large case series. We've written up one. It's in the process of being published soon, and we wrote about 8 cases, and the morbidity associated with them is quite high. And it is mainly because the soft tissue cover around the wrist is very poor, which is why it leads to soft tissue failure and wound infections. However, mind you, this is not a new technique. It was first described in literature in 1957. And when you search, you'll find that there are many case reports rather than big case series for this. So something obviously worth exploring, and the excitement is mainly because it does not involve any morbidity of the donor site. Now, just briefly discussing about arthrodesis versus arthroplasty. As we discussed, arthroplasty offers you better function as it allows you some rotation at the wrist. But the issues with that are subluxation. However, arthrodesis is a more robust reconstruction, but at the expenditure of movements. I've not personally seen or done this kind of a fusion, but I read this in an article where a compromise may be a mid-carpal fusion, where you fuse your graft with the lunate and the scaphoid and leave the mid-carpal row free, which will allow some movement at the wrist. However, to my gray matter, I cannot understand how much of a stability will you be able to achieve with this fixation. So in conclusion, the distal radius offers a reconstructive challenge to all of us. Biological reconstruction with arthrodesis is the mostly described technique in the literature, as it is more stable and more robust. When you review the literature, it tells us that all these techniques have some limitations and their own inherent complications. However, they are best dealt with by surgeons who are well versed with all these techniques, because if one fails, then they know what to do with the next. If anyone is interested, we wrote a review article on these reconstruction techniques some time ago, along with one of my colleagues from Tata Memorial in India. It is freely available. Thank you.
Thank you very much, Dr. Zishan. That was quite a detailed insight into GCTs. Just quickly before we move on to the next talk, I have this question. Since you've seen a lot of aggressive GCTs, where do you find it necessary to screen for METs? Have you ever seen METs in your cases?
I've yet to see one, but as I alluded to in my talk, in my recurrent GCTs, I always get a chest X-ray. I make sure. But having said that, for our anesthetic workup, all these patients, when you operate on them, they do get a chest X-ray anyways. I've yet to see one personally in Pakistan. I do remember seeing one when I was doing my fellowship in Birmingham. And mind you, whenever they metastasize, they still remain benign. The question is, how do you treat them? If they are in one side and there are not more than 2, you can resect them. There are some series where they've been followed up for a very long time and they've still remained benign. But even for a recurrent GCT, when it has recurred, and even if I've operated on it, it comes back, I still biopsy them. I have one case where it was operated on in another hospital and it recurred within 6 months. We did a repeat biopsy and it turned out to be a malignant GCT. So I always biopsy them. That's my take on musculoskeletal oncology.
Okay, so thank you very much. And with this, we move on to the next talk.
Comment.
Yes,
to add a comment. I know EPR is one of the topics for forearm reconstruction. So whatever reconstruction we've done, I know you've spoken about your work at Birmingham and the paper that's published. I think we did about 4 forearm EPRs in the last year and a half here in Oxford, and all of them have failed. So I think forearm is just one place where EPRs don't work. So people come in, they want to try new things. These were custom EPRs. They're all custom EPRs. And then for one reason or the other, they loosen, they don't give function, or they get infected. So I've seen so many problems with VPR that I think other solutions for reconstructive fibrillas or ulnar transplantation probably the way to go.
Professor Masood Umar has a comment, I believe.
Yeah, Dr. Zishan, thank you very much for this elaborate talk. As you yourself said, the incidence of a GCT of distal radius being malignant is very low. But obviously, nothing can be said as of being 100% or 0%. But what is the role, as in my practice, there's a huge role of frozen section. And obviously that has to be backed by a very expert pathologist. And if I have a reliable pathologist and I have a benign appearing radiology X-ray of the distal radius, and I do a frozen section and my pathologist says it looks benign, there is no features of mitosis or an aplasia or any abnormal cells, then I go ahead and do a curettage right there and then. What are your comments on that? Thank you.
Thank you, Dr. Masood. Yes, I agree with facilities on board. You can do that. However, I took a leaf from your book. I used to do all biopsies under general anesthesia. So I got some courage and I started doing them under local anesthetic. And now all my residents do them on the same day when we see them. I am yet to gather that much courage. Mostly because my pathologist is your pathologist and he sits around 1,340 something kilometers away from me. So I don't have that luxury, number one. Number two, with experience, I've had a few shocks just in the last couple of years. I'll give you one example. We had a patient where there was a lesion in a younger patient in a distal tibia. And that distal tibia lesion was very clearly and obviously looking like a bone infarct with some hemorrhagic changes. However, I discussed this with my radiologist and they said we should biopsy it. I did one biopsy and it came out inconclusive, discussed it with our combined pathologist, Dr. Nasser, and he said, I'm not happy with the radiology, either the pathology. So let's do a detailed curettage. And to my surprise, this was a telangiectatic osteosarcoma within a bone infarct. Now, it's never been reported in the literature. So incidences like these teach me that I only get one chance at these because you don't want to spoil it. So I err on the side of precaution. However, having said that, if you have the facility on board like you have, yes, there is a good argument to be made for that.
Okay, so thank you very much. We move to our next talk, which is on amputation versus reconstruction in malignant hand tumors. And I will request Brigadier Khalid Masood, who is in charge of hand upper limb surgery at CMH Lahore, to kindly share his experience with us.
I think Dr. Badr wants to make a comment also.
Okay.
Hello. Hello.
Ji, Dr. Badr.
जी sir. Dr. Khalid.
I think it's Dr. Khalid.
Yeah.
Okay.
Can you hear me?
Yes, sir, we can hear you. We can take Dr. Badr's comment later. So we can proceed with Khalid Saab's talk right now, I think.
Ji, Assalamu alaikum.
Can
you hear me?
Yes, sir, we can hear you. We can see your screen also.
Okay. Thank you very much. I am thankful to Dr. Masood Umar, who took me on board for this very important topic. And I can see General Suhail Hafiz, my teacher here, my salam to him. Sir, assalamu alaikum. Very happy to see you here. And salam to other my colleagues. So, as far as amputation or reconstruction is concerned in malignant hand tumor resections, it is very tricky because you all know that the hand is a complex structure. There is a very few soft tissue here, and almost every malignant tumor has engaged the neurovascular bundle. So it is always tricky that where you have to, you are going to amputate and where you are going to save the hand. As far as malignant tumors are concerned, these are very rare and can be missed as well. But the treatment and prognosis are related to the factors. These are depend upon the location, size, histological grade, and expansion. Expansion is basically the invasion of the tissue, and it can be mild, it can be aggressive. Generally, the malignant tumors of the hand, which we come across here in our practice, these are related to skin, soft tissue, bone, and cartilage. And skin tumors are generally squamous cell carcinoma, BCC, and melanoma. Soft tissue are already mentioned in my previous talk, and mostly the bone and cartilage are the osteosarcoma and chondrosarcoma. The objective of surgery in hand are basically three. Number one is the complete excision of the tumor. Number two, reconstruction of the defect. And number three, the most important, is the leaving behind a functional hand. So there is an evaluation protocol. One must keep in mind when you are going to manage these aggressive sort of or any malignant sort of tumor in your practice. Detailed clinical history and physical examination is very important. Then after having the routine laboratory examination, the imaging examination should include CT scan and MRI, and if needed, bone scan as well. And when someone is confused that whether it is a cystic or solid mass, then the ultrasound can help. Then the tissue biopsy, as already mentioned, it is very, 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 very important. However, it depends upon the expertise which are available with you. One can diagnose the case with fine needle biopsy, bone needle biopsy, open biopsy, and after that, one can need the chest CT scan for the final assessment of the metastasis. Staging is very important. So MSTS system, it grades lesions according to expansion, whether these lesions are intra-compartmental or extra-compartmental. And then second is the histological grades, whether these lesions are of low grade or high grade, and then the distant metastasis. The anatomical spaces, which are called compartments, may extend from beyond their boundaries, for example, into the wrist or into the forearm, because there are the tendons who may provide them the roots. From there, they can come from the hand into the forearm. So for clarity, a lesion in the hand and wrist may only be considered intracompartmental if it is superficial to the deep fascia, like it should be subcutaneous, or it is confined to a single digital ray,
Here the concept of compartment is very important. A compartment may be the bone itself in case of bone or cartilage tumor, or it could be the facial compartment in soft tissue tumors. However, one should keep in mind that compartments are not so easy to define the hand. So these are basically the grading, and generally the 1A, 1B, and 2A and can easily be radically excised, and one have to see for the 2B and 2B what should be going, but it is not very important, and these are the staging. The important is the size or location. Many a times a tumor of the small size but residing at a very tricky place can change your decision. So regarding definitive surgical measurement, there is a general plan of tumor excision in hand. The surgeon should be able to understand the biological behavior, pattern of local and metastatic spread in response to radiochemotherapy. And the margins of the excised tumor should be adequate and it should be clear. And amputation must be avoided if possible in hand. Unnecessary sacrifice of tissue is also must be avoided. Then the definitive diagnosis must be made before excision. Careful plan must be made and discussed with the patient. And compartmental resection or radical excision cannot be always applied to hand. These things should be kept in mind. Like this case, basal cell carcinoma, simple answer is amputation, but it can be avoided with the excision and the reconstruction. Squamous cell carcinoma of the index back of the index finger can easily be excised and managed. Subungual melanoma can be excised and covered with the local flap. Then there are certain principles that are according to the specific sites. Like if the tumor is residing in the distal phalanx. If the tumor is interosseous, then it can be amputated. Proximal to the joint, at the joint or proximal to the joint. Preferably, we should cross the joint and should be proximal to the joint. And if the lesion is residing in dorsal area, it should be excised with the volar flap. And if it is placed on the palmar area, it can be excised with the dorsal flap. And if the place of the tumor is at the middle phalanx, then the ray amputation or ray resection is the answer. One should not try reconstruction or local resection here in such cases, like these cases. And if the lesion is placed, soft tissue tumor in the metacarpophalangeal joint area, then again the answer is amputation. And amputation should pass the joint, it should be through the metacarpal. Here the importance is that one should try to save the CMC joint, carpometacarpal joint, for future toe transfer to regain the function. Like this is one example, and excision and with flap coverage of the area. So if the lesion is placed at the ulnar border, like fifth ray, again the answer is amputation. The ray plus soft tissue coverage. It should be removed and the soft tissue coverage should be performed like this. This squamous cell carcinoma involving the bone as well, going very deep inside. The ray amputation, and this is the dorsal area, and it covered with the local flap. And if it is placed in a place that it can involve the second finger as well, and the lesion is larger in size, that may require the amputation of the both fingers, like this. This is an example. A soft tissue tumor residing between two fingers, like this. And here it has involved the fourth metacarpal. So fourth metacarpal was removed along with the metacarpal of the middle finger as well. So middle finger's distal part was left behind, but the fourth metacarpal of both finger, fourth and middle finger, were removed. So the middle finger metacarpal was reconstructed with a bone graft and small finger plate. And then the location is present between the first and second metacarpal. The answer is amputation of both the rays. There should not be made any attempt to do a radical excision of the tumor and leaving behind a functionless hand, like this. So if the tumor is present between the second and third metacarpal, then again the answer is excision of both rays. This is example, tumor between the second and third. And these are the marking of the marking for the excision, volar side and dorsal side, incision and excision of the tumor with the clear margin, this excision and the reconstruction. So still the patient have very nicely functioning hand. Similarly, another example, like a soft tissue tumor between the third and fourth, second and third metacarpal. And you can see that although the tumor is small in size, but because of this pressure, the second and the third metacarpal, they have, with pressure, we have been lost their actual structure. So the needle biopsy turned out to be fibroma. But when we went inside, it looked like that it is probably not the benign lesion. So we took it as malignant lesion. So the whole area was cleared, and the tumor, along with the common digital vessels and common digital nerve, it was excised and immediately sent for sent in pathology for frozen section. So it was turned out malignant tumor, fibrosarcoma, but luckily the margins were clear. So we kept it as here, but we regained restored the neurological and the vascular deficiency here in this case. And if the tumors are lying in the volar area here, in the wrist area, in the volar side or in the dorsal side, it is too large in size on the radial side, mostly such tumors need below elbow amputation. So this is the answer for such tumors. Like but sometimes if this is the surgeon's decision whether he can excise the tumor or he can leave it as such. Like this synovial sarcoma, so we manage, this is the excision margin, and it was excised whole, almost the dorsal compartment gone with this patient. But at the same time, the free muscular transfer was performed along with the tendon transfer, and it was closed. It was quite functional hand. So prognosis for the local recurrence, it includes the grading of the tumor first. That includes the histopathological type, that is very much most important, and then the vascularity and necrosis, then the histopathological grading as well. Then one must keep in mind the staging, that is basically the dimension and site, and then the treatment. And the treatment must include the clear margin of the excision with or without adjutant treatment. And generally, these are best done with the multidisciplinary approach. Thank you very much.
Thank you very much, Dr. Khalid. It was really very interesting talk, and we were introduced to a very nice new concepts. So I believe we can move on to the cases. I will share first. So you have to unshare your screen so I can share the first case, which was sent by Dr. Mumtaz. So it is consistent with the discussion earlier we were having in the chat box. Okay, so this is the case. I will request Dr. Mumtaz to unmute himself as well and walk us through the case.
Yes. Can you hear me?
Yes, sir.
A 6-year-old female presented with a lesion in his second metacarpal. This is her first radiograph at presentation. This initially we done a biopsy, and that turned out to be a enchondroma. After confirming biopsy, we took interpositional graft by taking the fibula, and we put it there and fix it with K wires. And after probably almost 2 or 3 months, this was the second radiograph that we took it, and after this, for 4 to 5 months of surgery, that radiograph, that which is the third one, that turned out to be, you can see the almost all bone is resolved along with the soft tissue mapping. One thing I forgot, when we applied this fibular graft, we took the material and sent it for histopathology, and that turned out to be a with the malignant transformation, and their histopathologist said there is the sarcomatous changes. He is not confirmed that what say actually, but he said that there is a malignant suspicion and all these things. Not confirmed that this is chondrosarcoma or what else, but taking history and all this, he just said that there are sarcomatous changes. This is her current picture, and now query is what to do, amputation or salvage. My impression was that I think we should go for amputation. It's open for panelists.
Okay, so we request the faculty, the panelists to kindly comment. Maybe Dr. Khalid to begin with. Since we just heard a talk from him regarding salvage or amputation for sarcomas of the hand. So this is a young girl, 6-year-old, and she had a recurrence with the sarcomatous change. And as you've seen, the fibula is eaten away almost. So what do you think, sir?
आई थिंक मैं एग्री करूंगा इनके साथ, डॉक्टर मुमताज़ के साथ, जब ये हो गई है, इसकी दोबारा रेकरेंस हो गई है, तो आई थिंक दैट शी इज़ चाइल्ड है, तो वन शुड गो टुवर्ड्स सेफ साइड एंड वी should go for amputation in such cases. And with the passage of time, such children are very much able to adopt themselves to do the daily activities with the prosthesis. However, one can work for this patient, that how maximum tissue we can हम कितना बचा सकते हैं ये टिश्यू जो है, ये बेसिकली डिपेंड करता है
sir.
जी
Level, sir, what should be the level of amputation? Can we save any digit?
मैं बात कर रहा हूँ कि जी इसमें हमें देखना है कि जी दूसरी डिजिट्स हम कितनी बचा सकते हैं, तो जितनी मैक्सिमम हम बचा सकते हैं हमें उस तरफ जाना चाहिए. इसमें अगेन इफ़ यू हैव द फैसिलिटी ऑफ फ्रोजन सेक्शन, तो दैट विल बी द वेरी एक्सीलेंट सपोर्ट टू यू, कि फ्रोजन सेक्शन की हेल्प के साथ हम इस काबिल होंगे कि हम मैक्सिमम जो है वो टिश्यू जो है वो बचा सकें. However, अगर नहीं है तो फिर भी अपने हिसाब से क्लियर मार्जिन लेके इसमें वन कैन गो फॉर सेकंड स्टेज सर्जरी, अगर आपके पास आपके पास अगर नहीं है जो है फैसिलिटी उसकी फ्रोजन सेक्शन की, तो उसमें ये है कि जी आप उसके बाद भी आप उसको ज़हन में रख सकते हैं 2 स्टेज प्रोसीजर के तौर पर भी, लेकिन मैक्सिमम जितना हो सके इसमें टिश्यू जो है वो बचाना चाहिए, और बट नॉट एट द कॉस्ट ऑफ टिश्यू बिहाइंड. तो फिर लेटर ऑन देयर आर लॉट ऑफ ऑप्शंस जिसके साथ हम इसको रिकंस्ट्रक्ट कर सकते हैं. उसमें अगर एक भी डिजिट बच जाती है वो हमारे लिए एडवांटेजेस है.
May I say something here?
Sir.
देखिए, जो मार्जिन की डेफिनेशन है वो सबसे पहले आप क्लियर कर लें कि व्हाट इज अ क्लियर मार्जिन. To my mind, the margin is the next natural barrier to the growth of the disease. For example, a periosteum and even the metacarpal or a epimysium or a nerve sheath, the definite margin to which resists growth of the disease. जब आपको ये क्लियर हो जाएगा कि आपने कौन सा मार्जिन निकालना है और कौन सा छोड़ना है, तो फिर आपकी सर्जरी थोड़ी सी जरा आसान हो जाती है. In this particular case, if you look carefully, removal of metacarpal does not mean removal of digit as well. For example, in this index finger definitely has to go, but if we remove the third metacarpal, it's not necessary to remove the third digit, that is the index finger, the middle. So if you can reconstruct, you can remove the third metacarpal, reconstruct the third metacarpal, and you could still have 3 digits with you. So this is as a principle, what I'm saying is removing a particular tumor does not mean removing the whole digit. You can still save the digit provided the nerve and vessel spared. So I would rather remove the, in this particular case, I would take out the index finger, maybe part of the periosteum of the first phalanx. I may take out the third metacarpal, but try to reconstruct the third metacarpal now, maybe by vascularized fibula or any other graft. And then, so we will have 3 ulnar digits and a thumb with us, which would be a functional hand. This is how I look at things. Zishana, what do you say to that?
Zishan has got a question.
I agree to all your comments, sir, Dr. Suhail, about margins. I mean, it's an anatomical barrier. It's not about how many centimeters or how many millimeters. So agreed with all of that in totality. However, my reservation slightly is on the initial radiograph. So the screen that Dr. Mumtaz has shared, the first X-ray on the left, it's very uncommon. We all know, but we know that nothing is uncommon in MSK oncology. To have a chondrosarcoma in such a young patient, particularly in enchondroma. Having said that, if we closely look at the plain radiograph, that doesn't look very typical of an enchondroma or a grade 1 chondrosarcoma like we were discussing earlier. So my concern is whether this was actually an enchondroma from the very beginning. Is there a point in revisiting that histology report, the first one that was issued? This to me doesn't look like a grade 1 chondrosarcoma. This was something else from the very beginning. So if it was me, Dr. Mumtaz, I would get those blocks and get them revisited and reviewed in light of your newer histology report with a frank malignancy. Because I think this was a malignant lesion from the very beginning, not a grade 1 chondrosarcoma.
I think Dr. Zishan, Dr. Mumtaz has clarified that the actual resection specimen did show sarcomatous change. So I think it is a case of the first biopsy not being reported right, and possibly this was a malignant change. Now the discussion is obviously
But I think it was never a chondroid lesion. That is my comment. This is my feeling.
And interestingly, we had this discussion. Is this an isolated lesion or are there other lesions in the body? Because we know that sarcomatous change in chondromas are associated with certain syndromes such as Ollius disease. So does the patient have any evidence of Ollius disease? Plus, we've not spoken about the metastatic workup so far, I think.
At the moment, it's a localized tumor. Actually, I want to clarity. Dr. Zishan is very right. In the first radiograph, it seems that it's something wrong with extra compartmental, or the soft tissue involvement is there. But when the biopsy turned out to be enchondroma, and that was an open biopsy was done. That was not a needle. So probably we have what I should say, but due to a report of histopathology, we were brave enough to go and treat it as a benign tumor. So, but then second biopsy, it turned out to be sarcomatous changes. They do not confirm whether this is a chondrosarcoma or what is this, but they just said that there are sarcomatous changes. And then
Dr. Haroon has a question, I think, sir. He wants to add something. Ji, sir.
Okay, thank you, Aisha. It will be very hard for me to comment on tumor and resection. So Professor Suhail has quite nicely elaborated. So my opinion is, even if you can salvage one digit here, and then reconstruction of a digit placed at the site of thumb, like transfer from toe, so that can greatly help in achieving useful function. So in hand, I think even if resection leaves a part of digit, of any of the digit, then rest of the digit or more than one digit can be reconstructed. And if you resect more than one metacarpal, 2 or 3, then perhaps osteocutaneous iliac crest graft is useful to reconstruct all the metacarpal as a single bone block. Skin is there, and you need to reconstruct then nerves and vessel by grafting. So in hand, I think, please don't feel offended. So resection is not like that of other part of the body. So here I would agree that doing a less than aggressive resection would leave a great place to reconstruct rest of the part. Thank you.
Can I request to keep looking at the cross-sectional imaging for the sake of discussion for the participants? It is probably more useful to see the cross-sectional imaging rather than the radiographs here.
Dr. Athar, your voice is a bit cloudy, maybe because of the headphones again.
Is it better now?
Yeah, it's far better now.
It's probably because of the dusky weather in the West Midlands.
Yeah.
It just started having dawn now. Anyway, so I was just making a comment that we should probably be looking at the cross-sectional imaging while having this discussion for the sake of participants, rather than the radiographs. So if you can, I think there was a slide with cross-sectional imaging.
Yeah, I'll move to that slide.
Yeah, I think for the sake of participants, we might want to sort of arbitrarily show what we mean by barriers to tumor spread, which is a great turning point from sessions like this to people who do not practice oncology regularly. If one of the faculty can mark it.
Actually, I'm sharing it, so I believe I'm the only one. So anyone who wants to dictate, I will do that for them with a marker.
I mean,
So
this is
maybe
just for sake of planning. Actual resection will be intra-op decision.
Exactly.
But this is just for planning that what can be saved and what cannot be saved.
Okay, let's ask Dr. Khalid. So, Dr. Khalid,
metacarpal of the thumb have a hemicortical resection? Just for the sake of discussion, if I raise this question, can the metacarpal of the thumb have a hemicortical resection and you can save the rest of the ray?
ये एक्सरे पे वापस जाएं, एक्सरे पे वापस जाएं, मैं वहां पे बात करता
जी सर।
अच्छा, जैसे कि मैंने अपनी प्रेजेंटेशन में बात की ना कि अगर तो मैलिग्नेंट ट्यूमर बिटवीन 2 फिंगर्स यहाँ पे ये आ जाता है मेटाकार्पल लेवल पे, तो इट इज बेटर कि जी हम पूरी रे को जो है वो एम्पुटेट कर दें. सो टू बी ऑन सेफ साइड, इट इज नॉट इन फेवर ऑफ दिस पेशेंट कि जी हम थंब को और ये इंडेक्स को हम इसको बचा लें. इन माय ओपिनियन ये थंब की रे और इंडेक्स की रे ये तो इसके साथ जानी ही चाहिए. अब ये जो हमारी थर्ड फिंगर है, थर्ड फिंगर की जो मेटाकार्पल है, ठीक है, मेरे ओपिनियन के मुताबिक जैसे कि प्रोफेसर सुहेल हफीज ने कहा है कि ये भी जानी चाहिए ये साथ. अब ये डिपेंड करता है कि अगर हम उसी वक्त हमारे पास फ्रोजन सेक्शन की फैसिलिटी अवेलेबल है कि अगर ये सारा सेक्शन हम निकाल लेते हैं और हमें ये क्लियर दे देता है तो वी कैन लीव इट हियर, और फिर ये जो थर्ड जो मेटाकार्पल हमने रिमूव किया है इसको हम उसी वक्त जो है वो बोन ग्राफ्ट के साथ फिबुला या जो भी है हम आइलिया क्रेस्ट जो भी लेके उसके साथ हम उसी वक्त इसको मैनेज कर रहे हैं. यस यस, ये बिल्कुल बिल्कुल आपने ठीक कहा.
May I like to add here? देखिए, the periosteum of the third metacarpal, let us suppose the tumor is close to it. So if you remove the periosteum, the radial periosteum of third metacarpal, and if in doubt, hemicorticotomy, you remove the radial half of the cortex of the metacarpal and third metacarpal, and similarly on the thumb side, if you remove the periosteum of the first metacarpal, and if required, if you think that is closed by frozen section, if you remove the ulnar cortex of the first metacarpal, you can still save it. So the important thing is you must be able to establish where the lesion has finished. If it is superficial to the periosteum, you remove the periosteum and then you're done. If you think the periosteum is involved, you can remove the hemicortex as well. So in hand, I'm not the best person to comment on hand, but my feeling is as much saving even a small digit. If you save one digit, it is functionally better than an amputation. So I would suggest that a frozen section availability, removal of the periosteum, and maybe half of the cortex of the third metacarpal, that is radial, and half of the cortex on the ulnar side of the first metacarpal may do the trick in saving the thumb, and the third, that is the middle finger.
ये जहाँ तक सर बोन का ताल्लुक है, मैं आई टोटली एग्री विद यू, लेकिन ये है कि जब भी सॉफ्ट टिश्यू सार्कोमा, और उसकी टीचिंग और लिटरेचर भी यही है कि जब इस प्लेस पे 2 डिजिट्स के दरमियान में मौजूद होता है, देयर आर चांसेस कि जी सेल्स ऑफ द मैलिग्नेंट सेल्स दे फॉलो थ्रू दी टेंडन शीथ जो है उसके थ्रू फॉलो कर जाते हैं। तो उसमें रिकमेंडेशन यही है कि जी अगर बेस पे मेटाकार्पल लेवल पे हमारा सॉफ्ट टिश्यू सार्कोमा है तो फुल डिजिट शुड बी excised. So
yes, I agree with you. What you are saying is a longitudinal spread.
Yes, sir. मैं longitudinal spread.
Horizontal spread. So longitudinal spread तो समझ में आता है, but not the horizontal spread. So we can see the third or fourth or fifth metacarpal. ये नहीं कि हम पूरा का पूरा हैंड एम्पुटेट करने की कोशिश करें.
Not at all. वही मैं बात कर रहा हूँ कि ये जो हमारी जो मेरे ख्याल में ये थंब पूरा और ये इंडेक्स फिंगर, दिस ऑल शुड बी एक्साइज्ड विद दिस ट्यूमर, और बाकी रह गया पीछे थर्ड मेटाकार्पल उसकी पेरियोस्टियम की बजाय द होल शुड बी रिमूव, क्योंकि हमारे पास उसकी रिकंस्ट्रक्शन की ऑप्शन मौजूद हैं, वी हैव गुड ऑप्शन। तो जब हमारे पास रिकंस्ट्रक्शन की अच्छी ऑप्शन मौजूद हैं तो मेरा ख्याल है कि वी शुड नॉट बी स्टे देयर ऑन ए रिस्की साइड, वी शुड नॉट टेक द रिस्क जो कि बाद में ये हो। बाकी ये है कि जी अगर हमारे पास फ्रोजन सेक्शन की फैसिलिटी मौजूद है तो देन डेफिनेटली हम मिनिमम डैमेज और मिनिमम सेक्रीफाइस ऑफ द टिश्यू हम कर सकते हैं with very taking the safe side of the clear margin। और ये जो बाकी हैंड में जैसे कि ये बात की गई है कि जी हमारा बिल्कुल हम विद द क्लोज मार्जिन वी कैन टेक द रिसेक्शन ऑफ द ट्यूमर, जितना कि हम उसको क्लोजली ले सकें उसको हम ले सकते हैं, वी कैन गो फॉर दैट उसमें, बट सब्जेक्ट टू कि हमारे पास फ्रोजन सेक्शन की फैसिलिटी अवेलेबल है। ठीक है, सिर्फ हम विजुलाइज तरीके से कि जी ये इट लुक्स लाइक कि ये यहाँ पे हमें लगता है ऐसे है कि जी ये इसने इन्वॉल्व नहीं किया हुआ, तो सिर्फ सिंपल विजुअल इफेक्ट पे हमने नहीं जाना, उसके लिए फिर हमें हमें थोड़ा सा सेफ साइड पे रहना होगा।
Thank you very much for the nice input, sir. I think yeah. So we can we move on to the next case, because we are also taking some time from the break.
I mean, we have to meet up on the break.
Sorry, I can't hear. So we can just quickly do this case sent by Dr. Jahangir. So Dr. Jahangir can kindly walk us through your case.
Yeah, so it came for a couple of weeks, but she's a 72 years old female who presented with a pain and swelling in the left forearm for the last 2 months. She does not have any fever, no trauma. Otherwise, she is fit and well. There is no other known malignancy in terms of thinking of any mets. She had a swelling left proximal forearm on examination. Skin is normal, no signs of infection. Musculars was intact. She had marked restriction range of motion of especially the supination and pronation, and there is some restriction in the flexion as well. As you can see on the X-ray, again, optimal radius reaching up to this subarticular set on the radial head side. And if you move, if you look at the AP and lateral view, there is more in the cortex all around. And if you can move to the next slide, where we have the MRI scan. So coronal, sagittal, axial, all within the bone, no extra osseous soft tissue. So the questions here are, what could be the differential?
Okay, so let's ask the attendees and one volunteer over here who can give you differential. Any of the attendees, kindly please raise your hand and then we will unmute you and you can talk directly to Dr. Jahangir and you can tell us what are the possible differentials for this lesion. Yeah, there are no hand raises. So probably we can engage the faculty with the differentials.
Jahangir, can you go back to the imaging?
Okay.
I think of my
One of the participants has raised their hand, I think Naveed.
Yeah, so let's unmute him and
Saad, can you please unmute Naveed? Saad, are you here? Can you please unmute Naveed?
Yes, I can hear you.
Can you please unmute Naveed, Saad? One of the attendees. Yeah, Naveed
Yes,
Katana is here.
granted.
Naveed, can you unmute yourself?
Yeah, I did.
okay,
No,
welcome.
Naveed is here, the panelist. Naveed, can you please unmute yourself and then you can talk?
Dr. Naveed, can you hear us?
So I don't know what's happened to him. Okay,
I think we
Aisha, if
shall
you want to
continue.
continue. Aisha, do you want to continue with asking the faculty?
Yeah, I
Not
think,
there.
yeah, we are not getting them on the page. So I will give my first differential, Dr. Jahangir. I think this can be chondrosarcoma. And
so I mean, so by at age, she's 62 of it. And on the X-ray and on the MRI scan, we haven't seen any chondroid metrics. So this is very unlikely to be a chondrosarcoma. The difficult that we're thinking, and this was discussed within us, this might be a chondromyxoid fibroma, or because she is 72 years, so the most common malignancy is the multiple myeloma, and it can be a plasmacytoma, which is the isolated of the it's like a isolated, we call it a plasmacytoma. This can be a plasmoma, this can be chondromyxoid fibroma, this can be like a fibrous dysplasia, but again, she's 72 years old. So our first differential here was, and
what about
either the
metastasis?
chondroid or the metastasis. You're right. She doesn't have any other known malignancy, but still, the first MET scan presentation, you are right. So the plan basically to have all the blood and proceed biopsy We haven't got all the bloods yet, but biopsy's been done and it's came out as plasmacytoma, isolated plasmacytoma. So next question is how to proceed further.
Okay, so I will request Professor Masood over what he thinks about this. Now this is a biopsy proven plasmacytoma. Am I right?
Yeah.
Yeah. So the question is how to go about it.
Plasmacytoma, solitary variant of melanoma. If it is excisable, this is an expandable bone proximal radius. You can excise it. If it is in a non-excisable site, can very well be treated by radiotherapy. It is a radiosensitive tumor, and here the only problem would be functional loss of the posterior interosseous nerve and the loss of extension of the digits and the thumb. So that has to be taken into counseling with the patient, and for that a simple tendon transfer procedure can be done concurrently. So that would be my kind of choices. So surgery versus radiotherapy, primary radiotherapy, but more opting, since it is an expandable bone, more opting towards a surgical option with simultaneous reconstruction. Thank you.
Yes, sir. So
I want to comment, please.
Yes, please.
Yeah. I think plasmacytoma is isolated multiple myeloma. It's form of isolated multiple myeloma. And it's almost 1-2% of all the multiple myelomas can present in isolated lesion. We have seen ileum plasmacytomas only involving the iliac blade, not the systemic involvement. So key is to again do all the work for multiple myeloma, though it's confirmed. Surgery is expendable just to do excision only. That's enough. Per 72 years female must undergo chemotherapy for multiple myeloma and treatment related to the multiple myeloma. That's an idea to treat isolated plasmacytoma. Resect and treat the way multiple myeloma are treated in the chemotherapy. So this is.
Thank you very much, Dr. Badr and Dr. Masood. The MSK oncology is one of the where it's difficult to make any plan from one person. So it's where the role of MDT discussion is, where there is a radiologist, the pathologist, and there is an oncologist as well. So talking about this isolated plasmacytoma, I was reading about it, and it's very interesting to know. This can be, there are soft tissue isolated plasmacytoma also have been reported with extraskeletal manifestation, and there are isolated osseous lesions also have been reported, like a plasmacytoma. With a plasmacytoma, there is about 15 to 20% chances of converting into a multiple myeloma. If you have diagnosed isolated plasmacytoma, I think after all of the blood workup, it's reasonable to do a bone marrow biopsy as well. That's what we call bone marrow occult disease. And if it came out to be in a bone marrow as well, then it should be treated as a multiple myeloma. And if it's not, then it should be treated as, then it does not need any chemotherapy, and it should be treated as an isolated lesion. The next option, either to do surgical resection or the radiotherapy, as said by Dr. Masood Umar, I think the decision is not be from one person. It's a MDT discussion. And at the end, we had options for discussion with our patient. It's going to be a combined decision. As Dr. Masood rightly said, if we go for the resection, there is going to be a considerable risk which is involved with the resection. Is that patient is going to take that risk? Where there is another option of radiotherapy, which is equally good and quite less frequent after the radiotherapy has been reported with isolated plasmacytoma. So I think the purpose of putting this case here was basically to enlighten again this fact that there is no straightforward decision in MSK oncology, and the MDT discussion, and at the end, the patient who is undergoing this should know what the options are, or the pros and cons, and then the next decision can be made. Any other comment from, I think Dr. Zishan is want to make a comment.
Dr. Zishan has made a lot of comments in the chat box.
Just to complement what Dr. Musumar said and what all of you said, is that this is a hematological disorder, a hematological malignancy. So we already know that this is a systemic disease. So we should not be treating it as like a sarcoma, although whenever we plan a resection, we aim for complete resection. So the most important person in this, apart from the MDT, is the patient herself, I think, female, yes. So she should be consulted and her symptoms should be kept in mind. If the symptoms aren't that bad, so the medical management along with local radiotherapy would be the preferable option. But if symptoms are quite bad in term, and what I expect that they will be when she rotates her forearm, then we should aim for resection. But during the resection, like I alluded to, as it's a hematological, i.e. a systemic disease already, the important neurovascular structures must be preserved in order to limit our morbidity. That would be my take on it. So what we should not forget is the patient and as to what she wants. We know that in a 72 years old with a hematological malignancy, even with multiple myeloma, in the best of instances, the survivorship isn't that great. At 5 to 7 years, it's probably around 50 to 70%. So not that big. So we need to limit our surgical intervention in this case, keeping in view her symptoms. That would be my way of progressing.
So if I can make a comment, mostly to agree with what Zishan has said, what we do is, here it would be discussed in actually two MDTs. One, if it comes to the sarcoma MDT, then it has to go to the hematology MDT. And obviously that workup of getting a bone marrow biopsy and then deciding on to medical management, the role of the hematologists and the MDT. Obviously, local treatment has to depend. So very rightly said, it's a systemic disease which we cannot treat by local treatment. So the treatment of the disease itself is systemic, which is led on by the hematologists. The local treatment, be it in the form of surgery or radiotherapy. Radiotherapy will be for pain management mainly, and for controlling further progression of the lesion, to my mind. And then surgery will be done for symptoms. So if the symptoms are mechanical, which could be problems with pronation, supination, then they will have to be managed with resection, whether it's complete or. But usually you can see that after radiotherapy, these lesions do consolidate quite a bit, and it's much easier to resect plasmacytomas, which is commonly seen in pelvic plasmacytomas, which are, at least in my practice, I've seen more pelvic plasmacytomas than forearm or other site plasmacytomas.
Okay, so thank you very much for the active participation. With this, we come to an end to our first session, which was on general principles of extremity tumors. And thank you very much to Dr. Attar and Dr. Masood Umar for this opportunity to interact with such an amazing faculty. And we had some really interesting discussions and mind-boggling kind of case discussions. So over to Dr. Attar to move on to the next session. Thank you very much.
Okay, is everybody in for a 5-minute break, or should we continue going? I'm asking the faculty because the participants are
not a bad idea, 5-minute break.
Okay. Let's take a 5-minute break because it will help you regain your concentration. So we will reconvene another 5 minutes. Keep logged in so that you don't waste time for logging in again, especially for the participants. Panelists will be here. So we are back online. We'll be starting soon. We are waiting for Dr. Mohsen Azam, who is here. Just waiting for him to be put on the panelist panel. So we'll start off with his work in this second session. Saad, can I ask you to get Dr. Mohsen Azam to become one of the panelists, please?
Athar, your voice is breaking up.
Is it better now?
Yeah, that's good.
So Saad, Dr. Mohsen Azam is here. Can you make him a panelist, please, so that he can share his screen and start the talk? Saad apparently is on some other call. I'll give him a couple of minutes if he does not respond, as I do not have the controls. So we'll probably have to go to the next speaker while this issue is sorted.
Just called him. He's on another phone, I think.
Yeah, I've been calling him as well. He's on another call. So I think we should just proceed with the session, and so let me introduce. This session is about resections, reconstructions around the humerus and the proximal humerus. So we will be talking on the most common site that most of us do our upper limb oncological procedures is around the shoulder. We've spoken a lot of, we've shown you a lot of cases around the hand and the forearm, and now we'll talk about the a bit further up, which is accessible to most surgeons rather than microvascular surgeons as well. So obviously there are a number of methods of reconstructions for the proximal humerus and resections as well. We will skip the first talk as the speaker is waiting in the waiting area to be admitted to the panelists. So we will continue with the following talk, which is...
Wait, Athar, he's online. Saad, can you hear me?
Saad, are you here?
No.
Yeah, Dr. Mohsen is now online, I can see.
Yeah, I'm here. Okay.
Mohsen, so we are ready for you. So Dr. Mohsen will be starting with the first talk of the session, which is proximal humerus tumor resections with EPR reconstructions. Dr. Mohsen is a very dear friend of mine who has now departed and works in Dubai. Very experienced oncology surgeon. He had his oncology fellowship in Rizzoli and thereafter worked in Karachi for quite some time and was a joy to work with. Good to see you, Dr. Mohsen. Without a lot of your time, I'll let you crack on.
Okay, thank you very much, Athar, for the introduction. Of course, we've been friends for the longest. More than that. So thank you for having me here. I'll be presenting on proximal humerus resection and endoprosthetic reconstruction. Since I'm the first one, I took the liberty of going over some theoretical things before we proceed. So as an introduction, so just a sec. So so the upper limb extremity is involved by bone and soft tissue neoplasm, 1/3 as often as lower extremity. So most of us are operating on lower extremity tumors most of the time. The scapula and the proximal humerus are common sites for primary sarcomas, including osteosarcoma, Ewing sarcoma in children, and chondrosarcoma in adults. Soft tissue tumors and some metastatic lesions have propensity for proximal humerus in the shoulder girdle. Historical background: until the mid-20th century, 4/4 amputation was the treatment for malignant tumors of the shoulder girdle. Today, approximately 95% of these patients can have limb salvage and limb-sparing resections. Tikoff-Lindbergh resection and its modifications are limb-sparing surgical options for tumors in this location. The relationship of neurovascular bundle to the tumor and other structures of the shoulder girdle is the most significant anatomical factor which determines the resectability. Continuing, some of the earliest discussion concerning limb-sparing surgery focused on techniques for resection of the tumors above the scapula. So most of the shoulder girdle surgeries were initially on scapula. First reported scapular resection was in 1819 by Liston for an ossified aneurysmal tumor. Between this time and the mid-1960s, several other authors discussed limb-sparing resections above the shoulder girdle. 1965, Pepino and Francis reported about 26 scapulectomies and discussed the indications and limitations of the procedure. The Tikoff-Lindbergh interscapular thoracic resection or triple bone resection was described by Baumann in 1914 in the Russian literature. The shoulder was suspended from the remaining clavicle by metal sutures. Tikoff and Baumann performed 3 such operations between 1908 and 1913. Tikoff was named as the originator of the procedure, and then this was popularized in Western literature after 1926 when Lindbergh published about this. Classically, most shoulder girdle resections were done for low-grade tumors of the scapula and for periscapular soft tissue sarcomas. Like I said, after 1980s, osteosarcoma, Ewing sarcoma of the proximal humerus became most common tumors treated by this kind of resection. A variety of new techniques and modifications of the shoulder girdle resection have been developed since. Most of them are called Tikoff-Lindbergh or modified Tikoff-Lindbergh, but this eponym basically is not fully explanatory on what kind of resection is done. So the classification of such resection was presented by Malauer in 1991. It is based on current concepts of surgical margins, the relationship of the tumor to the anatomic compartments, intercompartmental versus extracompartmental, the status of the glenohumeral joint, the magnitude of the involved surgical procedure, and precise considerations of the functionally important soft tissue components. Here is the diagram of the Malauer classification. So basically, type 1 is intra-articular proximal humerus resection. Type 2 is partial scapular resection. Type 3, intra-articular total scapulectomy. Type 4, the extra-articular total scapulectomy and humeral head resection, the classic Tikoff-Lindbergh resection. Type 5 is the extra-articular humeral and glenoid resection. And type 6 is extra-articular humeral and total scapular resection. I will limit myself to the type 1 and type 5 as that's the main topic of my talk. So each type of these resections are also divided in subtypes A and B, depending on if the deltoid and the rotator cuff muscles are preserved or lost. So loss of any component of the abductor muscle, creates a similar functional disability of the shoulder. So abductor mechanism is almost always resected when an extraosseous extension of the tumor is present in this area. So I will go in further details of the type 1 resection. This is the least frequently performed because whenever we find a tumor, they're usually in this area extraosseous, and you need to do an extra-articular resection. Still, we'll discuss about this. It's performed for some low-grade tumors, rarely for high-grade tumors, like I just said. Metastatic. Sorry. Okay, so metastatic disease of the proximal humerus without extensive destruction of the bone or a pathological fracture can also be treated with type 1 resection. Resection is performed using an endoprosthetic or local muscle transfers. A Gore-Tex graft reconstruction of the glenohumeral capsule may be required following a type 1 resection, even when normal soft tissues are retained to provide stability. In the type 5 resection, this is the most common procedure, which is performed for the high-grade sarcomas of the proximal humerus. It involves extra-articular en bloc resection of the proximal humerus, distal clavicle, glenohumeral joint. The scapular resection is performed through the scapular neck, just medial to the coracoid. In newer modifications, it is also done at the lateral to the coracoid, just taking the neck of the scapula. So the axillary nerve and the shoulder abductors are routinely sacrificed because of the extraosseous extension of the tumor in this kind of resection. Resection of the osseous defect is performed. Reconstruction of the osseous defect is performed by modular proximal humeral endoprosthesis in conjunction with dual suspension technique, which I will just describe in a bit. This is combined with multiple muscle transfers to reconstruct all the soft tissue that has been resected. This is the MSTS classification for resection. We describe them as the parts that are being resected. So we can go S2, S3, S4, or S5 for similar resections. So after the Malabar classification, Weinstein and Conrad classified just the proximal humerus resections. So type 1 is a short proximal humerus, type 2 is a longer proximal humerus, type 3 is a extra-articular, like type 5 on the Malabar classification, and type 4 is with partial scapulectomy. So goals of any resection in this area has three components. So surgical resection of the tumor following oncological principles, of course, to resect all the tumor, reconstruction of the skeletal defect with an endoprosthetic prosthetic replacement or other methods, soft tissue reconstruction using multiple muscle transfers to cover the skeletal reconstruction and provide functional extremity. The goal of the shoulder girdle reconstruction is to provide stable shoulder and to preserve normal elbow and hand function. The extent of tumor resection and remaining motor groups available for reconstruction actually dictate the degree of the shoulder motion and function that follows. In this area, reconstructive options can be osteoarticular allografts, allograft prosthesis composites. Endoprosthetic reconstruction can comprise of hemiarthroplasty, anatomical modular megaprosthesis, or reverse shoulder arthroplasty, which has been popularized lately. So other proximal humerus reconstruction options include clavicular prohumeral, in which the clavicles disconnected from its medial joint and then suspended on the acromioclavicular joint, and then it is fused with the remaining humerus. And the other choice is glenohumeral arthrodesis. So we'll restrict to the endoprosthetic reconstruction. This kind of a surgery was developed in lower limbs in the 1940s, just because more tumors were for lower limbs, and also there was more research and development in that area because of its weight-bearing nature. So use of the technique was gradually broadened to include defects of the upper extremity and shoulder girdle. Markov and Francis performed some of the first resection of the high-grade sarcomas in this location in the late 1960s and 70s. During 1980, all prosthetic replacements were custom-made for each patient. In 1988, a modular replacement system, MRS, which obvious need for custom devices was developed by Howe Medica. So from the initial design, MRS has undergone several changes and improvements since time. Now it's a completely modular system. MRS is used in conjunction with both intra and extra articular resection, and results are highly predictable and successful over time. So reported rates of fracture, infection, non-union, reoperation, tumor recurrence are lower, and time for immobilization is shorter with endoprosthetic reconstruction as compared to allograft, composite reconstruction, or arthrodesis. Survival of the MRS humeral prosthesis is reported to be 95% at 10 years in different centers. Preoperative considerations in such surgery. Orthopedic oncology patients have several specific characteristics that affect the choice of surgical reconstruction. Consideration for potential for shortened survival, particularly in patients with diffuse metastatic disease, myeloma, and some primary bone tumors should be made. So patients often need surgical solution that allows for immediate stability to allow for restoration, especially when they have poor prognosis. So concomitant effects of radiotherapy, chemotherapy, including high risk for scarring, wound healing problems, infection, have to be considered. As far as surgical technique is concerned, for any planned proximal humerus resection or reconstruction, planned length of resection should be measured preoperatively. Advanced imaging and preservation of soft tissue that can be repaired during the reconstruction should be accomplished during the resection. Deltoid insertion should be spared if possible. Glenohumeral capsule and respective tendon stumps should be tagged with sutures for later identification and reattachment. These structures are useful in achieving joint stability by attaching soft tissue attachments to the endoprosthesis. After measuring the resected specimen, the defect is reconstructed by combining modular humeral head, body, shaft, endoprosthesis, as it was shown for the MRS, for optimal soft tissue tensioning to get the best amount of function that you can get. So if adequate distal function is not achieved, with uncemented intermedullary system, you can use cemented system. Soft tissue repair to endoprosthesis can utilize attachment of soft tissue to the holes of the endoprosthesis with non-absorbable sutures. Soft tissue repair can be augmented with synthetic mesh or a tube over the endoprosthesis, so the soft tissue can be sutured to it. Endoprosthetic reconstruction following tumor section entails following steps: fixation of the endoprosthesis to the remaining distal humerus, fixation and stabilization of the prosthetic humeral head to the scapula, providing stable shoulder joint. Soft tissue reconstruction to completely cover the prosthesis to optimize postoperative function and wound closure. A dual suspension technique was described by Malavar. In this, it's used to create shoulder stability with the anatomic kind of prosthesis. So the drill holes are made around the glenoid, and Dacron tape is passed in two different ways. So head of the prosthesis is secured by 3 millimeter Dacron tape. So prosthesis is suspended mediolaterally. For horizontal stability, the sutures are placed horizontal, and then it is suspended using additional Dacron tape from craniocaudal direction to provide vertical stability. Dynamic suspension is provided by transfer of the short head of biceps to the coracoid, and this can aid in the elbow flexion. This is a diagram of the dual suspension technique. You can see Dacron tapes in horizontal and vertical fashion, which can be tied to the proximal part of the prosthesis to provide this kind of stability. Soft tissue reconstruction, remaining muscle groups are tenodees to the pectoralis major and to the osteomized border of the scapula with similar Dacron tape. This mechanism offers dynamic support, assists in suspension of the prosthesis, and provides soft tissue coverage. So soft tissue coverage is essential to cover prosthesis and prevent skin problems and secondary infections. Rehab in such patients begins preoperatively, when you can discuss with them what to expect functionally and cosmetically. Afterwards, a sling is applied in the operating room to restrict the motion. Edema is controlled by elevation, compression, wrap, and stocking. In immediate postoperative period, the patient is instructed on motion exercises for wrist and hand. Elbow flexion is encouraged within the confines of the sling. Neck motion and shoulder elevation exercises are started as early as possible. Once the incision is healed and removed 2 to 4 weeks after surgery, shoulder exercises, elbow extension is begun. Pendulum exercises, gentle shoulder motion, flexion, extension, internal and external rotation are done with the help of family members and physical therapists. Elbow flexion, extension, supination, pronation are performed. The sling is removed for therapy, but subsequently reapplied to keep the shoulder stable till the strength is improved. Gentle strengthening is instructed once the motion is returned. The use of active motion and isometric exercise with lightweight can be done. So I think my text color is gone. So basically, functional outcome with the the functional outcome with anatomic EPR, usually the mean anterior flexion is about 45 degrees plus minus 4.15 degree, then 41.33 degrees of posterior extension. The most importantly, abduction is around 42.17 degrees. And we can do this one. Sorry for this change in color, maybe at the last moment has messed this one. So anyway, this compared to the newer thing, which is the reverse shoulder arthroplasty. Reverse shoulder arthroplasty, it provides an alternate and has been more popularized in the last 15 years. It is considered when rotator cuff is compromised or resected, so it provides better function associated with better actually with abduction. So mean active forward flexion is 96 degrees as compared to 45 with the anatomical one, and then active abduction is around mean of 88 degrees, range from 30 to 160 degrees, which provides much more functional ability in reverse shoulder arthroplasty than versus the anatomical megaprosthesis. Here's a short video about the insertion of a reverse shoulder arthroplasty. So you can see a tumor here. Is the audio of the video audible?
No.
Okay.
No.
So I
do you want to?
So I will go over it. So basically, the beginning showed the excision of the biopsy tract. and then the exposure of the proximal humerus. You measure the amount of tumor based on the MRI findings. In this case, an osteotomy is performed with a margin of 2 to 3 centimeters. So you can see this is the distal osteotomy. Then the soft tissue can be separated from the resection specimen slowly towards the joint. This is the subscapularis muscle being separated. So this is a video for an intra-articular resection. So you can see the joint capsule is open. Now, starting with the prosthesis, the glenoid is being prepared. So the glenoid implant is placed and secured with screws. Now we're having the reaming of the distal humerus. So okay, so the glenosphere is now being placed. So this is the distal part of the reverse shoulder. The joint is reduced and stability is being checked. So PET tube is being placed over the implant, and then the implant will be reduced again. And this is secured by non-absorbable sutures. This provides stability to the implant. Soft tissue is then reconstructed, and you can see on post-operative X-rays the presence of the implant of reverse shoulder. Okay, just in the end, to discuss the advantages and disadvantages of endoprosthetic reconstruction. So the advantage is modularity of the prosthesis, convertibility of the prosthesis. For example, if you're doing a hemi first, then it can be converted later on to a reverse shoulder. Immediate stability is provided by the presence of the endoprosthesis, because there's no fracture or any osteotomy to heal. Early range of motion and the functionality can be restored. Lower complication rates compared to the osteochondral allografts. There's no need for an allograft because of the modular prosthesis. There's good long-term survivability data available now. Good term functional outcomes as described before. So some disadvantages, especially with the hemiarthroplasty, proximal migration can occur. There's instability is a possibility. Aseptic loosening of any prosthesis has been known. So metal soft tissue attachments is always an issue. You can tie them up, but sometimes there's issue with the healing.
Dr. Mohsen, I think we have lost you. I think that was the end of the talk anyway. So yeah, very interesting talk by Dr. Mohsen on proximal humerus EPR reconstructions. He covered a lot of ground here, including the basics. We will let discussion roll on to the case-based debates, because there is a whole session on case-based debates on proximal humerus reconstruction. So we will, in the interest of time, because we're running over time, and I'm acutely aware of that, we'll continue with the next talk, which is talking about fusions around the shoulder after resection of the proximal humerus. And I would request Professor Brigadier General Retired Suhail Hafiz to share his screen and talk to us about his extensive experience in working around fusions of the shoulder using a free vascularized fibular transfer.
Can you see my screen?
Yes, we can see your screen.
Okay. Thank you very much, Athar and Professor Masood, for giving me time. I'll be speaking on the shoulder arthrodesis after resection of the proximal humerus type 1 by using the free vascularized fibula. That's where I've been working for most of my life, CMH on the top and Shifa down here. Just the principles for the younger lot, the management of malignant bone tumors, of course, diagnosis depends on history, physical examination, X-ray, MRI of chest, and a biopsy. Then we ultimately stage the disease, and it, needless to say, it has to be done in a multidisciplinary setting in which a radiotherapist, oncologist, plastic surgeon, radiologist are a very, very useful member of the team. And let me confess that I learned a lot from these meetings, which we have been continuing for the last 20, 25 years. Our results have improved not by our skills, but by the cooperation of the oncologists who have given us the wonderful drugs of to manage the osteosarcs, Ewing sarcomas in the by giving neoadjuvant and adjuvant chemotherapy. I would be restricting myself to the last bit, which is the reconstruction after resection, but I will be hinting on some of the subjects, that is limb salvage and the wide local excision. Now, before we embark upon trying to do a resection, one has to be very, very careful, and one has to be sure that he can actually remove all of the tumor. And if there is any doubt, one should think otherwise. So an experienced oncological surgeon starts whether he can do safely resect with clear margins. So oncological clearance is the first bit that you should be sure about before you embark upon the surgery. We talked about the compartment. Dr. Brigadier Khalid Masood talked that the compartment definition, of course, is not the anatomical compartment, but it is actually the next natural barrier to the growth of the disease. And if you can safely take out the next natural barrier, and probably the job is done, then the case is a salvage. Involvement of nerve and vessel, especially in the proximal humerus, I thought it to be an absolute contraindication, but no more. With the help of my plastic surgical colleagues, we have been able to perform limb salvage even when the vessels have been involved. And if one nerve can be preserved, we can actually attempt a salvage. After the resection, of course, a defect is created, and there are different ways of closing these defects. And in addition to closing these defects, you will have to have a soft tissue reconstruction, which could be primarily, or also trying to regain the function as a secondary procedure. For example, if you have to excise the radial nerve in the proximal humerus, then you might have to do a tendon transfers later on to get the function of the hands back. Just to highlight, in our setup, most of the time, the tumors that we see, it has grown so much in proportion that the rotator cuff is invariably involved. So we have to resect the rotator cuff. And most of the time, deltoid, either the whole of it or part of it, deltoid is gone. Axillary nerve, it is very difficult to say because most of the time it is involved. And the shoulder itself is an inherently unstable joint, as Dr. Mohsen pointed out. So one has to be careful while one is reconstructing. He has to be careful that he does not leave behind an unstable joint. Humerus, of course, has a very narrow cross section. Radial nerve, of course, it passes in the middle lower third of the humerus, and most of the time we are able to save it, but some of the time you have to resect it, and then you have to do secondary reconstruction. The most important point in reconstruction of the shoulder, I think, is the scapulothoracic movement. The talk that I'm giving, of course, is on the arthrodesis. I'll be able to highlight that this particular position, that the scapulothoracic movement, is very helpful in getting a useful function of the arm and the elbow and the hand, so that the patient is able to take the hand up to the mouth or behind the head as well. So this particular motion is very relevant while you decide the ultimate outcome of the procedure. I would not go into details of the excision itself. Of course, the incision is a quite big one, starting from the spine of the scapula, and it extends over the shoulder up and becomes the Henry shoulder strap. It may go down to the elbow joint. Deltoid rotator cuff I already highlighted. Lat, back and teres major, you have to resect at some level. Depending upon the extent of the lesion of the tumor, you might have to resect it more towards the chest rather than towards the to the humerus. Coracobrachialis and long head of biceps is always almost resected, but sometimes you're able to save the short head of the bicep. Axillary nerve, as I said, it is not salvageable most of the time. Radial nerve, we are able to save most of the time. Axillary artery and vein, one has to be careful about. Somebody said 2 to 3 centimeter. We take a margin of 5 centimeter from the distal margin of the tumor as measured on the MRI. And intraoperatively, we take a frozen section from the medullary canal of the distal humerus. And once we are sure, only then we proceed. There is one particular case which I'll show that we were doing a frozen section and we ultimately reached to the elbow and we had to replace the whole of the humerus because the Ewing sarcoma was involving even the capitulum and trochlea of the distal humerus. Now, this is what you are left with. If you notice here, there is only just the glenoid on the top with the capsule of the shoulder joint and distal, it's the lower third of the humerus. The limb is hanging just by the nerve and vessels. And if you notice, all of the deltoid is gone, the rotator cuff is gone, brachialis is gone, long and short head of biceps are gone. And here is a challenge to reconstruct not only the bony architecture, but also the soft tissue, which are very relevant in the ultimate function of this limb. The options of reconstructions could be biological, prosthetic, and combination. Let me assure you, none of them is perfect. All of them have their pros and cons. So choose the one which you think in your settings. I would rather go for a biological reconstruction. Allograft, we are not fortunate to have bone bank in our country. So if we have the biological options, we have other autograft, which could be a free vascularized fibula graft, which is the topic of my discussion. But of course, you can use a non-vascularized fibula as well, and a treated bone, which Sohito is going to talk about. Prosthesis are wonderful options available, and allograft prosthesis composite are also possible, but they have their own limitation. To my mind, the prosthetic reconstruction is okay, but in our country, there are 2-3 factors. Number one, you see these patients, some of these patients are very young. So if you try to put a prosthesis in a young patient, the long-term results, that is what will happen after 15 years, 20 years, definitely they would require a reoperation, which probably would be a major undertaking as a secondary procedure. Number two, most of our patients come to us very late, in which all the rotators and all the deltoid is gone. So probably we will have an unstable situation. Third, of course, is the cost. I just checked up the cost of the prosthesis for one of my patients, and it ranged from 5.5 lakh rupees to 15 lakh rupees. So to my mind, the use of a prosthesis is a very valid option. It should be used in an adult, in which you have the rotator cuff function, rotator cuff, and the part of the deltoid available. In addition, you must be able to cover the implant as well, and therefore probably rotating the lat would be a good option. This, of course, it could, as Mohsin, right, Dr. Mohsin just showed, it could either be just an endoprosthesis or it could be a composite APC. These are now getting out of vogue because the allograft acts more like a dead bone, and it takes a very, very long time to unite with the host bone. As I already said, that we need, in addition to the skeletal reconstruction, we also need to reconstruct the soft tissue. Once we have removed all the muscles, you need some soft tissue to cover your bone and also the metal work. Otherwise, they'll tend to cut out of the skin. You also need soft tissue for a lymphatic flow from the distal part of the limb towards the thorax. And of course, if the tumor is such that you need to give them adjuvant radiotherapy, you need to have a good skin and soft tissue, which should be able to resist the radiotherapy onslaught. Secondary surgery, I already alluded to. So my workhorse for the last, I would say 20 years or so is vascularized fibula. It has its advantages. It hypertrophies with time and is a long-lasting, is a permanent solution to a problem. But it has its difficulties. Ultimately, of course, it's a resection arthrodesis. You cannot preserve the head of the humerus in most of these situations. It takes a very long time to do the surgery, about 6 to 7 hours, because 2 surgeons are working. And if you are not taken a skin paddle, you would need a bone scan to establish the vascularity of your graft. Now, this is our friend Mamoon. Everybody knows he has been with me for good about 20, 25 years now. And he is now very good at it. He gives us the vascularized fibula within an hour. And we are able to, we have shortened our surgical time quite significantly in the last 5-10 years now. So the fibula comes with its vascular pedicle, and in this particular case, if you look carefully, it has got a skin paddle as well. Now, this was my initial surgeries in which we used to reconstruct arthrodesis with the help of 2 plates. One plate is on the top, it's a 3.5 millimeter recon plate, which is fixed to the spine of the scapula across the shoulder. Now I do the osteotomy of the acromion and sandwich the graft in between the acromion and the glenoid. And then the distal, there's a 3.5 millimeter DCP, which is fixing the fibula to the distal part. But now I tend to use a single plate, which starts from the spinal scapula down to the distal humerus. If for any reason you don't have to, you don't have a very long plate, then you can actually overlap 2 plates, which I'll show you in a while. This is how it looks like. Look at just notice the this is the acromion, and there's a lag screw going through the acromion, through the graft into the glenoid, and then of course this is the plate over it. This is how ultimately it looks like. This is the case which I was referring to. We started off removing upper third of the humerus. While we were taking the frozen section, we realized that it was going all the way to the elbow joint. So we actually removed the whole of the humerus and did a vascularized fibula, which is fixed from the spinal scapula to the ulna. So this patient had double arthrodesis of the shoulder and arthrodesis of the elbow. Okay, coming to whether it is worth it or not, what are the results? 2 things one must consider. It is either the graft survival and the patient survival. Some of the patients may have a recurrence of the disease, or they may have metastasis and may die because of the renal disease. But as an orthopedic surgeon, we have to be careful about the graft incorporation time and the complications of the procedures that we have embarked upon. I went through the literature regarding the arthrodesis results of the resection arthrodesis of the proximal humerus due to the using the vascularized or non-vascularized fibula. I was surprised that if you look carefully in different studies, the number of patients in each study is very less, primarily because this is uncommon. 21 patients here, 8 patients there, 9 patients here. The biggest article that I found was 39 patients. But again, this was not only the vascular fibula. This particular study, if you notice, it had 12 arthrodesis, 7 prosthetic reconstruction, and APCs as well. In all of these, this study and the study above, which was comparing arthroplasty with 7 claviculohumeral and arthrodesis, all of them showed that the arthrodesis did better. Again, mind you, the number of cases in all these studies are not very large, primarily because it's a rare disease. So when I studied the literature, I found that all these studies are very small number of cases in them. The MSTS scores and Toronto Extremity Salvage scores in all of them showed that the arthrodesis did better in the long term. And the range of motion, because of the scapulothoracic movement, was up to 80 degrees. To my mind, if your arthrodesis is successful, you get a very stable shoulder on which you can work on. But it has its complication. The graft fractures we have seen, non-union, mostly at the proximal end we have seen, and then it's a very flat shoulder, which may not be to the liking of some of the patients. I looked up at my study, which is starting June 2003 up till now. A total number of 38 resection arthrodesis we have done for different reasons: osteosarc, Ewing's, Conroe's, MFH, and giant cell tumors. That's the total number that we had in the last 17 or 18 years or so. The average length of free vascularized fibula that we used was from 7 to 21 centimeter, and 18 centimeter was the average. Time to union is a long one. It takes about 7 months. This was the average time. And the mean MSTS score was 23. Some of them did not do very well if you look at 8 and look at the 28 score as well. My results, we had 1 primary recurrence resulting in 4-quarter amputation, 2 pulmonary mets. The patient died because of this. But in addition, I had a 21% complication rate, which included superficial infection, deep infection, non-union oblique delayed union, and 2 fractures of the graft. Now I'm going to show you 1 or 2 cases just for illustration. I would have thought earlier on that this is non-salvageable, but we took up, this was a very young boy, I think 8 or 12 years old from Gilgit. This was post-neoadjuvant chemotherapy, post-restaged MRI. And this is what I was talking about. We have done an arthrodesis on the top. There are 2 plates. If you look, one is coming from the spine across the arthrodesis up to the vascularized fibula. And then if you notice, the second plate is overlapping the first plate, and then it is going all the way down. This is a 2 years follow-up, and if you look carefully, there's a good union here and good union on the top. Looking at the results, if you look carefully, now this is important for you to understand, he is able to lift the shoulder up to 90 degrees. And this movement is not occurring at the shoulder joint, at the joint. The child will turn around and you will understand, you will see what I mean. Here we are. Look, the movement is not at the shoulder joint. The movement is scapulothoracic. There we go. You see, he's able to get about 80, 90 degrees of abduction at the shoulder. So this boy saw me after about 8 years, and these are his results after 8 years. The cosmesis, as we were talking about, look at the flatness of the shoulder. But if the child puts on a shirt, it is not possible to discern from a distance that he has got no shoulder at all. So for a child, I would strongly recommend an arthrodesis is a better option. It will give you a very stable joint, and also you can get a good movement. There's another patient. Look at the extent of motion. You see about 80 degrees of abduction, which is very reasonable. The patient can do day-to-day work. Another patient, sorry. This is another patient. Just these videos are here to highlight that an arthrodesis of the shoulder is compensated by the scapulothoracic movement and is a very reasonable and a very good option, especially in a child. So how I look at it, if I gather my experience, I would suggest that avoid 2 plates. If you have to put in 2 plates, get an overlap. Try to get a long plate, sometimes which is difficult. If you have 2 plates, overlap them. Then you have to do an osteotomy of the acromion. You put in the vascularized fibula into the glenoid, make a sandwich kind of a thing, pass in a lag screw through the acromion, through the fibula into the glenoid. This lag screw fixes it there. Sometimes I'm able to put in 2 lag screws. And then you need to have a lat dorsal cover of the proximal arm to give you some coverage of the metalwork and also to give a contour. I always give them an external support in the form of a aeroplane splint, which you see here, which could either be manufactured in your own, or you could have an expensive off-the-shelf aeroplane splint. As I already said, if you have sacrifice the radial nerve, you have to do a tendon transfer for a wrist prop. Mind you, I'm not saying this is the only way of doing the surgery. There are other methods, as already hang the fibula to the clavicle. I think Dr. Masood Umar is going to talk about it. To my mind, the glenograft arthrodesis gives you a better stability, but it takes longer time to unite. If it works, it is long lasting, but it has its own complication. The hanging scapula is less stable, but you're able to get an early movement. I cannot for the long-term results, especially in a child if he lives for 20 years, 25 years or more. Somebody said, well, if you can work on a vascularized fibula, why not a non-vascularized fibula? It is there since 1911. To my mind, after the literature search, I would suggest that you can use a non-vascularized fibula, but if the defect is up to 8 to 10 centimeters, please do not use it in longer defect. If you're using a non-vascularized fibula, you should have a vascular bed, and cancellous bone grafting should be done at both ends, and you should aim for a stable fixation. The non-vascularized fibula does not work well if you are going to give them post-operative radio or chemotherapy, or if there is a suspect infection in these places. Of course, this is a possibility in centers where there is no facility of a microvascular surgery. So vascularized fibula would be done in center with microvascular facilities. Any defect you can fill in, as I pointed out, in potentially infected area and in where you can use an adjuvant chemo radiotherapy. So I would end by concluding by saying that dissection arthrodesis of the shoulder using a free vascularized fibula is a reason, not the only option. After a wide local excision of malignant tumor of the proximal humerus, the shoulder arthrodesis gives a stable foundation, and scapulothoracic movement gives a good functional result. Thank you very much. If there are any questions, I'll be happy to take them.
Thank you very much, Professor Surafi's very enlightening talk. I think we'll keep the questions for the debate, because we'll revisit this in the debate session as well, if that's all right. We have learned a lot from your experience, and a lot of us have gone on to experiment with this technique in our own practices with not as successful results as yours, provided your long experience with this technique, but it is I personally have found it a very, very useful reconstruction option, especially in the younger age group, as you have rightly highlighted. Going on to the next option in reconstructions after proximal humeral resection, there's a technique that I myself have never experienced or had the opportunity to see even. I will welcome Dr. Ali Anwar Jilani, who is a consultant orthopedic oncology surgeon working at the Indus Hospital in Karachi, who has
Assalamu alaikum. Can you hear me?
Yes.
Yes, we can. Go ahead. Athar, we lost your voice.
Can you see my?
Yes, Jilani sir, go ahead.
Assalamu alaikum. I am Dr. Ali Jilani, and I am working as a sarcoma surgeon at the Indus Hospital network. So I was referred a case from my pediatric oncology team about a year and a half ago. She's a 20 years old female. She is a treated case of osteosarcoma of the proximal humerus. She operated 3 years back at some other hospital with wide margin excision, and she was reconstructed with a vascularized and a strut fibula. So the previous surgeon used both the fibula and he hanged the shoulder joint. So there were no significant finding on the history and examination. However, on radiograph, I found a abnormal looking calcification area near the proximal end of the reconstructed shoulder. This was her X-ray at presentation. So I decided to remove the screws, take a biopsy, and then go for a MRI, because our radiology was not letting us do the MRI before removing the screws. So we did that. This was the post-operative X-ray, and this is the MRI of the left humerus. So you can see the lesion, and it's attached to the reconstructed fibula, and part of the glenoid is also probably going to go in the resection. So biopsy reported a recurrent telangiectatic osteosarcoma. There was no metastasis. And in the tumor board, we decided for a wide margin re-excision and not to go for any further chemotherapy. So the first part was not difficult to decide. We opted for a type 5 resection with an extra-articular resection of the shoulder of the bone. So dilemma was how to reconstruct. So because I had been doing recycled bones for before this, and the nascent bone was not available, and there was no fibula. So for desperate situation needs a desperate answer. So I was left with two choices: either to hang it with a nail and place a cement spacer at the proximal end, and or to do a clavicular pro-humero reconstruction. So it was first described by Professor Winkelmann from the Münster University in 1992, and then republished in PubMed in 2008. So basically, it starts from either disarticulation of the clavicle from the mandibular clavicular joint, or an osteotomy just distal to this joint. And then you have to preserve the soft tissue around the clavicle, and you have to take special care on the medial end, because this is where the feeding vessel to this clavicle enters. It's a branch from the thoracoacromial artery, which is a branch of the axillary artery. So you have to be very meticulous near the lateral end of the clavicle, near the coracoid, to save this branch. So
Apologies for the technical difficulties. I think Dr. Ali is having connectivity problems probably. And he's dropped offline. He's probably disconnected.
That really happens when the electricity goes off. It's very common in Karachi because of the rainy season now.
Z, you are muted.
मैं कह रहा था सर, ये गरीब मुल्क के कॉमन मसले मसाइल हैं, सिर्फ कराची को लिमिटेड नहीं है.
You're right. पहले कोर्स हम करा रहे थे अभी 2 हफ्ते पहले, तो डॉक्टर शोएब और अयाज खान उधर से पेशावर से थे फैकल्टी, तो they had terrible problems due to electricity and couldn't connect in their due course. Had to select a different time जब वो electricity on होनी थी. But you are absolutely right.
So let's just give a couple of minutes to Ali to log in again. If he doesn't, then we can probably take his talk a bit later, and we can go on to the next speaker. So in the meantime, while we're waiting for Ali to log in, I would like to welcome Mr. Tom Koska, who has just joined the list of panelists. Mr. Tom Koska is a consultant orthopedic oncology surgeon at Oxford University Hospitals. He is also the honorary secretary of the British Orthopaedic Oncology Society, and previous head of anatomy at the Oxford University Medical School. Thank you, Mr. Koska, for joining us. We're just having technical difficulties with the current speaker who's just dropped offline. We're giving
Thanks,
it
Arthur. Thank you. Thank you very much. Very good afternoon, faculty, and thank you very much for inviting me onto this. As you were just dealing with your technical difficulties, I was just thinking with fond memories about the 4 months I spent working in Karachi, and I remember the frequent power cuts during the rainy season. So it's I remember it very well.
So Dr. Athar Ali has confirmed a power breakdown. So let's move ahead. We can engage him once the power is re-established.
Okay.
Kindly
Sure,
go ahead.
sure. So Ali can obviously continue his talk later. We will move on to the next talk in the session, which is by Dr. Badr Sahito. Dr. Badr Sahito, again, a very dear friend of mine, did his oncology fellowship in Japan, has quite significant experience with recycled tumor-bearing bone, and he will be talking to us today about using recycled tumor-bearing bone in humerus reconstruction. Dr. Badr works as an associate professor at the Dar University of Health Sciences in Karachi. Dr. Badr, we can see your screen. I don't think we can hear you, Dr. Badr. You're not muted, so.
आवाज नहीं आ रही, Dr. Badr.
It might be a problem with your mic. Do you want to unplug your mic and just speak to the computer microphone?
Can you hear me now?
Yeah.
Yeah.
Thank you very much. So I'm going to present the
Dr. Masood, if you mute yourself, I think there's a lot
most common site for development of primary malignant bone tumors, and second most common site affected with the metastasis. And for upper limb reconstruction, most of the work done on the humerus, less on this radius and ulna, but distal radius already discussed. There's Dishan and distal radius reconstruction. So we will discuss only on humerus. So Dr. Mohsen already showed this isosceles classification related to the humerus resection. So if you do some recycling, you can do resection all around the humerus and do reconstruction. There's no problem with recycling all around this, all these 6 quadrants of this humerus resection. So these are multiple methods of reconstruction, and these are biological. So recycling is one of the methods of recycling, biological methods. So recycling is a method where you can preserve the host bone, and there are multiple ways. And we have all the team, they are doing in a different way. And the advantages are we can preserve the bone at low cost, as easily doable in our society, easily soft tissue attachment, and we can preserve the growth plate, where the mega process costs much cost in this. So autoclave, Dr. Masood doing it, few of the cases, Dr. Attar did the pasteurization, irradiation, still we are waiting to do somebody do the irradiation, and frozen we are doing in Civil Hospital Karachi. So all these 3 procedures done in Karachi, most of our faculty is also doing these methods. Rishan also did the frozen bone also, he also did the autoclave. So autoclave, we can do autoclave for 130 degrees for 8 minutes, and for upper limb tumors, autoclave bone acts as a spacer only. So if the patient does not develop any non-union or infection, then results are good. But this is a big problem, that bone becomes completely dead and it only acts as a spacer. So these few studies are published. One of this in Malaysia, they show there's only 3 cases of humerus tumor recycled with autoclave, and 2 of them united after 8, 10, and 11 months. 1 had a fracture and a recurrence. Dr. Masood published cases where he mentioned 5 cases of humerus and 3 of the radius with the autoclave, where 4 have a union within 5 to 11 months, and 1 had a non-union, and all 3 radius united within 6 to 9 months. So good ratio of union, even Dr. Masood have shown in cases. Another method of recycling is irradiation. There's 50 to 300 the variable people doing at a variable rate of radiation. So it's again useful technique for limb salvage with bone preservation is possible, and it's also effective way to reattach the tendons and produce long time biological reconstruction. So this was a study published in 2005, and they did most of this 50 patients around, and out of them 11 was the humerus. So they put composite, and they have shown good result with the composite. But they have mentioned this complete resorption of this bone after some time in 1 or 2 cases. So they mentioned that they have dissolution of the humeral head, have proximal humeral cases. Thereafter reconstruction with. They did the later on reconstruction with the processes. So they have done the ventricular recession as well and reconstruction with vascular fibula followed. Avian developed in one of the female head, one had the non-union and one had the disarticulation. And they did the one disarticulation. So this is again as Ajay Puri has, they are doing in India, they have a good number of cases related to the irradiation. They have done few of this. This is the article they mentioned. Humerus in 3 and 1 in ulna. And ulna autograph after recycling. Ulna recycling with irradiation infected later debrided. And humerus recycled bone also the problems of implant failure, refixation and bone graft. So Athar started posterior when he did training from Korea. So this bone was kept preoperatively heated in 60 degrees saline for 30 minutes. And in retrospective study, 144 patients process composite reconstruction done in 12 patients only. The most frequent cause of failure was infection, 35%, followed by loosening and fracture of posterior bone, metal failure, and local recurrence. So these are all complications do happen with all these types of methods of reconstruction. So failure rate by location was femur in 24%, humerus 42% was failure, and tibia is 49%. And pelvis is 67% of the failure. So I have listened that they have even stopped to do this posturization. So we are doing frozen bone cryotherapy, where we are doing this freezing across that was first used in management of tumors in 1964 as a palliative procedure, and the use in the meds of renal cell carcinoma, and the use of liquid nitrogen in the management of primary osteosarcoma was first described in 1984. So one of the studies conducted at Kanazawa, they showed 8 patients with humerus sarcoma treated with the frozen bone, and freezing range classed in a group 2 depending on whether the joint surface humeral void was frozen. And they mentioned in their results that freezing group means active shoulder abduction and flexion were 43.8 degrees and 55 degrees. And isolated score was 70.8%. So some of good excellent functional results you are getting with this technique as well. They have in the joint preservation group, they have active abduction and flexion about 130, 140 degrees. And score is around 90.8%. So it was excellent related to when we are doing the preservation of the joint. So how, there are few cases, we did 3 of these cases where we did this frozen bone technique. So there are 2 methods there we can do this freezing, and with the liquid nitrogen at the rate of minus 196 centigrade. Either you can do this pre-freezing where you cut this both the ends of tumor, achieve the margin, and then freeze into the liquid nitrogen for 20 minutes and thawing into normal saline 20 minutes more, and then re-implant and fix it. So this is pre-freezing. One is pedicle freezing where you need to dissect whole the bone, whole humerus, and then you need to revert this whole arm and put into the liquid nitrogen for 20 minutes and then thaw more than 20 minutes around with normal saline and then re-implant and fix it. So there are 2 methods of freezing and pedicle, this pre-freezing and pedicle freezing. Those other methods you can't do this pedicle freezing, and this is the method where you can preserve the distal vascularity of this bone and that will heal the bone nicely and within limited time. So See, it's V-shaped osteotomy they have done. There's one of the method where you have to achieve the margin and you do the V-shape that will provide a stable fixation of this bone, because that will create a hinge and that will prevent the displacement of the osteotomy site. So frozen bone also can be used with the composite processes where you need to remove the head and you can put some glass. So we did composite in femur, not in the humerus yet. So this is one of my cases where 18-year male having even sarcoma right humerus, already have 3 cycles of chemotherapy, so we planned for pedicle freeze. So this is after post-chemotherapy, so the huge mass that regressed and calcified as well. So involving almost at the level of this neck and mid-diaphragm. So this was an incision mark where this was the biopsy done elsewhere, so this creates some morbidity, but we make an incision right from shoulder, mid of the clavicle to this elbow. And we dissected all around and identify, see, this is an osteotomy site that we confirm on the image. We should do, we did a V shape so that create a hinge and provide easily fixation around this proximal humerus. All the tumors all around on 3-dimensionally dissected out. So see, this is an osteotomy here. And this is no, just identifying this radial nerve, this posteriorly just spared that nerve and dissected whole the humerus right from this proximal end till this elbow. And all the venous structures related to this were spared. See, this is the question you will ask, how to do frozen section in this. So see, if you see this whole tumor is dissected out clearly, take the marrow from this proximal end, send it for histopathology. Number one method of doing frozen section. Number two, if you cut this area, and when you're removing this tumor, cut this area in a single line and take this whole soft tissue and wrap up and send this whole specimen for frozen section. So this is method we adapted ourselves, because most of the people are asking how you do the frozen section while you are doing this pedicle freezing. So it's not possible, but we are trying to do and achieving the margin and make it clear during the surgical procedure by doing frozen section. So after dissecting out, this nerve of radial nerve is spared, and a whole tumor was created out from this bone. And put into the liquid nitrogen for 20 minutes, and then 20 minutes into the gamma saline. See, after freezing, and then put it again and put the plate. So see this after this whole fracture get united. You don't see the osteotomy site in this. So this get united within 3 to 4 months. So I got this recent X-ray, and see, and this is how he had range of motion. See, is 90-degree abduction. This forward flexion, 90-degree abduction is doing almost 30-degree extension. So it's excellent to see the union. There was no infection, excellent movement all around the limb. So he can abduct 90-degree as well. So I have another case with 15-year male having lump on the left mid-shaft of the humerus. That biopsy is confirmed of the chondrosarcoma. Here already this child was treated for Hodgkin's lymphoma in 2009. So see, there was a mass all around this lateral aspect, but looks smaller on the simple X-ray. But see, if you see this MRI, this neurovascular bundle is spared. Neurovascular bundle is spared here, but see this all around this tumor is involving the anterolateral side. See, it's still biceps is spared, somehow this tricep is spared, but everything all around this get involved with the tumor. So this is again a coronal view. You see this medial side is still spare, but lateral side is all involved. Huge involvement of this. So we again did the same. We did the wide margin resection reconstruction with pedicle freezing and fixed with the PLA. So this was a huge mass where we again make an incision all around. This biopsy was done somewhere else. So we did the humerus dissection and see again whole humerus dissected all around this. And again we did the frozen section from the proximal end where we cut this from here, from the medial side, cut this area and save this whole soft tissue around and send this for frozen section. Confirm the margin was negative and see all neurovascular bundle was spent. This is radial and all the medial structure related to brachial artery, everything is spared. Again, there's another view for saving this whole humerus dissected out. And see, we just curated all around by making this incision here and preserve. And send for frozen. After cleaning this whole tuberous bone, created the intramedullary cavity as well, and put into the liquid nitrogen again for 20 minutes. So see, everything should be covered, put at least 2 to 3 towels here so that this normal tissue should not touch to this frozen area, because that will damage to the normal. Cover everything, cover it so that this fluid should not touch anywhere into this normal structure. And see all this and just make it, see the tumor was down the line, so we could make the osteotomy transfers below this and see the union. So this is at 2 months. So absolute union around the osteotomy site, there was no infection and the child was moving all around. So see the movement he getting is more than 50 degree. See the almost all abduction, all flexion. So everything normal on the shoulder. So we have another one case, but I missed to put on, there was a female also having sarcoma. So we did 3 frozen, all 3 pedicles, no free freezing in the humerus. So we got excellent results related to all this union in all these cases. So any question related to this topic?
Thank you very much, Dr. Badr. Yes, because this particular topic is not included in the discussions or the case-based debates later. So there is a question from Dr. Faraz on this particular topic. And again, it is the question about margins. So the question is, how do you assess distal resection margin when you're doing a pedicled, when you're utilizing pedicle freezing? So I think what he means is, how do you measure the margin on the side that you have left attached to the body? Especially your intramedullary margin.
Yeah, basically you are exactly right. That is almost impossible. But we make an, see this, if you dissect it out, hold the tumor. Now see, whole things you get dissected out, everything out, all around this. So see, now what you need to do, just cut this from this surface, cut this surface on one end where the tumor is less. Split this in a 2 segment, this tumorous tissue, while you're curating, and apply this stitch, 2 stitches right from on one side, and send this whole specimen. You will get all around the frozen section.
No, but
so this is what we did. Yes,
can
please.
You hear me?
Yes, sir.
Yeah. Yes, Dr. Bhatta, how are you? My question is that how do you assess the distal disease? Because to my mind, what I understand is that you have to dip it into the liquid nitrogen till you have reached some centimeter, like 0.5 millimeter or 1 centimeter beyond the diseased margin. Because you have to eliminate the disease in the intramedullary area as well.
Yeah, I got your question. You are saying that how I assess that this distal margin, there is no tumor, and how I can make it free. Number 1, I resected see whole the humerus. Humerus grossly is only involved this area, but see whole this humerus is dissected till this elbow. and whole this humerus is dipped into the liquid nitrogen. Even this normal portion is dipped into the liquid nitrogen. So if I have a doubt that the tumor get residual into the distal segment, so it's unlikely to be preserved. So that will be damaged with the liquid nitrogen. And
But
second, we all ring this medullary cavity whole, right from proximal to curate all this. Because if you don't curate, if you leave the tumor inside the bone and put into the liquid nitrogen, that will increase the pressure and the bone get break. We have a few patients in distal femur also where we put this some tumor residual inside the bone and we put in the liquid nitrogen. So that will create a pressure inside the bone and the tumor cells get swell up and there are chances of fracture around this. So we always try to remove everything that lying inside all around the bone. So if you remove everything, there will less chances of breaking in the bone.
So you mean that the liquid nitrogen goes inside the bone and it goes distally and damages and destroys the malignant cells. This is what you're saying.
Exactly.
Thank you very much.
Can I suggest something?
Can I have a question? Can I have a
Yes,
question?
Yes,
Dr.
please.
Fadar, in your opinion, do you think this treated bone would act like a allograft or a non-vascularized fibula or a vascularized fibula? The why I ask this question is that you have to extrapolate the long-term results based on what it mimics. If it is mimicking a non-vascularized fibula or a vascularized fibula, so the results should be comparable to that particular technique, won't it be?
So basically, you are saving this whole distal blood supply where this humerus is getting from intramedullary. So you are still preserving their distal attachments all around this in the elbow. So somehow this is not discontinuous from this distal vascularity. So this is all vascularized. And I have seen this all cases even in children. This 8 weeks or so, this all fractures get united. Yes, I am worried about the infection, definitely. But see, this vascularity in the distal part is preserved. So this is one of the advantage where you're doing pedicle freezing. You have double advantage that you are going to preserve this bone. This bone get dead, but say this distal vascularity preserve it. And there was a studies published by the Canada people. They mentioned that all this bone becomes normal. They are getting all this vascularity even into this bone. So this is how you can consider it as a vascularized, because this is vascularized. We are living on one side.
So if you remember the talk we had from Professor Suchia 2-3 years ago, I believe it was in the workshop we organized at Liaquat National, in the course that we organized at Liaquat National. They had shown histological studies showing very early revascularization of cryopreserved recycled bone, which can happen as early as 6 weeks. And there is a mouse-based study which compares autoclaving versus pasteurization versus cryopreservation, as well as extracorporeal radiation. And obviously, that particular study has shown significant advantages of cryopreservation or liquid nitrogen over other methods because of one. Yes, you can technically argue that the problem could be, are there any malignant cells that are harvested? But in the long case series of Kanazawa itself, they have not had problems with tumor recurrence local. And I agree with Colonel Faraz that you cannot histopathologically prove the distal intramedullary margin. You cannot. You don't have proof on your slides, and that has been my problem with discussing this on some of the MDTs when the oncologist is a non-believer in this technique, and you cannot convince them that you have got. We've discussed this a number of times, Badr, haven't we? That it's very difficult to. One of my oncologists actually refused to give the patient chemotherapy because he said the wrong surgery was done.
Yeah, exactly the same. Everybody say, one of the patient I have, remember the proximal femur, we did this pedicle freezing. They said, margin, how can you assess margin? So we don't believe on you. So what they did, even the biopsy of post-operative we did, and there was 0% tumor necrosis in evening. And what they did, when I sent them back, they radiated. So there was a fracture. And in that case, we put this PFN and there was 100% union on that radiated bone after frozen with union. So somehow that is showing there was excellent vascularity and showing the healing. So this is again the people. I discussed with the Sucha the same thing. He said, don't ask them to radiate this bone because you are going to hit the twice. Already once you are doing this in liquid nitrogen, again they are putting radiation, so you are going to hit twice, so the bone become more dead. So don't ask them to radiate. Give them a good chemo. That is a good solution. Good new adjuvant, good adjuvant. That is the best solution for this. If you do everything, so recently what one
Dr.
case I
Badal?
did fail prophylactically because I was don't expect they will not do the radiation. So I did prophylactic fixation, pedicle freezing. Maybe they will put some radiation. Again, there was a fracture. So there are some our issues in our system. But the things I found, if you don't have infection in these cases, they are such an excellent. Even freeze frozen, they have excellent results if you don't have infection. So I am only worried about the infection, but bone union is excellent, all these cases.
Yeah.
But there's one thing that can be added. I think we can make a small window quite distally, a small bony window, and take out the marrow and send for frozen section. Maybe that's how you can prove that the distal segment is disease-free.
Yeah,
That's
this
just
is again discussed. See, either you achieve the distance. Again, if you make whole window, you're gonna weak this bone. Yes, you can take somehow. This is one of the methods. But again, if there's something that people don't believe. Just being a surgeon, Vishan don't do frozen because most of the time he rely on this 99% he's getting free margin. He never do the frozen. But see, surgeon should even believe on himself as well because you are doing routinely and you have to convince your whole team that they believe on me, I'm doing something good. So don't run away.
Thank you so much, Dr. Badar. I think in the interest
just
of time, can I
make a quick comment?
Yeah.
Or a question, basically. Are you regularly doing a frozen section after freezing the bone? Before
No.
fixing it? No.
We did. No, we don't. No, we don't.
Would
We
that
did
not
in one
answer your
case.
question in a way? Dr. Faraz's question?
Yes, again.
Intramedullary. At the end of your freezing and thawing process, you can maybe take a
yes,
curette and bring whatever you can bring out and do a frozen section on that. And that might answer your question.
Yes, we can. But see, if you follow these old cases, if you leave something inside the bone, there must be some recurrence. If you leave even a single piece of this tumor inside the bone, there will be recurrence. So even the Sucha have shown their cases, even we have seen cases, we don't have a recurrence in this recycled bone. Yes, we have one patient, we have soft
You can't empty the whole bone out. Something will be left. That's why we believe in this freezing. You cannot clear it up. Maybe you can bring something back. Okay. Anyway,
I think this topic, this discussion is beyond the scope and the time that is built into this particular webinar.
Dr. Badal, sorry, एक last comment है मेरा.
Ali is also sitting. He is doing a lot of these. So, what is his comment? Ali, please.
Dr. Badal, can you hear me, please?
Yes, sir.
Yes, Dr. Khalid, we can hear you.
अच्छा, इसमें ये है कि ये जितना बड़ा स्पेसिमेन आपने क्लियर किया है, ये एंड यू हैव मेड रेडियल नर्व को बचा लिया किसी तरीके से आपने मौजे से.
Yes, sir.
तो हाँ, तो आई थिंक व्हेन यू टेक सच अ बिग स्पेसिमेन, probably it is not possible to save the radial nerve. In my opinion, if the radial nerve or any nerve come in the area of the tumor, it should not be saved. It should be taken out.
You are absolutely right, sir. If you are absolutely right, see this MRI. See, this nerve is lying somehow here. And if you remove this, see this here. It's not inside the tumor. See, this just an edge all around here. So if you take to the sheath, you can preserve it. So there was an article written in Canadian journal. They mentioned if you are doing reconstructive surgery and you are saving the limb, you just take the sheath all, preserve the main structure that will provide a good functional outcome. So if this comes into the tumor, definitely you remove it. But if you are getting the margins, even marginal. So save the main structures. If you cut these main structures, even that create a problem. So see, it's a nearer to this tumor, but around this one end, you get a margin free.
Just a small comment, Athar. The pericardium is again a margin which resists the growth of the tumor. So you can preserve the nerve, radial nerve especially. And in our cases, now 80 to 85% cases, we are able to preserve the radial nerve.
So soon there will be a paper which will elaborate on the histological essence of this. We are working on that. Why the perineurium acts as a margin. Because there is no histological evidence published so far, there is obviously clinical series, and it's established fact that all of us tumor surgeons use.
I would just like to make a small comment. I've been doing a lot of vascular frozen bone reimplantation and also the pedicle frozen grafts. So I haven't found any recurrence. And if we do a biopsy at the distal end, then there's a likelihood that the bone is then going to break from the distal end, because you cannot usually get a fixation beyond the point that you think that the tumor is not going to be present here. So, and our histological margin is based on the MRI, and I usually go for pedicle frozen only if I have a 5, 7, 8 centimeters of free
tumor-free
bone available. Yeah, free bone available, and there is no intramedullary edema on the MRI. So I make sure on the pre-operative planning, only then I go for pedicle freezing. Otherwise, I usually resect the bone and do a free frozen. Thank you.
Okay, we'll go on to the next talk now. I think we've overrun the time quite a bit, but the good thing is that it's generated a lot of discussion, this talk. Thank you, Dr. Badr, for that. Thank you so much. I will now ask Dr. Zishan Khan again. You've heard him before talking about the distal radius. He works in Peshawar and Hyderabad Medical Complex. He's done his oncology fellowship in ROH Birmingham and is leading the oncology services in Peshawar and the northern in the KPK region. So Dr. Zishan Khan will be talking to us about nail cement spacers and his experience with using nail cement spacers. He will tell us about indications of this cheap option for management rather than EPR, which are very in our socioeconomic setting.
Thank you very much, Akhtar. Badr, can I ask you to stop sharing your screen, because I can't share mine until you've logged out.
Yes, sir.
Dr. Badr, can you stop sharing your screen?
Okay.
If you go to screen share at the bottom of your Zoom and or at the top, there should be a red tab.
Yes.
Yeah, thank you.
I can now. Okay, thank you very much. I've talked a bit about this in some meetings, and just like there was a lot of discussion generated regarding pedicle freezing, I've always had to answer so many questions with regards to this. Let me make a confession. At some point, I thought I'd just made an invention, but sometime later, when I went through the literature, I just found out that I hadn't reinvented the wheel. In fact, I tried and made some modifications with regards to the needs of our society. Anyhow, so we've already discussed that the proximal humerus is not an uncommon site for musculoskeletal tumors, including both primary and secondary disease. It always offers a challenge when it comes to removal of the tumor because of the close approximation to the brachial plexus and the vascular bundle and the important structures, including the muscles around it. We all know that the shoulder is a very hypermobile joint, and the only reason why that is because of the sort of the mobility levered to it and the stability provided by the rotator cuff. We are always challenged because of the demands by the younger population and the demand at the shoulder, because you need the shoulder joint to place your hand in order to do what you want to do. So the role of a musculoskeletal oncology surgeon in metastatic disease is to get a diagnosis and then perform an operation which should provide the patient with good pain relief, restore as much function as possible, and most importantly, whatever form of reconstruction we should do should see the patient through the rest of their life. So these are the important things to be kept in mind. When we look at the reconstruction ladder, lots of these things have been discussed, but when we consider metastatic disease, I believe the two options that we are valid only are either ablative surgery or reconstruction with an endoprosthesis. This is our society, this is what we live in. But whatever we exercise, we have to do some safety, hence the helmet worn by the driver. Supply and demand, this is the basic law of economics. Unfortunately, every one of us in this country cannot afford a Swiss knife, so we have to make do with a simple dagger. Or in Pashto, we say ad-darewal chaku, which works very well, serves the purpose. Now, this is where the word frugal came from, and I'd never come across this word called jugaad, which is very common in Karachi. And because of my frequent visits in Karachi, this is where I learned the word jugaad. And actually, this is what this whole topic or this whole lecture is about. So I'll introduce this to you with a case scenario. If I'm not wrong, this is probably the first case where I did this reconstruction. A 32 years old male nurse came from a humble family background, was recently married, and was attending his friend's wedding just after his, and had a fall. And as usual, he came in with a history of pain, no pre-existing symptoms, otherwise fit and well. If you have a look at the plain radiograph, certainly there is some heterogeneity, suspicion enough to warrant cross-sectional imaging. And when we looked at the cross-sectional imaging, there was a cartilaginous lesion with some heterogeneity. We did a biopsy, and the biopsy confirmed this to be a clear cell chondrosarcoma. I don't normally get PET scans for my patients because of financial reasons. We only get them if we are concerned about distant mets not picked up by routine CT scans. So I think because of this guy being related to the allied medical profession, he got a PET scan, and surprisingly, although very uncommon with clear cell chondrosarcomas, he had a lesion in his left rib and another hyperactive lesion in his lymph nodes. We biopsied his rib with the help of our interventional radiologist and the neck nodes, and they both came back as positive, which was a surprise again, considering this was a clear cell chondrosarcoma. So we went in, did a resection, and as this was a metastatic disease and affordability was a problem, hence the first time I used a nail cement spacer. It worked very well, and this is what I offered him. We wanted something else, but we had something else, and Captain Jack Sparrow still came in and saved the party for us. So it did the trick, although it wasn't what it actually should be. So in this scenario, an endoprosthesis was only acting as a spacer. Bear in mind that the resection is below the deltoid, the rotator cuff is gone, and in more than 50% of these cases, the axillary nerve is sacrificed as well. So when you look at the cost analysis, around $500,000 rupees is the cost of an endoprosthesis or a hemiarthroplasty. And this construct with a K-nail, 2 packs of cement, and a 25 by 25 proline mesh in order to stabilize the head of this humerus cost around 19,000 rupees. So a stark difference between the two. So then I did a few more of these for some other metastatic disease. And when I started having good results, I thought, why not we expand the indication? So I started doing them for patients with malignant disease where they did not show good response to chemotherapy, or the prognosis was guarded, or some patients with mets as well. So I started doing them for primary malignant bone tumors or primary malignant bone tumors, such as in this case. Now, one of the issues with this is, as I alluded to earlier, that the rotator cuff is excised completely, deltoid in more than, well, I would say probably in about 70 to 80% of the cases, more than half of the deltoid is resected as well. So stability is an issue. Now, bear in mind, my patients cannot afford an endoprosthesis, so they cannot afford a Trevera tube or some form of a Merceline or a Proline tube as well. So instead, what we do is we get this proline mesh, which the general surgeons use for their hernia repairs, and we stitch it around in a purse string fashion around the glenoid or some part of the labrum that is left in place. And this offers some stability. As I will show you in this video, operatively, that the joint is quite stable. So in a way, I sort of create a pouch for this, and the remnant soft tissues are stitched onto this mesh, which offers an adhesive area for all these muscles to be attached. Then we use them in certain more aggressive cases, like in this one, where even the whole of the deltoid was resected. And as you can see on the clinical photograph on the right side, we had rotated an LD flap to provide our soft tissue cover. This is a young Afghan girl on whom I did that LD flap. I think we did this around 2017. And both of us here were cursing the sarcoma, and we thought we'd done a great job. But unfortunately, the Lord had some other plans, and she had a recurrence distal to that site around the elbow, and it was confirmed as recurrence on a biopsy. So the reason why I want to show you this is we went in and planned for a disarticulation because we couldn't do further limb salvage in an already salvaged limb. And what I found was that that proline mesh had formed such a nice capsule all around it. And if you follow this clinical photograph on the bottom right, you would see that that mesh has incorporated all around the labrum, and it has formed a very nice capsule. And this is what gave me more confidence that this will offer stability to these patients or the construct. Now, the common long-term complication with these is proximal humerus migration leading to saucerization of the acromion, pain, and may need revision surgery. This is one patient, plain x-rays immediately after reconstruction, and this is that patient at 5 years showing some saucerization of the acromion. But this is not inherent just to this construct. This is a common problem with these hemiarthroplasty kind of endoprosthesis leading to these proximal humerus migrations. This is one such patient, and if you have a look at her function clinically, she has reasonably acceptable function, allowing her to do most of her daily activities, albeit with restriction at the shoulder joint. So this is where I am now. I've done about 3 dozen cases, almost half and half for primary malignant tumors and metastatic and other diseases. If you consider mechanical failure as an endpoint, then the survivorship at about a maximum of 5 years is 100%. I have so far yet to revise one for mechanical problems. The MSTS score isn't that brilliant, but it is almost comparable with just the endoprosthesis as a spacer. I'll give you some of these results when we discuss that when we are comparing it with the endoprosthesis. But with regards to their daily activities, they are reasonably satisfactory. So I conclude by saying that the shoulder is a hypermobile joint. It is a complex joint offering challenging situation to the reconstructing surgeon. More often than not, the rotator cuff, deltoid, and axillary nerve are resected, and they are the bits that are paramount to our function. In a resource-constrained environment, we have to improvise. In my hands, so far, functional results are satisfactory. However, if a better prosthesis is available, such as a reverse polarity shoulder, but even then, keeping in mind, you still need the axillary nerve and the deltoid to move that joint, that should be used. So we're still learning. We do not yet know which is the best type of reconstruction for these challenging tumors, but they should be customized to your patient, the prognosis of the patient, and whatever your health system allows. Thank you very much.
Thank you so much, Z. And this again opens up and sets the ball rolling for the debate that is coming in later, which is endoprosthesis.
Dr. Zishan, would you be using it in palliative settings, or it seems you are now thinking of using it as a primary procedure, as a definitive procedure?
Sir, like I mentioned initially, I started off with metastatic disease. Now I am using them in cases where the prognosis is sort of guarded. You can get an idea where your patient may not be showing a very good response to their neoadjuvant chemotherapy. So in those instances and with the sort of constrained resources that we have, I have a discussion with these patients and offer them this nail cement spacer. However, my preferable technique in the younger lot is still a vascularized fibula. As you know, I've been doing that, and we happily say that I am a convert now because of you. But in the elderly population, in the metastatic disease, or if we do not have the availability, then I would use this nail cement spacer.
Okay. If that's all right, we'll revisit further questions and discuss this again in the debate session.
Can I one comment?
Yes, Badr.
Dr. Zishan, do you think the heat creating some problem in this spacer with the bone cement? Because we have put few patients where we found there's once it is cold, the patient is okay, they're moving all around, and when this heat goes on 40 plus around, because patient coming all around from Ladakanathar everywhere, so they have some burning sensation, they have some infection even we have seen. So do you think in Peshawar, if heat is going on and this spacer creating some problem?
See, it's a wonderful world we live in. This is the first time I'm doing this. Actually, not so far, but something good that you've mentioned. I'll probably start asking all these patients whenever they come for their routine follow-ups regularly, but not something that I've been informed by patients. Bear in mind that it gets as hot.
I observed this thing.
Right. It gets as hot in Peshawar as
exactly.
it does in
They are feeling
Sindh.
that there's something hard because the heat is around 40 plus. Yeah, sometimes happen in June, July and Peshawar as well.
I'll check that next time.
Dr. Masood, do you have a comment to make?
Just a small question, Dr. Zishan. How do you ensure a very stable nail cement bonding? That doesn't loosen in due course of time of the patient subsequently.
So at the top end, you mean the humeral head that? So initially, what I started doing was that I was just putting some masonry around the top part of the nail, and then slowly and gradually we sort of made a sleeve of that cement in continuation onto the nail. But in the last sort of 15, 17 cases, what I've started doing now is I put a screw through the top part of the K nail because there's a slot available there. So that offers some more rotational stability. Having said that, in all the cases I've done so far, there hasn't been any migration of the so-called humeral head, if you may call it, on the nail.
Can I add to that question? I was looking at that disarticulation that you did with the nail cement spacer on, and when you opened up the sleeve, you could see some, was that metallosis, that pigmentation, or was it something else? Because there was that gray discoloration around on that proline.
No, I think it wasn't any metallosis because there wasn't any metal rubbing on metal. It was probably just the mesh, I believe it was just the mesh undergoing some histological changes, transforming into some form of a fibrous or a scar tissue. Having said that, I can only confirm if there was a histological test performed. Let's hope not, but if I revise any in future, I'd keep that in mind and send it off.
Sure. Good. So I think because of technical difficulties, we did lose out on Dr. Ali Jilani completing his talk about clavicle prohumeral reconstruction. So Dr. Ali, would you kindly continue the talk from where we left off?
Okay. Can you hear me now?
Yes, we can.
Okay, I'm very sorry for the interruption.
Not your fault.
Okay. Okay, you can see the screen now?
Yes.
Can you? Okay. So
yes.
I'll run quickly. So I was referred a case about a year and a half from now, and she was a 20 years old female, and she was a treated case of osteosarcoma of proximal humerus, and operated 3 years back with a wide margin and reconstruction with a hanging vascularized and both and a strut fibula. So both fibula were used. So there was a abnormal calcification here. So I went for the removal of screw, took a biopsy, and then went for a MRI. Post-op X-ray, this is the MRI. The tumor is abutting the fibula and the part of the glenoid. So biopsy was reported as recurrent telangiectatic osteosarcoma. There was no metastasis, and in the MDT we decided for a re-excision and no chemotherapy. So opted for a type 5 resection, an extra-articular, and my cut going through the scapular notch, taking the glenoid out. I was able to save the acromion. So dilemma was how to reconstruct, because I had been doing recycled frozen bone in the past, and no nascent bone was available, and both the fibulas were also used in the previous surgery. Prosthesis was not an option. So I was left with two options, either to go with what Dr. Zishan was telling, or to go for a clavicular prohumeral reconstruction. So this was first described by Dr. Wilkelman in 92 and later published on PubMed on 2008. So the procedures start from the disarticulation of clavicle from the manubrium, or you can do a osteotomy just lateral to that joint, and then start lifting the clavicle. And you have to preserve the soft tissue along the clavicle so as to let the blood supply be in the bone. And you have to be very conscious at the lateral end, because this is where the artery to the clavicle is going. It's a branch from the thoracoacromial artery, and which is a branch of the axillary artery. So we have to protect it near the coracoid process. So there have been some case series, and most of them have been in the pediatric population. So now coming back to the case, I did a resection and able to save the neurovascular bundle and the acromion and the clavicle and the acromoclavicular joint. So turned the bone down and fixed it to the remaining part of the humerus. So this is the 6 months follow for this patient. And the other thing is, you can, if you have some coracobrachialis or the muscles available in the distant part of the arm, you can hang it to the coracoid process. So that will create some movement at the shoulder, and not like the ones we saw in the vascularized fibula. But you can get up around 30 degrees of abduction and some degrees of forward flexion. So this is at 1 year follow-up. She's able to use her hand quite well, but there is not a lot of abduction. She can rotate her shoulder to some degrees. So we have to remember that this was in desperate situation. So second case is a 14-year-old boy, osteosarcoma, X-ray at presentation, the MRI, and conventional osteosarcoma. Started on pre-chemo and then the post-chemo sclerotic images. So this is the per-op picture. So the incision is quite simple, like in the teak half, and then extending the same limb on medially towards the manubrioclavicular joint. So again, the immediate post-op at 6 weeks, and at 8 months, I can Now appreciate a little bit of bone resorption between the second and the third screw on the proximal end. So this is a problem with this clavicle turn down procedure. Function is okay. He can do most of his chores, but not like we cannot call it a stable shoulder joint. So my third case is a 13-year-old boy, and he had a fractured through the tumor. No metastasis, and the biopsy reported Ewing sarcoma. We opted for a new adjuvant chemotherapy. So the tumor solidified, and we could now go for salvage procedure. So this is the post chemo MRI. Again, now at 3 weeks, it's quite stable, and at 6 weeks, it started to unite. If you can appreciate it, it has started to unite now. Now, the second complication, it did not resolve, but this time it's broken at the stress riser. So I had to do a long plate reaching up to the proximal end of the clavicle. So my fourth case is a 9-year-old girl. She had a swelling on the right shoulder, and she was diagnosed as chondroblastoma, and it was quite big mass considering her age and height. So the problem with this case was the clavicle was too short, and she had considerable shortening of the arm. And because it was so thin, I could just put it in the distal part of the humerus. She had good union, and at 6 months completely with no issues. My fourth case is a 16-year-old female. Actually, it's the fifth case. So she was reported to be giant cell tumor. The biopsy was done in another hospital. This was her X-ray on presentation, and because it's not really a disease of 16-year-old, we had to do a relook at the blocks, and our histopathologist concurred with the previous diagnosis. So we discussed in MDT and then went for denosumab. So these are post denosumab images at 2 months, and then we went for a resection. And so my last case is a 22 years old boy with a right-sided proximal humerus swelling, and was diagnosed as chondrosarcoma, and metastatic workup was negative. These are the images and the MRI. So again discussed in meeting and decided for a upfront resection reconstruction. So I don't have the post-operative X-rays, but at 3 months follow-up, the bone has started to unite. So I have very few cases, and because I have started it just a year and a half ago, but this sums up what I have been through with this clavicle turn-down procedure. So one problem is the clavicle is not long enough to support a 20 centimeters, maybe a 17, 18 centimeters of resection, and the limb becomes extremely short. This is one problem. The other problem is you have to protect the vessel going into the clavicle, which is very difficult. And even if you do protect it while dissecting, when you are when you're shifting it on the humerus, it is very fragile and it's tend to shear apart, and not just per operatively, but maybe after the surgery, and when the child starts to move his limb, then this problem can arise. there is no solution to check whether this artery is working. But what you see is delayed union, non-union, bony resorption. This is the thing that I have seen most. I've done 8 cases, so I've seen bone resorption and fracture in 3 of them at least. And the other thing is when we are doing it on a small child, 8 years, 7 years, so the bone is so thin that it becomes very difficult to really fix it with any kind of plate, any size of plate. So these are some observations in my short stint with this procedure. So it's a good salvage option where techniques for vascularized microcircle techniques are not available, and you don't have that luxury. So you can go for this, and it saves a lot of time, because when I was doing frozen bone, it took me around 6-7 hours, 8 hours maybe to do the procedure. Now with this, I can complete the procedure in almost 3 hours, 3.5, 4 hours. So it's saving a lot of time and anesthesia to the patient. Thank you.
Thank you so much, Dr. Gilani. I think there are a few questions. Dr. Masood Umar has raised his hand. So, Masood.
Thank you, Dr. Gilani. I think I can vividly remember the first case, and I think we had discussed it together also.
Yes.
This is a very good case. I think you don't have the initial the pictures. Actually, Atar Siddiqui was also involved in this case when he was at Liaquat. So it's to complete the history, it has 3 or you are the third surgeon in line for that patient. Just to give a brief background, it was a huge mass, just as you have shown in the last X-ray, huge lytic mass, which initial impression was that of this one, just the giant cell tumor patient. The initial X-ray was like this. So I think Dr. Athar did the first biopsy, and there was a doubt of aneurysmal bone cyst. And I think we talked with each other. I told him this doesn't look like aneurysmal bone cyst on the X-ray. And I am sure that this is not ABC, just like the case that Dr. Mumtaz showed, that this cannot be an enchondroma. So the radiologist cannot bypass you. You have to have your own. This is for the residents. You have to have your own good understanding of the preoperative X-ray. Yes, like this X-ray. So we then talked. We said let's go for another biopsy, and this time biopsy was sent outside also, and so we came up with a diagnosis. Final diagnosis was telangiectatic osteosarcoma. So, and then this was a huge disease. Then she was subjected to chemotherapy, ultimately resection, and if I am not wrong, the resection percentage necrosis was only 25 or 30%. Of post-chemotherapy, post-resection, post-chemotherapy specimen. And then obviously she developed this recurrence, which was localized to the deltoid region, and problem within our social circumstances is lack of financial resources, and ultimately she ended up with Gilani Saab. We discussed it in our tumor board also, and I think in lieu of the very low response to chemotherapy, we offered her disc articulation. But ultimately, in this hospital being offering free services, she ended up there. So much so for that. But my question to Dr. Gilani was, I have seen patients with this procedure. Cosmesis is an issue, especially for females, when the shoulder just shrinks in minus the clavicle. What has been your experience in the follow-up? Thank you.
Sir, cosmesis is definitely an issue because the length of the clavicle is not very long, and when you turn that onto the humerus, you have a arm that is quite short from the normal length. So, but because I'm dealing with kids, so cosmetically, if they are wearing their shirt, it doesn't look that bad. If you can see in this patient, the cosmesis is not so bad. They have a good shoulder contour. The only real problem with the kids is that they don't have a very stable shoulder joint. They are able to do some of their chores, but and because I have transferred some soft tissue, mainly the pectoralis, onto the clavicle, and so there is some movement at the shoulder.
Dr. Suhail Hafiz has a question as well, I think.
I would just add a comment here. I think Gilani has very rightly used the word salvage. As I already highlighted, there are many techniques of reconstruction after doing a proximal humeral resection. It seems that Gilani seems to be getting carried away. He's trying to use this procedure in every case that comes across him. I would, for my younger colleagues, I would only add that you must know all the procedures. Every procedure which is written in the book or your teachers have shown you, but please be very careful in selecting it in that particular patient. Every patient is different, so a salvage procedure should not be translated into a definitive procedure for every patient. That's my only comment.
So very rightly said, sir. It's not up to the mark when you consider vascularized fibula or what I am doing, a frozen reimplantation. But most of my cases here that you see, I have shown 6 cases. All of them except this boy had good structural bone that I could have used for freezing. So only in this boy I did not use because it was fractured, and I was not sure if when I was curating when I will curate the tumor out, whether the bone will be of the same strength at that time. So definitely it's a salvage procedure, but you have to use it judiciously, not in every patient. Most of the patients that I have done have a more osteolytic component to their tumor, so using the same bone was not possible. And since I don't have a microvascular person available who can do a vascularized fibula on the word go, so I have to commit to these procedures.
So just a final question, Ali. When you turn this down, do you do some sort of suspension at the top? I might have missed it in your presentation, or do you just rely on because I can see that the clavicle is definitely not articulating with the acromion anymore. It's turned down. So how do you address that suspension at the top?
So when we are dissecting the clavicle, we have to preserve the soft tissue all along, and then especially at the lateral end, we have to leave a little bit more tissue so that the acromioclavicular ligaments are still intact. And then what I did not do it in the first 2 or 3 cases, but now what I'm doing is I'm using ethibond, which I can pass through the acromion and then through the clavicle. And because I'm dealing with pediatrics, so that pass is quite easy with a thick needle that the ethibond 3 suture has. So I just revamp it with an ethibond suture at the proximal end. So far I don't have any complication at that area.
Sure. We'll continue with the next talk. Yeah, is there a question or comment?
Yes, I have one question. Does the humeral end of clavicle grow in children, Dr. Ali?
Sir, Yes, sir. So far, my pediatric patients, in my pediatric patient, my follow-up is only about a year or year and 2 months. So I cannot really comment on that. But in the literature, what people have described is that the end does grow. And if you have not fixed it across the physis, then it may grow to some considerable length.
Thank you. Thank you very much.
Thank you so much, Ali. We'll now move on to the next talk, which is we talked about multiple methods of reconstruction. Now it is about how do we not reconstruct and we just suspend. It is not technically not no reconstruction. It is still called reconstruction using suspension arthroplasty. And I would invite Dr. Masood Umar, who is the head of the Department of Orthopedics at Aga Khan University Hospitals. He's also my mentor and my teacher. So I will invite him to speak on suspension arthroplasty after shoulder or proximal humeral resection. Dr. Masood, please.
Can you see and hear me, Athar?
Yes, we can see your slides. We do have a small echo from the previous slide. We do have a small echo. But as long as nobody else speaks while you are on, I think we should block. But as long as nobody else speaks while you are on, I think we should block.
All right. So, Bismillah ar-Rahman ar-Rahim. Sallu alayhi wa alayhi. So, I'll be taking you through some of my experience with the suspension, the shoulder reconstruction in a section. These are my mentors in orthopedic oncology. If people don't know, person on the left with me is Professor Annie King, and person on the right, extreme right, is Professor Umar.
Okay, now they are. We were just lagging behind. Now they are. We were just lagging behind a bit.
Can you hear me all well?
Yes.
Sir, can you hear me well? Okay, so these were my mentors. Let's go to the problem. So problem is stability of reconstruction. And that part of it was being alluded to by Dr. Zishan also, how he places his Merceline mesh, his Proline mesh rather, around the reconstruction in order to stabilize. As oncology surgeons, whenever we are dealing with proximal humerus or scapula or even proximal femur, our main challenge is stability of the reconstruction, whether we do it by biological means or by endoprosthetic reconstruction. And I would illustrate my problem with a case of a desmoplastic fibroma of the left proximal humerus. It's a 33-year-old lady which had a mass in the proximal humerus, and if you see the x-ray, that was her presenting x-ray. So hardly any upper 1/3 or 1/2 of the humerus left behind, hardly any head of the humerus left behind. Further x-rays showing the distal shaft intact. That was the MRI showing the distal less than half of the humerus shaft intact. So we did biopsy. It was a desmoplastic fibroma. We thought we can resect it, and since the MRI showed radial nerve adhesion, we excised the radial nerve with it, and this was the excised specimen, and this was the reconstruction, right? So I could find some muscles, and I could stabilize the shoulder prosthesis there, and patient spent significant amount of money undergoing this procedure, but she could afford at that time, and then we could manage this surgery. And so our surgery went reasonably well. We had clear margins, but look at what happened after 2 years. So this is the X-ray AP and lateral view after 2 years, and this is a 4-year follow-up. Now, minus the wrist drop, she had intact radial and ulnar nerve, but now she had significant problem of stability in the shoulder joint, and she had some elbow function also. She could do her household chores, but was very disturbed with this outcome. So this was a case of unstable reconstruction with a huge cost that was involved initially, with an unfavorable outcome, although she did have a functional hand with a wrist splint and a weak elbow, unhappy patient despite no recurrence. And also, very importantly, no money for revision surgery, which I offered to her. We can import a constrained prosthesis and do the revision surgery, but she just opted for no treatment and has not made a visit with me for last 4 years almost now. So I have no follow-up also on her. But this was just to highlight the problem which we face. I asked permission from Athar to show a video. Let me try that, how I do reconstruction now, and we can discuss the remaining cases in the case discussion format. Let me try if my video works. So Dr. Athar, can you see my screen?
Yes, we can see on screen. Yes, is it on video?
Can you hear the speaker? Can you hear the voice of the video?
Yes. Yes.
So I would stop here. It's a self-explanatory video. I would just stop and let the video run. Okay. 53 male. Now if you see the coronal images, the whole of the scapula is involved. If you see here, the chest wall as we move.
No, I think the screen that you shared is the. Sorry, the screen you have shared is the screen with the files on it. You probably need share.
Which is what?
Video.
Which is what on it?
Flare. So you can share and then select again. Select the window which has which is your app.
अभी कौन सी अभी आपको क्या नजर आ रहा है? सॉरी
अभी हमें वो फोल्डर नजर आ रहा है जिसमें आपकी वीडियो है.
So it's not loaded?
No, it's loaded, but it's probably loaded in the background. If you click on share screen again,
yeah,
and then you select where the video is playing.
Can you see it now?
Yes, now we can see the video.
Okay. So how do I run it now?
Just click play at the bottom, in the center.
वो involved, the muscles around the scapula are involved. It's not going into the arm. It's not. Is it okay now?
Yes.
Voice and video.
Yes.
Okay. Crossing the glenoid here. The humeral head is safe and sound. If you go to the axials on the other hand, you see this is the neurovascular brachial plexus area, which is safe. And as we come up, we are into the shoulder area. Here is the glenoid and the supraspinatus area, which is involved, but the humeral head is safe. So we're talking about a tumor which is purely involving the scapula on both sides, superior as well as inferior subscapularis side, and the neurovascular area is pretty free. So this is the plan that all of my patients get before surgery. My chief resident draws it out in his paper, and then we have it pasted on the wall right next inside the operating table. Okay, this is the patient now under anesthesia. He is in a left lateral position. As you see, we have done the prep, and I wanted to show you the swelling and the biopsy scar which is here, and this is the midline which must be exposed in such procedures, and we are in a floppy lateral position. Now we have marked, this was the biopsy site. We have drawn an ellipse around the biopsy site to stay clear, and this would roughly be our incision going parallel to the long axis of the body. This is the drawing of the whole scapula, the acromion and clavicle. We made the subcutaneous dissection. We have gone through the ellipse of the biopsy scar. That's the biopsy scar. The lower border of the scapula retracted. Yes. And this is the spine of the scapula, right? So we'll first move towards the rhomboid area, clear this side, lift the scapula up, get to the thoracic wall and lift it out. The last thing to be dissected will be the glenoid area. We are here after removal of the tumor. You see, this was the original skin wound with the biopsy wound excised here. That's the chest wall, and those are remnants of rhomboids, levator scapulae, trapezius, and that's the deltoid now, and that's the humeral head visible. This is the cut end of acromion, right here, right, and here is the cut end of the coracoid process, right. So that's the anatomy. This is latissimus, teres major, minor, and then the cuff muscles, subscapularis attaching here. So what we'll do is make a couple of drill holes in the humeral head, almost at right angles to each other. We'll make a hole in the acromion, and then we'll make a hole in the lateral end of the clavicle, which is this, and we'll try to go from here. So what we have now is a muscling tape. This is about 1.5 feet of tape. I've just removed the needle at the other end. And what we have now is an Arthrex fiber tape, which has a small thread at the end with a very strong tape in the middle, and then another needle at the end. So we will remove the needles, and we'll kind of augment these two tapes to form a sling for us, which will hold the humerus with the remaining acromion and clavicle. So I used a 2-0 straight proline needle to kind of railroad through the humeral head, both the muscling tape and the Arthrex fiber tape. And so this would effectively, virtually now hold my upper limb in a suspended manner. Now we have passed both the muscling tape and the Arthrex fiber tape through the humeral head, going transversely, coming out from behind the greater tuberosity, and then coming around here, going transversely into the humeral head, and then going through the osteotomized portion of the acromion, and then coming out here, both of them, and then going through the lateral end of clavicle, so that we now have two segments here as well as here. And the last step would be to tie them up so that the upper limb has a suspensory ligament. Now we have done the suspension, completed, and the humeral head is kind of mobile in all directions, along with the fractured acromion as well as the lateral end clavicle. And we'll show you that in the X-ray. Thank you. So that was the final X-ray of this patient with the humeral head suspended and coming back to stop share. Dr. Athar, I can move on to show my cases, or you want that to be done in the case discussion, whatever you decide?
Up to you. If you want to, you can show maybe a couple of cases here and then leave the rest for the case discussion.
Okay. So this was a 35-year-old gentleman to cut short, giant cell tumor of the scapula, no neurovascular compromise, did a biopsy, it was giant cell tumor, scapulectomy done in May 2014. This is post scapulectomy. I am sorry, can't do a full screen. What's wrong? Something.
Go to the bottom of your.
I'm sorry.
Go to the bottom of your.
Yeah, they're not moving out, so I can go to the full screen. Yes, perhaps now I can. Okay, much better. Take it. Okay, so this is suspension. Again, the same as I showed in my video. Now there is almost no acromion, also just the lateral end of clavicle holding on to the full weight of the upper limb. So we did this, but this is what happened in due course of time. There was laxity in our strength of the material, and the shoulder started to drop down. So we had, sorry, in a year's time go back and revise the reconstruction. This is what we achieved, and this is now November 2020, is doing well, and this is how he is now at a 7-year follow-up function of internal rotation. He can do his hair, he can wash his face, he can eat, he can take his hand to the back of his neck. He has problems in forward flexion and abduction, but he can do a very good internal rotation. So this is post scapulectomy. The whole upper limb is hanging from the lateral end of the clavicle. This was his scar. So relatively less stable construct, which is very low cost, reasonable function. Patient is happy. He was an engineer actually in interior sin somewhere, and still has no recurrence. That's the most important thing. So just to take you through pediatric problems of scapulectomy and reconstruction, we presented this in ISOLs a couple of years ago. I think Dr. Athar, you were there also in Kanazawa. I had 5 patients, 4 boys and 1 girl. All 4 had Ewing, 1 had osteo. The mean age was 11, mean follow-up was 19 months. We calculated the MSTS score, which was 19, and none of the patients died during the follow-up period. There was no METs, although the follow-up is very short. This we can skip that since I just wanted to show the case. So I'll just show one index case, 8-year-old male, right shoulder swelling, the scapula is involved, beg your pardon. So we biopsied, this is the MRI, turned out to be Ewing sarcoma. This is how we suspended him, right? So this was something, a radio opaque tape, I think Marceline tape. I've never used anything else, but now I'm using it combined with Arthrex tape as I showed in the video. But anyhow, this is the final reconstruction excised specimen, and most important was the function. This is, you can realize the voice now. So it shows we were together on some day. This is actually Hyderabad. A patient, when we went to Hyderabad, we called him there. He used to live in interior Sindh. And this is it, trying to give him some exercise, push-up. And he could do this with the suspensory thing, quite mobile in his actions. And lastly, to show the rotation, he could eat well, he could do his face, do his teeth, do his hair, and with the trick movement he could lift his shoulder forward. Internal rotation was good. He could wash the back of his neck also. And that was the scar. So I might as well finish now and we can discuss them later. This is another 56-year-old lady done few months ago, I think. Myxofibrosarcoma. Can skip again the plan on the board. So this was an axillary mass, scapular mass spreading onto the axilla and coming onto interior axilla. Again, patient in floppy lateral position, and so that we can access both front and back. So the excised specimen, again she had same problem. So this we have had in 2 patients now. the reconstruction was weak and there was too much distance between the acromion and the humeral head, which we had to revise and bring it back. So the very small portion of acromion and the lateral end of the clavicle. So she's very recently done 2 months follow-up, but she's holding on in this position. So the last, proximal humerus, as was my original topic, and so far I've been deviating from it. This was the post-op X-ray. So fibula with the remaining humerus, and then reconstruction with the acromion. And here you have a full acromion, so you don't need to disturb the lateral end of clavicle. 6 months and 1 year of 1 year and 8 months follow-up. So a boy from Lahore, osteosarcoma, proximal humerus. We did the same non-vascularized fibular grafting, which is shown here. Again, a sling method through the fibula, marceline tape going through and then going through the acromion like this and hanging like this. So 4-year follow-up of this patient. I don't have functional videos. We requested the family yesterday but could not get them. Anyhow, so just to conclude, suspensory reconstruction works both for scapulectomy and proximal humerus resection, and the cost benefit is huge. Just 20,000 rupees total, 22,000 rupees of implants, so as to say, being used against, as Dr. Zishan also showed, close to $500,000. Now it's almost more than $1 million for any implant, with very reasonable function and patient being satisfied. So as Dr. Haroon said, and I must complete and say that this is a great hobby, especially for oncology surgeons, especially for new residents who want to join this field. Besides physical stamina, you develop mental stamina, which you need a lot in these complex surgeries. Thank you very much. This is our great Nanga Parbat. Very early morning picture. See, you can see right up to the top. This is the southern face, which is the most deadliest face, or so as to say difficult face in the world. The northern face is much easier. I'm standing at 4,000 meters ground, and the peak is at 8,000 meters, so a 4 kilometers of wall, vertical wall going right up, although the camera cannot capture the verticality, but actually it is. Thank you for your attention.
Thank you so much, Dr. Masood Umar. For the sake of ergonomics of the session, plus the fact that Mr. Koskar is transiting from one location to another, case debates. So we can continue with the suspension versus prevascular fibula, and once Mr. Koskar joins, he can and then he can continue with his talk on scapular. So if you want to add more cases now, or we can have Major and Suhail, if he's talk about
this is all I had actually for today.
Yeah. So Suhail, over to you.
I'm sorry, I did not prepare a case for discussion. I think we had a discussion in which you said that you'll bring some cases.
No, I believe I said we can use cases. I think we've all seen cases. I think it will be quite useful to share for the sake of the audience, what indications and what sort of population you would, in your practice, select prevascularized fibula. We've spoken about younger patients. We've spoken about pediatric population doing well, relatively well with this technique. So I think we can look into that. So at the end, what I want to happen is for you, yourself and Dr. Masood to come up with sort of there's a lot of gray, but at least some sort of take-home message for the audience.
Right. If you allow me to say, I think we have seen different methods of reconstruction.
starting from
allow me to
no
say,
reconstruction.
I think
Starting from, we talked about vascular fibula, dissection arthrodesis, suspending to the clavicle. Then we cryosurgery. We talked about. We talked about clavicle turn down procedures. And of course, we talked about the megaprosthesis and composites. In our society, I think Dr. Zishan has showed a beautiful picture of the motorcycle, in which we must understand our society is very different from what we see in the West, where we have been trained. Number one, we see the tumor very late. It's not unusual for us to see a patient 1 year after he has been diagnosed. Some of the time the patient is diagnosed, you offer them surgery, then they go away. They go for non-medical treatment, Damdarud and all those things. And once they come very late. So we should actually be having a custom kind of a treatment for every patient. Every patient would be different. So for a young patient, in which we are going to do a proximal humeral resection, I would rather be going for a resection arthrodesis, considering that if the child is going to live longer, we have a stable, solid arthrodesis, and we can dissect the rotator cuff. We can also remove the deltoid as well, which is most of the time involved in these cases. If it is an older patient, for example, the patient is about 50 to 60 years old, the disease is early. If we can ensure that the rotator cuff is disease-free and some part of the deltoid is available, I would rather go for a prosthetic reconstruction. The use of clavicle turn down or the prosthesis which Zishan has recommended, a local spacer prosthesis, I would rather be using them in palliative settings. When there's nothing available or the disease is such that the life expectancy is less, say for example, 4 to 5 years, it's a metastatic disease, or the disease is likely to have a primary recurrence, then I would go into palliative settings. I think this we have to customize our treatment for each and every patient that come across. But most importantly, I would say one has to be very, very careful. He should be doing the surgery only if he can ensure a oncological clearance. Half-hearted surgery followed by reconstruction would probably not be a very good idea. Jay.
So if I can summarize, for younger patients, you have spoken about arthrodesis or rather for pediatric patients and young adults. And then if we go for older patients, and that with a preserved deltoid or rotator cuff, then we are talking about either EPR with anatomic or whatever the indication and the resection would be. And for older patients, we are talking about more palliative or for those with metastasis in a palliative setting, nail cement spacer. Now, Dr. Masood Umar, what will be your comments and your arguments to what will be your options in these?
सॉरी, वो मेरी टेबल पे सुबह से हलवा पूरी ला के रखी हुई, मैंने कहा ख़त्म कर लूँ, वो ठंडी हो गई मेरी बीवी बार बार आ रही, खा लो. So anyhow, coming back to the index topic, I think a line has to be drawn, which I have myself confused the topic. Line has to be drawn between proximal humerus reconstruction and post-scapulectomy reconstruction. Those are, I think, two very different entities. Yes. And I think your faculty, our faculty, Tim, Dr. Tim will talk about them in detail. So from my perspective, let us take an opinion poll about post-scapulectomy reconstruction. This is how I would do it. And this is how I indulged onto proximal humerus reconstruction, and I found it very successful. And my major worry, despite being a very good operating room, clean, everything, services, on infection is the biggest enemy that I face. I have faced over the last 20 years. Recurrence is not my enemy. Recurrence is everybody's enemy. And to a certain extent, as General Saab said, a index of the presentation when it is very late, and also an index of the response to chemotherapy, and of course some other indices also. So, but if you do a good job, at least you should be able to do a clear margin surgery. And as one point which I wanted to say in the morning, that if we don't have frozen section facilities, doing a limb salvage surgery is an even bigger challenge. So I can see people taking that challenge, which is very courageous, but I think there are major issues of operating in orthopedic oncology without frozen section facilities. Having said that, coming back to proximal humerus reconstruction, I don't know how many cases I've done, but must be close to 3 or 4 dozens of proximal humerus section in the last 15-20 years. But so far, I've always debated with General Saab that arthrodesis, I like free motion, and I have now shown free motion in some patients that I could get the follow-up in both pediatric as well as adults, and they are enjoying good motion. And you are also showing good motion in your videos, especially the younger adolescent patients, 3-4 of them that you showed, which were a very good function. Be it scapulothoracic, be it glenohumeral, doesn't matter, as long as patient can do their hair, patient can wash their face, and do their daily chores. So, so coming back to my argument is just to save him from an infection which is in the presence of big time metal. And to me, metal is a very big enemy of us oncology surgeons. That's what I practice or still practice. Post hemipelvectomy, I'm yet to put a metal there. All my patients are walking girdle stone. All of these patients have shown very functional, and they also develop with time a pseudo capsule, fibrous capsule around. As soon as their chemotherapy is finished, they develop that, and that brings some inherent stability. Although I've shown you 2 cases of revision also where the suspension got very long, but I was able to revise and reconstruct, and they are happy at 7-year follow-up. So I think, just to come back to my first point, let us discuss them separately: post scapulectomy reconstruction versus post proximal humerus reconstruction. Thank you very much.
Athar, may I like to add here? Masood has very rightly pointed out to the menace of infection that some of us face. My infection rate, I have infection. I've showed you, I think, 3 superficial and 2 deep infections. But I think we have improved this by using the lat all the time. A pedicle lat or a functional lat, which covers my reconstruction and my metal work. So if vascular tissue, which is bringing in the antibiotics, which is also giving in the system to the area, so the chances of infections are probably reduced. Of course, theater discipline and all those things are very, very vital. But if you have a vascular tissue covering your metalwork, this helps. One. Number 2, I forgot to mention other technique, the cryosurgery. I think it makes sense. And if you have intact bone, that means the bone is not ballooned out completely. That is, the architecture of the cortices is still there. Probably that is a very reasonable option in our environment, in addition to a replacement or a resection arthrodesis or hanging of the vascularized fibula or non-vascularized fibula.
I would still like to mention again that please do not get carried away. कि जन साहब resection arthrodesis करते हैं तो everybody should do a resection arthrodesis in every patient that comes across. Or for that matter, if it's a cryosurgery, not every patient is ready for a cryosurgery or for a tumor prosthesis or for Zishan's kind of a spacer as well. You have to customize according to your patient, according to the environment that you are in, and what the patient has presented to you. It's very good that this seminar has actually introduced many of the younger lot to different techniques. I would suggest look at them, study them, talk to the persons who are doing it routinely, and then translate that surgery into your particular patient in your environment. Ji.
Thank you so much, Jan Saab. I think, yeah, that was the whole idea when I was designing, the structure of this. The idea was, number one, to introduce people to the different options, including ourselves. Plus, it's not only customization to the patient, it's also about what you have learned and what you're comfortable with, what resources you have available, and then obviously having a shared decision making with the patient in the resources that you have, because ultimately the goals for all of us, whatever technique we use, is to get the patient best possible functional recovery. But in principle, we have to get rid of tumor primary as thank you so much. If there are any other comments by faculty as concluding remarks or their comments on this debate?
Dr. Athar, just a comment, Dr. Athar. There is a lot of talk about frozen sections since morning, and I think Dr. Masood has also pointed about doing a GCT by doing a frozen section and curettage, and he has pointed out in his last talk as well. I'm just asking from the faculty, because what my understanding is, I was looking at the literature about this, and there was one paper in which they looked at about 500 biopsies, and they compared it with the frozen section at the same time. So the result from the open biopsy, there was about 95% accuracy, and with the same frozen section, the accuracy rate was about 54%. So can we compare it, how the faculty experiences about the frozen section accuracy that we are getting perioperatively? Because I'm working in Stanmore, and we don't do routinely the frozen section here. It's good to have this luxury, but how much we can rely on this frozen section?
I think in Oxford, we also don't use frozen section. Very rarely, we when there's significant doubt, then frozen section is used. Mr. Koska, would you comment on that as well?
Yeah, I think that's right. I think just usually, if particularly in the pediatric population, if there's some doubt, then we'll do or if they're going to struggle with the biopsy. But usually, we try and get a definitive diagnosis before we go ahead with treatment. I
think Z was going to add something. Were you?
I think there is a confusion here. Probably the question was not diagnosis. The question is whether during surgery, how do you establish the margins? Whether you are clear or not. So for frozen, there's a definite role of frozen section while you are doing the wide local excision, but not for a diagnosis. For diagnosis, a pre-op, a true cut biopsy or an incisional biopsy is the correct method, but intraoperative clearance, you cannot establish without a frozen section. That's how I look at it. Z, you want something?
Just tell us whether the malignant cells are present or not. That's it. This is the purpose of frozen section.
So you need expertise, and you need the center to have, the pathologist to be confident about their frozen sections as well for you to utilize this tool, which is a very powerful tool. No doubts about that. Okay.
Z, you wanted to say something?
Yeah.
Yeah, so I agree with everything everyone said. It's a luxury if I can have. I was trained in Birmingham, where just like Stanmore and Oxford, you don't use a frozen section for your definitive surgery. Having said that, I may not have the exact figure, but in more than 95% of the cases, I'm still able to get clear margins on my definitive surgery. So my fresh frozen section is here, all the templating that I have done prior to the surgery. So I will memorize the MRI scan, all the cuts will be there. And as Dr. Masood Umar very nicely pointed out, he's got that chart for him. So he's planned out where he might be close or the steps that he needs to do. So what I do is almost similar, but in a slightly different fashion. I write things sometimes if there's a complex reconstruction. I write things in numerical order for me as to what I will need, where I will be doing this or that. Yes, it's a luxury if I have it available. I'm afraid I don't, but thankfully, the way I've been trained and what I do, I get good enough, decent results.
Yeah, thank you very much. Just to add on it, I spent 1 year in Singapore where we used to have this frozen section facility. And I hardly remember where we had done the resection as planning. And after the frozen section, we have to go back in and re-resect. So what's the experience of the faculty about getting the frozen section? And after your planned resection, how much time you have to go back and re-resect?
My experience is zero, so there you go.
Zero. I was trying to recall and scratch my brain. Never.
If I remember, I think I showed you one picture in which it was a Ewing sarcoma of the proximal humerus, and the MR scans showed me the margin. I resected 5 centimeter distal to it, took a frozen section from the distal margin, found it positive, removed another 3 centimeter, took another frozen section, found it positive, and then I had to remove the elbow as well. So just consider if this particular patient I had just done as per MRI, he would have had a recurrence. My all reconstruction, resection, arthrodesis, vascularized fibula would have gone in the bin. So I think it would not be harmful if you have the facilities of a frozen section to get the frozen section and be very, very sure and sleep nicely in the night that you've done a good job.
The only other thing, I do regularly is I make sure I have a very recent MRI scan before surgery within a week. Because the trouble is the amount of workload that we are exposed to, we might list a patient for surgery, but by the time their turn comes in, it might be 6 or 8 weeks later. So that's the only thing which I do, and I think that's something which saves me and my patients.
I think just to highlight for the juniors, Prof. Hafiz makes a very important point that, particularly in the case of Ewing's sarcoma, we must work off the pre-treatment MRI scans. So we can't, just because we've got a recent MRI scan that shows the tumor has receded, we must, particularly for Ewing's, work off those pre-neoadjuvant therapy scans to ensure that we get an adequate margin. Otherwise, as Prof. Hafiz says, we will always be caught out. Ewing's is a very dangerous condition.
I want to have a question, please. I want to know what's my faculty has experience. If you get a negative frozen section at the end of your section, you got the margin free. And what's the percentage of recurrence at the site of your resection after 6 months or after 8 months? Can anybody share his experience?
I'm not aware anyone specifically looked at that, Mumtaz. It's a very good question, but I've not seen any papers specifically on that.
Yeah, I don't think there are any papers. I just remember one case of chondrosarcoma recurrence from the distal femur in a young patient, and the case was very unusual because she had a low-grade chondrosarcoma on the background of an osteochondroma, which had been biopsied, and there were not by myself, but by a generalist, and there was significant soiling of the soft tissue with the cartilage cap. And I did a hemicortical resection reconstruction with negative margins. Obviously, I did frozen section because there was contamination. She had soft tissue later. So that only case that I remember, I utilized frozen section just because of the fact that it was contamination and did as wide a resection as I could. There was no recurrence in the bone. It was purely a soft tissue recurrence of the chondrosarcoma, possibly from previous contamination of the site, which was not resected and not picked up by the frozen section intraoperatively. But again, as I don't think there is any literature that has looked at this specifically.
What about your personal experience, our senior faculty? If you come across this problem, you get a margin-free frozen section, and later on get recurrence at that site.
I think it much depends upon the dissection and where you have taken the frozen section from. As we already highlighted, that one has to be very careful about the margin itself. What is the definition of a margin? So if you know that you have removed the next anatomical barrier to the disease progression, and then you have taken a frozen section beyond that margin, then the likely chances of having a recurrence is very less, until or unless there is a soiling that has been done intraoperatively. So the number of frozen sections that you have taken, at times I take 16 frozen sections all round. So depending upon where, how careful you were in your dissection and where you have taken your frozen section from. If you have, say, taken one frozen section from the area where you think it is closest to the tumor, and you have not regarded the rest of the circumference of the tumor, then there is a possibility that you could have a positive margins later on definitive histopathology. Umar,
we have mentioned about the margins, because when you read the when our residents read the general orthopedic textbooks, they always mention margins in terms of centimeters or millimeters, whereas we, the oncology surgeons, practice something completely differently. So like quite rightly, you mentioned earlier that in order to save an important structure such as a nerve, if you take the perineurium off, histologically, this is an anatomical barrier for us. It's a clear margin. So when you try and explain this to the novice or the generalist, they just look at you as if you've just landed from Mars. So that is something very important. And as Mr. Kosker mentioned very rightly, that's the same, the Ewing sarcoma is a completely different kettle of fish. So whenever dealing with Ewings, particularly around the pelvic region, you have to make sure that you read the pre-treatment tumor load. And that is why also now there's emerging evidence that if you are dealing with Ewing sarcoma of the pelvis, whether you should be irradiating them preoperatively before surgery. Yes, increasing your risk of infection, but reducing your risk of local recurrence, because getting margins clear within the pelvis is a difficult challenge for those of us who do pelvic surgery regularly. So it's a vast subject, very difficult, opening up a can of worms where there's no end.
Yeah, I think we've slightly deviated up from the main course, but these are all interesting topics to discuss. If you don't mind, I think in the interest of time, we should just progress to the next debate, which is on EPR reconstructions versus nail cement spaces. And again, the two faculty who would be joining us for this are Mr. Kosker and Dr. Zishan Khan. I mean, you can do this via case-based, you can show cases, and then talk about the pros and cons of the options and what would you use and in what setting.
Zishan, do you want to go first, or do you want me to go first?
Whatever you suggest.
All right. Well, I'll do that. I'll just show you a few slides, and then you go ahead. And can you see those okay, Arthur? Is that all right?
Yes, we can.
Yes.
Great. Okay, guys, thanks for your time. I'm very conscious we're slightly behind time, so I'll just talk for a few seconds about some of our experiences here in Oxford and the UK, and then really interested to follow on with what Zishan has to say in Peshawar. Zishan, I have very fond memories of Peshawar. I spent a month there and then travelled up to Skardu, so I know the area well. It's one of the most beautiful places on earth, so I'm very jealous of you.
You'll be very welcome.
Thank you very much. Well, as you know, guys, the upper limb is a challenge, and as I always tell my lower limb colleagues, actually this is much more difficult than the work they have to do. We have to deal with the brachial plexus. We have to try and preserve as much of it as we possibly can, and we have to make sure, using our significant expertise, we don't make it look like spaghetti, which we can see on the right. So all of the trainees who are listening, the brachial plexus is definitely something you need to know about and you need to understand, and you need to be able to reproduce it in the exam. And my top tip I always tell the trainees is never just learn how to draw the right or the left brachial plexus, because the examiner will watch for you to start drawing and then ask you to draw the opposite side. So just make sure you can draw both. And by the way, you can't do what one clever candidate did in the exam and say, oh, I'd like to draw it, and then turn the piece of paper over. So even with careful surgical technique, we still experience problems, and all of us on this faculty will have experienced this. This is just shows one of my cases, just a few months apart, absolutely meticulous closure, and just between January and April, the prosthesis has already tried to escape. And of course, the particular challenge, as we've said, about the shoulder is that, like a golf ball on a golf tee, the shoulder is inherently unstable. It has a huge range of motion through almost 360 degrees, which we need for day-to-day activity and to become the world-class cricketers that we all aspire to become. But the problem with that is that, unfortunately, that leads to inherent instability. So I just thought I'd show you just a couple of cases. We've seen a lot of fascinating cases this morning. This is one of mine, a 19-year-old boy with an aggressive tumor of the left proximal humerus. And as we can see, the X-ray always underestimates the size of the lesion. I was away at the time this happened, so my senior colleague, Professor Gibbons, took this case on, and he decided to resect the lesion. He got clear margins, and he just placed this as really as a temporary spacer. So you can see that even from the outset, although the tumor has been resected, unfortunately the shoulder is already dislocated even at the outset. And he then left it for me to revise. Now, the problem with this one was that almost all of the soft tissues had been completely resected, and therefore I wasn't really happy just to place a longer hemiarthroplasty into position. So we decided to go for a Bailey-Walker type option. Now, this type of constrained device gives you really good looking X-rays. To start with, this is the screw that goes into the glenoid. On that, there's a glenosphere into which the proximal humerus attaches on, and then a ring locks this into position. There's a hydroxyapatite collar below, but as I'll show you in the subsequent X-rays, the problem with this particular device is that the construct is simply too strong for the surrounding bone. So what happens usually is that you either get loosening here around the implant as you put it into the glenoid, or you get loosening down the bottom, whichever one decides to fail first. And sure enough, I was very pleased with my original X-rays, but just a few months later, here's the original, and here's the loosening that we can see already. So very quickly, this has started to execute a windscreen wiper effect. So this is starting to toggle backwards and forwards. Unfortunately, the hydroxyapatite collar hasn't had a chance to do its job, and already this is starting to loosen. Here's another of our younger patients. This is one that Arthur helped with, I think. Again, a very young patient. This was a very unusual case where the primary osteosarcoma was actually down the distal femur, and then he had a new lesion here in the proximal humerus. And you can see, unfortunately, this not only involves the proximal humerus itself, but also invading the joint, and therefore we decided to undertake an extra-articular resection. And in this particular case, we decided to think laterally, and we decided to turn the shoulder into a hip. So we used an acetabular cup here, uncemented acetabular cup, which we screwed into the acromion, put a long screw into the coracoid and one into the inferior scapula. And he actually got very good function for this. He sadly passed away about 3 years after the surgery, but for the remaining time he had left, he had really very good function. But really the point of this debate, and I think Zishan touched on it very, very nicely earlier, is that actually these kind of implants are extremely expensive. So in terms of the UK, this would cost probably about £15,000, about 20,000 US dollars. And therefore, really the point of this debate and what Atha asked me to really concentrate on is to think about whether actually the level of improved function that we get from this kind of very costly prosthesis is actually worth, whether we can justify that degree of spending. And we saw earlier very good results from Zishan with a very simple, inexpensive spacer device as opposed to this 30,000 US dollar implant. And wherever we're working in the world, all of us have, as surgeons, have a responsibility to ensure that what we're putting in is cost effective and justifiable. So if we are going to put something in, and really where I've got to in terms of my thinking in, and I actually sort of agree with everything that Zishan said, is that if you're going to put an implant in, you either need to put in something that's absolutely 2021, that's state of the art, that has really new features, which I'm going to show you on this slide, or you may as well not bother. Because if you're going to put in just a straightforward hemiarthroplasty, as we saw on the slides earlier, which, let's be honest, in itself will cost £10,000 or 14,000 US dollars, actually the improved function that you get between what Zishan was talking about and this kind of implant is actually very minimal. Now, this is the kind of design that I've been working on with Atha here in Oxford. This is printed from titanium. It's 3D printed, and we have these roughened surfaces to try, if possible, and reattach the deltoid, potentially the rotator cuff, if we can preserve it, the pectoralis, the latissimus dorsi, and then we have this new collar, which is a very clever titanium mixture with a pore size which is exactly matched to that of bone. And the idea of this with the augmented plate is that this will grow into the remaining humerus and will actually fully osteointegrate. We place a temporary screw across the humerus just while this is bedding into position. But this then allows us to reattach all of the soft tissues. And actually, I think if we're going to do it, then unless we're going to go for this really 21 style implant, then apart from that, there really is relatively little point. So what we're aiming for, what I'm trying to move the concept forward from is getting us away from this, where we have a conventional style implant. There's no ability to effectively reattach the soft tissues. Yes, the patient can do many of their day-to-day activities, but they don't have full abduction. They can't potentially lift or carry. They have an inherent risk of dislocation. To actually trying to think about moving to something like this, where just 3 months down the line, you can really appreciate and see the difference, where the soft tissues have been reattached. We've got this osseous integration, and actually they get really, really good function. So my argument in this debate, and I'll stop talking in a second, is that either you go for an implant which has all of these inherent abilities, that's this really brand new forward-thinking design, or actually you're really no further forward than you are with this. That's my side. Over to you, Zishan. We've lost your sound, Zishan.
You're still muted.
There you go. Can
There
you
we
all
go.
hear me now?
Yes.
Thank you very much, Mr. Kosker. Now, for the 14 years when I was in the UK, everything to me was metalwork. I was a full metal junkie, and that's what I confessed when I came back in 2016. And when my colleagues Athar, Dr. Masood, Professor Suhail Afisa, Dr. Badr, all of these folks used to talk about biological reconstruction, I just thought of, sort of think deep inside as they were all just being silly in a very nice way, because this is all what I was exposed to. And when I started working, I then realized the dilemmas and the situations that we experience in Pakistan. And quite rightly, like you said, any prosthesis, any implants that we put in, we have to justify it to ourselves first and then the patient later on. Very rightly, you mentioned or showed the picture of the Bailey Walker prosthesis. And we all know that it has been studied because of the high constraint. It does not have as good a function or a result as it should have. Although with that Stanmore prosthesis that you showed, we would expect the HA coated collar for the bone to integrate onto it, but it didn't. Anyhow, so why the nail cement spacer? This is what I get when I see a patient. And in my sort of NHS equivalent OPD, you'd be surprised that I get about 450 to 500 patients in every OPD, because our outpatients department is a walk-in department and we don't get pre-booked things. So they look at you as if you have a magic solution and you have to deal with them. So I get one go at them, because any revision surgery is going to cost them a hell of a lot. This is what we get. This is what I'm talking about. This is who we are. I'm just going to show you the total health budget. This is the total health budget that is spent. Now, the current government just claims that they have raised the bar for the health budget in the province that I work in KPK, from 124 billion Pakistani rupees to 142. Yes, we all agree it's a big jump. But if you look at the census of 2017, we are a nation of approximately 31 million people just in KPK. Now that means every single person gets 4,600 rupees. And the poor cheap nail cement spacer that I showed you, even that costs 19,000 rupees. So this is the dilemma that we face here. Whereas in the UK, the census in 2019 showed that the population is 68 million. I may be wrong, or I may just be right, that the total health budget is 269 billion rupees. And according to the World Bank data, it's around 4,615 US dollars. Still, that isn't enough. So reality versus expectation, this is what we get. Now, it is not uncommon for us to see patients like these. And in most of these instances, we have to, like I said, make these decisions for us. When we look at the proximal humerus, we've spent almost a lot of the afternoon talking about the optimum reconstruction option for the shoulder. But when you look at the literature, you just find that there is no definitive gold standard solution, because one size doesn't fit all. And if there was one, none of us would be having this discussion here. So we know that the choices depend on the health system that you work in, the age, the demand of the population, the prognosis, and the available expertise that you have. Now, all of us have discussed that the shoulder function is mainly based on the muscle, the amount of bone that we resect, and most importantly, the axillary nerve. Because if you resect the axillary nerve, even if you put in a reverse polarity shoulder, you're still going to have a spacer in place. So just to make clear, these are what we're comparing and not this. So it's a very common mode of reconstruction. Cost is the major issue. We've discussed that the neurovascular bundle and the muscles are important factors. They are readily available, the endoprosthesis. They can be custom or modular. For us in Pakistan, custom made is modular is easily available rather than customized. Cost again is an issue. They allow us to return to function rapidly and with low early complication rates, and patients can continue with their adjuvant therapy. They are expensive. There is an increasing complication with the passage of time. There can be complications, infection, and loosening. This is probably one of the biggest series from the Birmingham group looking at the proximal humerus endoprosthesis. So we're talking of the hemiarthroplasty, and they showed that around 86% of them will still be working nicely at 20 years, which is a very good result. Now we have to innovate, and we have to bring in frugal innovations that we've discussed. Now, the idea is not new, like I said. In infected arthroplasty, we do put in cement spacers. And this is where this idea came from. And this was the guy who showed me it. Some of you might know him. This is Lee Jiz, who's one of the leading oncology surgeons in the UK. And he asked me to come in and see a patient who he had revised for an infected shoulder arthroplasty. And the chap has had that cement spacer in for 7 years. And because he was pain-free, his infection was controlled, and he had reasonable function, the patient refused to have that revised. And he said, why don't you consider this when you go back to Pakistan? Because he knew my future plans and that this might be an option. When I came, I looked at it, and actually it wasn't something new. The Tata Memorial Group has been doing this for the lower limb cases, and they had shown good results at 7 to 10 years. However, they did say that these have to be revised at some point. So in a way, the advantage that you get is somehow you've converted that oncological problem into an orthopedic problem. So once you get on top of the oncological issue, that reconstruction can be dealt with later if and when the financial constraints allow. So this was one of the papers who looked at it. They had about 18 cases with a follow-up of 42 months. They showed good results, reasonable functional outcomes. This paper published in the Journal of Orthopaedic Surgery compared EPRs, and again, when I mention EPRs, hemiarthroplasties with cement spacers, and they showed an almost equal functional outcome when they both compared these two reconstruction techniques. However, as with all the oncology case series, the sample size was small. I think they had 12 on one and 8 in the other arm. This was the group from Aligarh University in India. They presented this study in ISOLS in Athens, and they showed the 34 cases. They, however, had one patient who had migration of the cement spacer and one aseptic losing. Again, not unheard of in these hemiarthroplasty type constructs, be it an endoprosthesis or a nail cement spacer. So like I said, I just thought initially that I was the inventor of something, but I did not reinvent the wheel. It had already been in place. Now, some people took it right up to the next level. I was just searching the literature last night, and I came across this case report where the authors did not like, or they may not have good masonry skills, and they could not construct a good femoral head. So instead, what they did was they made a 3D prostelac type of a thingy where they put in cement and reconstructed this implant. So I think it's probably not at all a bad idea, keeping in mind that you are waiting to clear your patient from that oncological issue. Again, it's something which has been practiced in arthroplasty first, then some people doing it in oncology. Why not in trauma? And we see that a lot of us are doing it in trauma as well. When we were discussing about the liquid nitrogen treatment, I was talking to one musculoskeletal surgeon from Portugal. And he said that he has been using it to treat osteomyelitis quite frequently. And for me, that was quite new. But then when you think about it, if it can kill tumor cells, why can't it kill bacteria? So anyhow, as I mentioned, they are both spacers. This is the case that I'm putting forward. For me, they are both, when they both act as spacers at no increased functional range of motion, the cost difference is humongous. And as I said earlier, that once you deal with the oncological issue, if they have passed the 5 to 7 years line, and hopefully if they are past that time, they are free of disease, then when the time allows and when the facility is available, it can be converted to any better endoprosthesis. So these are the sort of cases that I mentioned earlier on. Initially, I was doing them just for metastatic disease. Then I expanded on the indications and started doing them for the sort of non-responsive or poor response chemotherapy patients. I did mention this earlier in my talk, that if you take mechanical failure as the endpoint, I am yet to revise one, and my follow-up time is up to about 62 months now, from 4 to 62 months. Now, Mr. Kosker did show these, the proximal migration. We do have this problem, whether it's the endoprosthesis or the nail cement spacer. The proximal humeral migration is a problem, and eventually they will have some pain, and you may have to do something about it. So if you don't have a deltoid, if you don't have an axillary nerve, and if your bone resection is significant, then it is a spacer. This was a paper which was recently published in the Journal of Shoulder and Elbow Surgery from the Birmingham group, where they looked at these Bailey walkers. If you have a look closely, there are only 8 cases in there. And with a minimum only a follow-up of 3 years, they showed no revisions but good function. But we do know that they are severely constrained implants, and eventually they will fail. So this is what we were discussing about. So my take-home message is that this is an option, not the option. It has shown almost equal results when you compare it with shoulder hemiarthroplasty type endoprosthesis. So we have to compare apples with apples. That's the most important thing. Low mechanical failure rates, albeit with small series midterm data. It is a good option for guarded prognostic patients, metastatic disease, and in health-constrained health systems. The bottom line is the most important part. This is where I would use them, not in every patient. So I do call it, I ended by calling it a recycled Ferrari. It does the job, but it may not be one. Thank you.
Thank you so much, Z. That was a very nice talk, and I think we'll revisit the outcomes, the take-home messages from the previous debate, that no solution fits all. And I think the solution has to be tailor-made to the scenario, depending on the patient, the disease, your expertise, and your resources. I think what we've done at the end of these 2 debate sessions is presented the audience with options and the current arguments that revolve around what option you would select for your patient and your training and your scenario. Are there any other comments from the faculty? I think there is a masonry skill question by Dr. Faraz Anwar, who has asked, how do you make it into a perfect ball?
let's say, as a child, I used to play with a lot of Play-Doh. So I've been actually thinking about it when my residents work with me. They do ask if there is anything we could do to better the shape of the humeral head. Frankly speaking, bar the first 3-4 cases that we did, where even when I look back at those humeral heads, they look a bit funny. Now we've sort of developed a very good rounded head. And what I do is I sort of size the humeral head to the size of the native humeral head, or check the size of the other side. I have been thinking just recently if I could get, very cheap molds, plastic molds, where I can inject cement in and make that prosthesis. But when I look at those x-rays, they're reasonably round. They do a very good job. But I am constantly thinking of improving on this technique.
You're rolling it in your hands. You're making it in your hands.
Yes.
That's perfect. That's perfect.
I mean, I suppose the obvious thing to say as well, Zishan, is that, although the upper limb I think is technically more difficult than the lower limb, the one privilege that we do have is that for most people the upper limb is not a weight-bearing bone.
Yes.
And it means that we really can get away with a lot more shortcuts and compromises than we would be able to in the lower limb. So unless they're sort of regularly transmitting weight, which is usually just the elderly actually sort of trying to get up from a chair, or if they're trying to regularly push down to get out of the bath, then actually we don't usually put a huge amount of force through the shoulder. And really what patients care about is that their elbow is still working and that they've still got wrist and hand function. So actually, as long as you keep the electrical connection from the brachial plexus to the forearm and their hand, usually that's what they're happy with, actually.
Very true. I mean, taking it further on the same point, I mean, I'm quite confident now with the sort of 5 years and a bit of experience with about 30 plus cases to do it now for that select group of patients constantly in the upper limb. But I have so far not gathered confidence in putting it in a lower limb patient, because we know it's a weight bearing bone and we do know it will fail, where mechanically it may not fail in the upper limb.
Zishan, one little suggestion I'm keen for you to, you may have done it already, but for you to take on for 2022 is just as the cement is about to set, I wonder if you could try just creating some little holes through, like we saw on the implant, that you could perhaps reattach the deltoid and the rotator cuff to. Is that something you've tried already?
What I do, Mr. Kosker, is let me see if I can, whilst I'm talking, put up that video. Is I put a proline mesh all around the humeral head.
Yes, yeah.
And I reattach all the muscles onto that proline mesh. So it sort of gives me that anchorage that I need.
Yes, you did show that earlier, actually, yeah.
There you go. Let me just put that on. So it does work, but it may not be a bad idea if I use that as well.
What I've done for these knock 2 or 3 nail cement spaces that I've done, actually taking a leaf out of Zishan's page. So I've buried the suture before the cement went hard. So I've buried the mid portion of my ethibond sutures within the cement, and then that gives me the suture to stitch it back on. So I've got that, and then do the mesh on top. So I would bury 2 or 3 sutures mid-substance or mid-length into the wet cement, or just before it started to go hard, and then that gives me additional anchorage. Well, I don't know if it adds anything, but yeah, something.
Given an option, let me confess, I'll happily put in a good, fancy, sexy-looking prosthesis.
That's yeah, exactly.
We all like playing with those fancy toys, don't we?
Exactly.
Yeah.
Anyways, that brings us to the.
Hello, Dr. Zishan.
Yes, sir.
Can you hear me? Yeah.
Yes, we can.
Yes.
Yeah. You are doing wonderful, and you know, as you mentioned, that in Pakistan we people have a lot of problem, particularly regarding the patients, they can afford it or not afford it. But definitely there is a difference between a custom-made implant and a designed implant, and there is a difference of working as well. But there is I have used these endoprosthetic implant in 12, 13 patients here. Generally, they show very good results, but there is a complication, as you mentioned, that there is upward migration of the implant, and there could be a subluxation of the implant. So we have modified this with the use of fascia lata graft. We take the fascia lata graft. If you can allow me, I can show you with my. Is it possible that I can show you?
Please go ahead if you've got a slide to show.
Yeah. Share screen. So can you see this?
Yep.
Yes, like this is an example of the tumor,
chondrosarcoma that was removed, and the whole the partial deltoid resection was performed in this case, and the whole rotator cuff went with that. That was a big defect here. So that is the endoprosthesis which we are using, and it have its separate parts that we can manage the length and the defect. So that we put here. Now the issue is stability here in this area, and this area generally we cover with this facial autograft. We take the facial autograft and cover this area all around, and so it is like this. So this area that make the basically the glenohumeral joint, it is very well stabilized with this facial autograft. It is anchored anteriorly and posteriorly to the glenoid. So it does not allow it for upward migration, and as well as not allow us for subluxation. What additional we do, we perform the muscle attachment that are left behind, like latissimus dorsi or the pect major. These are mobilized and attached here in this area where these rotator cuff is attached. So it gives very excellent sort of stabilization, post-operative stabilization. If you can see this movie, you can see this movie.
Yeah.
This is post-operative. It is very good post-operative stabilization. And so then it is covered with the leftover muscles like this. So these muscles are transferred here. These are basically the leftover latissimus dorsi and leftover pect major muscles. They give very good stabilization and covered with the rest over muscles. So we have follow-up of around 3 to 4 years. And in these 3 to 4 years, none of the patient have any issue with the upward stabilization or subluxation, and movements are very good, and they have very reasonable movements like this. So that I wanted to share with you.
Very good. Very good.
So we end session 2. I know that we have a break built into the program now, but for the sake of time, plus I think Mr. Koska has to go and he's been waiting for quite some time. Thank you, Mr. Koska, for coming and joining us on Sunday. I know you had commitments today.
No problem.
However, we proceed to your talk, which is going to be about scapular resections and reconstructions and the Oxford experience, which we have had in the past with scapular resection.
Arthur, thank you very much, and a particular thanks for giving me the rarest and most difficult topic for the for the conference. But I'll try my best. And by the way, anyone who says that they've got vast experience of this, even the Americans, is not telling you the truth, because even in the specialist units, some of these procedures are still relatively rare. We'll be doing one, as you know, this coming Wednesday for a huge tumor, but this is really one of those anatomical areas to try and get the help of your colleagues, to try and get, if you've got them available, the plastic surgeons available, the vascular surgeons, to really try and do this as a team effort. Here at the Oxford Sarcoma Service, we've got a huge number of people with specialist interest. We're very lucky. We've got orthopedic oncologists, plastic surgeons, sarcoma oncologists, and for the case that we're doing on Wednesday, for example, we'll be involving the cardiothoracic surgeons as well, just to help us get an adequate chest wall resection. The scapula is a particularly unusual site for a primary malignant bone tumor. as we're all aware on this call, the proximal femur, the distal femur, and the proximal humerus are the commonest sites of disease. And the scapula really is one of those much more rare anatomical sites, like the foot and ankle and like the carpal bones. But it's still something we have to have in our repertoire. We have to be able to understand the regional anatomy, and we have to be able to deal with it safely and adequately. Now, if we're lucky, this is the kind of tumor that we'll get. This is really the sort of basic entry-level tumor that we may see in the involving the scapula. It's entirely contained. It's anatomically relatively easy to deal with. The joint itself is not particularly affected, although I would be concerned in this case. It does lie very close to the joint, but really this is the sort of easiest that we get. And actually, for most of us, we'll see a presentation which is much later, particularly in the pediatric population. These people, these families have frequently been reassured by the family doctor that this is just a normal growth and nothing to be concerned about. And often by the time we see them as orthopedic oncologists, unfortunately, the tumor is of a very substantial size. So this is where we really have to understand exactly what we're dealing with. We have to be very clear about our treatment plan and our surgical approach. And this really is starting to get towards the upper end, like the pelvis, of the kind of conditions that we're expected to treat. And then we may see the really very much more extensive and aggressive tumor. This is very similar to the case that we'll be doing on a Wednesday, where really all of the tissue margins have become obliterated. The tumor has crossed multiple anatomical planes that normally act as resistance to the tumor. And then, of course, the tumor starts to spread towards the chest wall and very quickly then invades the ribs and the pleural cavity. So we really need to think about these very carefully. These are really ones to plan very, very extensively and carefully in advance. And as one of the faculty said earlier, this is one of those tumors where you must have imaging within about 2 weeks of your surgery, because I myself have been caught out where I had an old MRI scan. The tumor had progressed significantly. And when I was in surgery, I found myself dealing with a much more extensive tumor than I was expecting. And then these are really the top end of the type of tumor. This is the scans of the patient we'll be trying to tackle later this week. So this is a telangiectatic osteosarcoma. It originated in the scapula, but you can see it's now crossed all boundaries. It's involving the brachial plexus, the subclavian vessels. It's pushed all those normal structures out of the way. And we really just have to think very carefully about how we're going to resect this to try and get an adequate margin. So just to take us back to some of the anatomy, the scapula, really the way to think about the scapula is that it acts as an origin for all of the key muscle structures to join the trunk to the upper limb. The scapula itself, as we all know from experience, is a very, very thin bone, often just 1 millimeter or 2 thick in the area of B, which condenses to be a much more solid structure to form that golf tee that we were talking about earlier, which is the condensation that forms the glenoid with which the humeral head will articulate. But really, absolutely everything about the scapula is about providing a wide surface area from which the muscles will originate, and they will then pass to their final destination, either in the neck, the spine, or across into the upper limb. And that's what really makes the scapula so very unique. Of course, the lower limb doesn't have a similar analog. This is really one of those very unique areas of anatomy, often poorly understood by medical students and trainees. But we really need to understand this if we're going to be able to adequately, safely, surgically resect it. And then, of course, the other thing to mention is the importance of the brachial plexus. The brachial plexus traveling underneath the mid shaft of the clavicle. The clavicle acts as a bony protection. to both the brachial plexus and the subclavian artery and the subclavian vein. And we need to think about whether or how much of the brachial plexus we'll be able to preserve as it goes down towards the elbow, the forearm, and the hand. Because really, as we said earlier, what these patients care about is that they will have some form of function after the resection, so they can use their elbow, forearm, and hand, which is, to get to the chase, how they're going to be able to keep themselves alive. It's great if they can wash and comb their hair, but actually what they really need to be able to do is to be able to eat, to be able to drink, to maintain personal hygiene. And therefore, whatever we can protect in the brachial plexus and preserve, allowing for, of course, for a tumor margin is really essential. One of the really interesting things that one of the faculty touched on earlier, which we don't understand very well, by the way, is why the major nerves act as such a good barrier to tumor. All of us as tumor oncologists will have found that the major nerves are remarkably resistant to tumor spread, and it's only usually in the very late stage of disease that the tumor will actually infiltrate into the nerves themselves. So some of the time we'll maybe take a slight compromise and we'll try and preserve, for example, those very major nerves, the median, radial, and ulnar nerves, just to try and strive for function, even if it does lie very close to the tumor itself. And then looking at it from the front, just to remind you, a real classic exam question. Here's the coracoid process. 9 structures either attached to or originate from the coracoid process. It's really a central anchoring point that the lower limb just does not have. And unfortunately, so often with these big tumor resections, we have to detach all of these structures. But then we have to think about how we're going to reconstruct them to try and give the patient function. So, for example, just a very simple, straightforward thing that we may be able to do, if the tumor doesn't involve the very tip of the coracoid, we may be able to perform a coracoid osteotomy to leave most of these attachments and then to try and perform some form of soft tissue reconstruction. Absolutely, I'm not saying that that applies to all cases, but it's something we just have to be thinking about anatomically so that we can try and give the patient as good a function as we possibly can. Looking at it from the top, so just to remind all of us here, the 4 muscles of the rotator cuff, we can see subscapularis lying anteriorly, supraspinatus, infraspinatus, and teres minor. Unfortunately, with total scapulectomy, almost all of this will have to be resected. But again, we need to understand and remember our relevant anatomy so that as we're doing the resections, we can think about what we might be able to preserve, but equally what margins we will have to take if indeed the entire specimen has to go. Just to remind us of the important anatomy around the posterior aspect of the scapula, those spaces that we all got asked about in the exams. So the quadrangular space defined by teres minor, the superior border of teres major, the lateral border of the long head of triceps, and the medial border of the humerus containing the posterior circumflex humeral artery and the axillary nerve to power the deltoid, the triangular interval formed by the lateral portion of the long head of triceps, the medial border of the humerus, and the inferior border of teres major containing the radial nerve and profunda brachii artery, and then the triangular space containing the circumflex scapular artery. So when we're resecting, again, for example, if we're doing a total scapulectomy, we need to think about, can we preserve, for example, the radial nerve? Can we move the radial nerve out of the dissection to still give us a safe surgical margin as we resect the scapula itself? And all of us will have seen these diagrams of the typical shoulder girdle resections, but actually with all of this, what we're really thinking about is not necessarily whether we're calling it a type 4 or a type 6, but we're actually thinking about the patient in front of us, the CT and the MRI scan, and about what will be a safe surgical margin as we do the resection. We must have a really clear plan as to what we're trying to achieve with each particular resection. And I would say to the audience here that perhaps never more with any of the areas that we resect, the anatomy here is absolutely crucial to a safe resection. We really need to know where those neurovascular structures lie. And frequently, as we're actually doing the resection, we'll encounter some of those vessels. And if we're to prevent catastrophic bleeding, because remember, for many of these tumors, the vessels will have become much enlarged and will become hypervascular, we need to be able to anticipate, like a good pilot flying through a storm, we must be able to anticipate those neurovascular structures before we actually get to them. So in terms of the practicalities, this is an area for a really large surgical excision. So we can either place the patient prone and do much of the work from the back, then flip them over and do it again from the front. Or my preferred technique is we'll actually have the patient lying on the side so that we can do a utilitarian incision coming right up the posterior border of the scapula, over the top of the humerus, and then down into the front so that we can sequentially detach those key structures that we looked at earlier. So here's the approach from the back. We see an extensile approach down the medial border of the scapula. We'll detach the levator scapulae in order, then the rhomboids, then rhomboid major, then the trapezius, and then the superior border of latissimus dorsi. That will then allow us to move forwards the medial border of the scapula and then start to progressively dissect underneath it against the thoracic wall. Now, for this case that we're doing on Wednesday, unfortunately, things are not so straightforward because the tumor is going into the chest wall. So that's when the cardiothoracic surgeons will actually go another layer deeper, and they'll be taking the lateral chest wall for us with a controlled pneumothorax so that we can then do a disarticulation of the humerus. Now, here's a diagram just to show you. Arthur asked me just to talk about thinking about endoprosthetic replacement. And really, we've looked at this very extensively now in Oxford and across the UK centres. And I would say to the audience really now that the only indication for actually replacing the scapula to actually put an endoprosthesis in is where you're also having to do an extensive resection of the proximal humerus as well. If you're just putting it in as a spacer, I would argue that you don't actually need to do it. And I'll just show you some evidence to support that. If, however, you are thinking about taking the proximal humerus as well for those very big resections, then it may be more valid to think about putting in an endoprosthesis because you need an articulation between the scapula and the humerus itself. But these are incredibly expensive reconstructions. These are in the order of 30 to 40,000 US dollars. And for any health system, even here in the UK, that's a phenomenal financial burden and may not be borne out by an improved functional outcome. So I think this kind of implant is used to really very, very rarely. I've only put in about a single figure number of these in my career, and I would counsel the participants that this should be a very, very rare indication. We looked at the experience of total and partial scapulectomy. I won't make you read all the slide. Even with our experience, we only had very, very small numbers. We followed them up, and the key takeaway point is that there was no significant difference in the range of motion between those patients with an endoprosthetic replacement and those without. This is not an implant that's worth putting in for financial reasons unless there are very specific indications, which I showed you earlier. It's not just the Oxford experience. This is the Japanese experience as well. And again, they looked at a very small number of patients, just 7 in their group. But again, no significant difference in function between just the soft tissue reconstruction and the prosthetic group. And the reason for that, by the way, is that what actually happens when you go back and look at these cases histologically is that the muscles on the front, for example, subscapularis, the muscles at the back, for example, latissimus dorsi and the rhomboids, actually form a fibrous layer in between the two. They fuse effectively and they essentially form the old scapula themselves anyway. So by putting in a piece of metal here, you really don't add anything to the party. And as we discussed earlier, what patients really want is some form of cosmesis. If possible, they want a square shoulder that they can hang a shirt off, that they can look at sort of reasonably from the front to wear a shirt, and they can appear in public even if they haven't got an arm. So in conclusion, I would say this is a difficult anatomical area. It's one not to be doing on your own. Bring your colleagues in, involve colleagues from other specialities, and that by doing this as a team approach, hopefully we can get a reasonable result. Arthur, thank you very much.
Thank you so much, Mr. Koska. Thank you for coming out on Sunday and staying till mid-afternoon now here. Any questions for Mr. Koska? As I can appreciate that Mr. Koska needs to leave the session and will not wait for the end of the session from participants or faculty.
Stun them into silence, Arthur, sorry.
Well, if I may just carry on the same note. Scapular prosthesis, quite rightly, like Mr. Kosker has showed, that there are very small number of patients or very small case series, like I showed the distal radius EPR case series. And the reason why most of the people don't use them is because of the number of complications and the issues that you deal with. And at what cost? I mean, financial costs put aside, do we add anything in terms of function? I think it was the 2016 or 17 ISOLS meeting that we presented the work from Birmingham on, again on only 6 or 7 cases. And the results were, I mean, just short of appalling, really. I've done probably about 10, 12 scapulectomies, and I always do suspensory reconstructions exactly in the same fashion as Dr. Masood Umar said. And the patients do have a reasonably rounded shoulder, not completely squared off. And they're generally happy because they have good function at the elbow and hand. The most important thing, as Tom alluded to, is to preserve the neurovascular bundle to allow them to have a functioning elbow and hand. So yes, we do like these prostheses. We do like good x-rays. We do want to show them off in meetings, but we have to be very sensible in terms of what added advantage we're offering to the patient. Have a look at the pelvic endoprosthesis. I mean, so many customized prostheses and all that. If you have a look at the literature, I mean, do we really add much onto it? It's a matter of debate and a scenario yet to be resolved. But we have to be justifying it to our patients and ourselves whenever we put anything in our patient.
Absolutely. Yeah, thank you so much, Mr. Koska, once again. Good to have you on the program. And yeah.
Thanks for having me, Arthur. Much appreciated. Thank you.
I think Professor Hafiz has got a question or comment.
Tom, wonderful presentation. What percentage of patients you were able to do a partial scapulectomy?
Yeah, no, very good question.
Saving the glenoid.
Yeah, I didn't touch on that because Arthur asked me to cover total. But yeah, I mean, I think you're right. I think where possible, if you can preserve the glenoid and therefore give the patient a normal shoulder, the part that always amazes me, which I've never understood anatomically, is that you can resect sort of 90% of the shoulder and just leave a very small section of the glenoid, which you think wouldn't have any inherent stability, and yet it seems to function as a reasonably normal shoulder. I still don't understand that. It must be because of the number of ligamentous attachments around the glenoid and the coracoid that just hold it in position. It's remarkable.
We just did a couple of months back for a recurrent GCT where we had this partial scapulectomy through the scapular spine, and we were able to save on the top of the scapular spine with the supraspinatus and the deltoid and the glenoid, and the cut was just inferior to the glenoid. And at the end, this chap has got a very good function, and he's got a full range of motion. There is a prominence of the clavicle when he does the subduction, prominence of the suprascapular spine, like is a winging of the scapula. But I mean, he has got a very reasonable function. A good range.
Yeah. Arthur, I'm going to have to peel off, but thank you very much for having me, and an absolutely wonderful conference. Really very impressed. Thank you.
Thank you so much, Mr. Kos, for coming in.
Take care.
Bye-bye. Bye now. So we missed the break. Do we agree to have a break, or there's 2 more talks to go, and then we can complete this?
I'm already on my break.
So yeah, I think what I suggest is we're significantly over time, and the faculty is also, I think tired, and I'm sure the participants are as well. So because this is a virtual setting, all of us can have their breaks and teas and coffees and in Pakistan it's past lunchtime. So I think in the interest of time we should just crack on. I think we should. Yeah, I think we should. So for the next talk, I would like to invite Dr. Brigadier Sayyid Faraz Anwar, who will talk about forequarter amputations and what options we have available for prosthetic replacements once we've done this radical, massive resection. Dr. Faraz works currently. I thought he was in CMH Pindi, but just a couple of days ago, I learned he's back to Karachi. Welcome back to Karachi, although I'm not there to welcome you myself. But good to have you.
Thank you.
Faraz. Please, if you could share your screen and continue with your talk.
All right. So am I being shared?
Yes, we can see your screen.
Yes, sir. Go ahead.
Okay. Thank you very much, Sir Masood, for giving me this opportunity to learn and to talk subsequently. I'm back at PNS Shifa. I hope most of you have seen this area. So, rare procedure and difficult to talk on. Anyways, forequarter amputation or interscapular thoracic amputation is a major amputation procedure, and it involves the entire extremity, the scapula, and the lateral part of the clavicle. It was first performed in 1808 for treating a bullet wound. And then it was first used to treat upper extremity malignancy in 1836. As the research progressed, the tumor response got very well to radiation therapy and chemotherapy. And therefore, this procedure was replaced with limb-sparing procedures and reconstruction with endoprosthetic reconstructions. And the endoprosthetic reconstructions are now done in 95% of the patients. Well, if not endoprosthetic, then there are different ways, like vascularized fibula or turn down of the clavicle. The upper extremity and scapula are attached to the upper torso and chest wall by soft tissue elements. We have seen in the previous talk as well. The rhomboids, levator scapulae, trapezius, pec major and minor, the latissimus dorsi, teres major, and serratus anterior muscles. And of course, there's a single bone, which is clavicle. So once you do this procedure, these muscles have to be transected. The rotator cuff muscles, which consist of the supraspinatus, infraspinatus, subscapularis, and teres minor, which aid in humeral head, are removed. So a very, briefly, the anatomy which is displayed from the posterior side. These are the muscles which you need to transect. levator scapulae, rhomboid major, minor, and this is from the front. Just a small and a quick revision of the anatomy of this area. So the most significant structures that must be evaluated prior to surgery are the axillary and brachial vessels and the adjacent infraclavicular portion of the brachial plexus. So the axillary vessels are routinely evaluated in order to determine the segment that can be safely transected and ligated, because large tumors may come close to the thoracic outlet. So you can have an angiography or you can have an MRI. These are the vessels and the plexus just shown in the slide. And this is what is done in the four quarters: the limb, the scapula, and part of the clavicle. Sorry for the busy slide, but these are the indications which are there. Unresectable high-grade osteosarcoma or any other high-grade tumor of the proximal humerus or the scapula. Axillary soft tissue sarcomas involving the brachial plexus. You can also go for palliation of intractable pain or tumor fungation with a rapidly growing tumor. Recurrent bone or soft tissue sarcomas following a failed limb sparing procedures. And some radiation-induced sarcomas of the shoulder girdle. Recurrent breast carcinoma involving the brachial plexus. And a pathological fracture through high-grade sarcoma, especially if there's a poor response to the induction chemotherapy. When tumor extends to the chest wall, it generally forms a contraindication, but sometimes you can excise a part of the chest wall. And when the tumor extends to the paraspinal and posterior triangle of the neck structures, because in this situation, negative margins may not be obtained if you're doing a curative resection. Top of the line investigations, of course, after X-rays are the CT and MRI, and they determine the extent of local regional disease and thus helps in deciding margins of excision. So angiography gives you the anatomic position of the axillary and brachial vessels, the involvement by the tumor, and what will be the best level of resection. This is usually done for the brachial plexus because it's simple and accurate method of determining brachial plexus involvement. A brachial venogram will show complete obstruction of the main axillary veins when tumor is infiltrating the brachial plexus, whereas a tumor adjacent to but not infiltrating the plexus will show venous patency and displacement. Of course, we have to go for a biopsy before such a big operation, and it should follow the incision for a 4-quarter amputation so that it can be easily removed with the tumor. It's preferable not to contaminate the larger posterior flap, deltopectoral interval, and the suprascapular area, and the pec muscle. Large proximal humeral tumors should be biopsied through the anterior delta because you're removing it with the tumor. And scapular tumors should be biopsied along the axillary border, which is in line with the amputation incisions. Very briefly, the surgical guidelines. The anterior approach has been the preferred technique of exploration of the axillary vessels and brachial plexus. These are the slides, not my slides. I have borrowed them from Professor Masood. A 45-year male farmer, and he had no comorbids. There was no family history of cancers, and there was swelling of the right upper arm of 18 months duration, which gradually increased in size, and he had occasional pain. It was diagnosed as chondrosarcoma. The swelling was around 15 by 10 centimeters. It was hard, non-tender, fixed one-line structures. It wasn't mobile, and the skin over it was intact. The lymph nodes were not palpable. Elbow and shoulder RM was full, and neurovascular status was intact. So this was the case picture. These were the investigations which were done on these patients. And this was the pre-op X-ray for the chondrosarcoma. This is the environment. So this was done quite some time before. These are the anterior incisions. These are the posterior incisions going over the scapula and closures. This is how it looks like in a picture. The anterior incisions, the posterior incisions going over the body of the scapula down to the tip or the angle. And this is the end result. This was another case, osteogenic sarcoma. And you can see that this is the end result. There were mets over here in the axilla, and therefore 4-quarter amputation was planned. So briefly, with a 4-quarter amputation, a prosthetic system consists of a socket, naturally for the scapula and clavicle, which could include ribs or upper portions of the trunk, a prosthetic shoulder joint, a prosthetic elbow joint, a socket at the wrist, and a terminal device. Several prosthetic solutions are available. They are passive, which gives aesthetic appearances, cosmetic, it's used for cosmetic purposes, body-powered, myoelectric, hybrid systems, and activity-specific systems. Now, this is the passive prosthesis. So you can have different shades, and the artist can make beautiful wrinkle lines on it to give you good aesthetics. This is one of our patients at FIRM. So cable operated, it's body operated prosthetics, which make use of the cables, pulleys, and hooks to increase the functionality of the prosthesis. And these prosthetics are harnessed to a patient and are activated by the remaining mobility of the limb stump, the muscles of the upper body, and the individual's other limb. They're all connected with a cable. This is also made in our setup in FIRM. One of my colleagues from FIRM has told me. And then we have the externally operated myoelectric, and these prosthetics use microprocessors to amplify the EMG signals from the patient's muscles, allowing to control the wrist or the hand. So this is the advanced form. The volitional decision to contract a muscle causes a nerve to stimulate a muscle, and that will subsequently depolarize that muscle. Now, this depolarization of muscle leads to EMG signals that can be detected and processed by the prosthesis to allow the wearer a natural or a near natural range of motion. So these prosthetics can combine the natural look of passive prosthetics with a high degree of functionality and control, and are therefore some of the most popular. Of course, they're not available in our setup because of the cost going beyond 2 crores or something, one of my colleagues has told me. Since we don't have them, we have to take pictures from the West. And they have, the scientists have developed sensory technology for a robotic prosthetic arm that detects signals from the nerves in the spinal cord. So now, gradually, these things are becoming, more advanced. The complications, of course, you can have infection, but this is of significance, and that is the phantom pain. To control this phantom pain, it is recommended that you put in an epineural catheter
into the axillary sheath at the time of surgery and infuse 0.52% Mercaine for 3 to 5 days post-operatively. So this also decreases the pain in the post-operative period, and it will also decrease late causalgia syndromes. So this was a brief talk on 4-quarter amputation. Although 4-quarter amputation is really performed today, it can be a life-saving procedure as well as providing a long-term palliative benefit. So thank you.
Thanks so much, Brigadier Faraz. Yes, indeed, a rare surgery with an even more difficult challenge after the resection of what to give the patient, and they are usually left with significant functional and cosmetic compromise. Any questions or comments?
Athar, can I say a few words?
Yes, please.
Let me see if I can share my screen. I just wanted to show you. This is, can you see my screen, all of you?
Yes.
So
yes, we can.
This is an article one of my residents has submitted for publication. I think, if I'm not wrong, we've got about 12 or 15 patients or something. Yes. Funny enough, like Faraz said, these are rare operations. In the 16 months that I was in Birmingham, I assisted one and I did one. And in the last 6 years, I've done about these many patients. I do a combined anterior-posterior approach, slightly different. What I wanted to show was that if you have a look at my results, let me just see if I can drag it here. Of the 13 patients that we operated on, this is up until 2018. 1, 2, 3, 4, 5, 6, 7. 7 of them are deceased by now. Now, when you're doing a 4-quarter amputation, that essentially means a very large size tumor. And a very large size tumor means we know that bigger the size of the tumor, poor the prognosis. This is how they look like. This is one of the patients. So in my hands, or in my experience that I have so far, more often than not, if you have a look at some of these pre-op radiographs, this is more for, local control of the disease rather than life-saving. It's unfortunate because by the time we see them, they are enlarged so much that we can't do much for them. So it's a necessary skill to have. I showed you a few pictures in the last debate that we had of that chap with the huge scapular lesion. And when that guy walked into my OPD, what I said to him was to take off that sack that he had on his shoulder and sit comfortably. He looked at me in so much of disgust, as if I was making fun of him. And when he took off his chadar, or the shirt, I then realized that it was actually a tumor, not a sack that he's put on his shoulder. So these are the sizes of the lesions that we see. So in my experience so far, since 2018, I think I would have probably done about 6 or 8 more of these cases. They are, in a way, they are straightforward. It literally takes about 60 to 70 minutes. They don't take that long. But in my hands, or in my experience, they are more for palliation rather than for disease control. And my results speak for them. So I don't know. I mean, I've forgotten when we wrote this article. The literature is about the same. So whenever you're going for an amputation, the results are poor. So this is another message that we need to deliver to our junior colleagues, because a lot of the generalists think that the only option is an amputation, and an amputation gives you better results in comparison to limb salvage. This isn't true, actually. An amputation means larger size tumor, poor prognosis. This is what I wanted to allude to by showing you this and mentioning 4-quarter amputations.
Yeah, thank you. See, I think a very important point to bring out also in this discussion is that a lot of journalists think that limb salvage has got poorer prognosis, which is not the case. I think when you are opting for an amputation, a number one amputation is not the failure of a limb salvage surgery. It is the case and the disease that determines the need for the surgical intervention that you are going to do. And most of the girdle tumors, whether it is lower limb girdle tumors or upper limb girdle tumors, do have relatively significantly guarded prognosis. We know from the caseloads we see. They develop metastasis early, they develop local recurrence early, and they have got very limited disease-specific survival in the long term. Yes, very valid point. Thank you for bringing that out. So we will now go on to the last. If there are no further comments or questions from faculty, we would go to the last talk of the session. So this is obviously a general topic, but it is very, very important, I think, for all of us who are aspiring to establish sarcoma services as units, as dedicated units in our country, which is the role of nurses and a dedicated sarcoma team and how it functions. So for this particular reason, I have asked Dr. Raja Bhaskar, who's an orthopedic surgeon in Ganga Hospital in Bangalore, India, and he's currently working in university hospitals. Very versed researcher, very widely published, the special interest in research. He's currently the Girdlestone Fellow at the Oxford University, and he has recently worked with and published his work on role of sarcoma care nurses and how that can help develop services. Obviously, this is an example from a developed country, but we can possibly take a lead from his from the work here and try and reproduce some bits of that back home in our relatively underdeveloped countries. Thank you, Dr. Raja, for joining us.
Thank you so much, Arthur. And I'll share my screen now. And yeah, it's visible, right?
Yes, it is.
Perfect. Yeah, at the outset, I would really like to thank Pakistan Orthopaedic Association and especially Arthur Siddiqui for giving me this opportunity to talk on slightly, I would say, a non-academic tumor topic, but it's very relevant. And the exact relevance of this, I understood only after I came to the UK. So I've been in the UK for about a year and a half. And though, you know, we speak on many different aspects, and most of the meetings, most of the forums nowadays focus on tumors, outcomes, but the main service care providers, how they give an exact effect on the outcomes and how they are effective, we will be talking about this. So my talk will be for 10 minutes and I will touch outlines. And as Arthur was saying, I've structured my talk where, you know, what is happening in the developed countries like UK and how we can take it to countries like India and Pakistan to give better care outcomes. So I'm the Girdlestone Scholar in the University of Oxford and I work in the Nuffield Orthopaedic Center. And I will be talking on the role of specialist nurses in delivering effective care in tertiary sarcoma center. So let us start with a small case example. So as Dr. Zishan was telling, you know, in a very busy clinic, especially back home, on maybe a Monday morning at 10 o'clock, you face this case where you get a young 6-year-old girl whose parents are not exactly literate, and they come in, and this is like a spot diagnosis for any orthopedic trainee or especially a tumor surgeon. This is an osteosarcoma with significant amount of, you know, Codman's triangle and all the periosteal reaction. This is a spot diagnosis. So now comes the next question. Especially in a very busy clinic where you have about 200 patients back home, the management plan, the treatment, the prognosis, this is a huge spectrum, and it just does not involve like, you know, a simple arthritis or a simple fracture. So much of counseling, so much of effective, so much of different points have to be emphasized. We will revisit this slide once again in our presentation. So before we start this talk, I would like, if today from one point from my talk, if all of you would like to actually take back, is This Aravind eye care system, this is actually an eye care service provider. Anyone who's an ophthalmologist in the world will know them. So it was started by Dr. G. Venkataswamy in the age of 66. So he was in the army, he came out, and then he started this, where his only goal was, how do you do high quality eye care to India's poor? Like what they said is, in a population of 1.3 billion, there are nearly 50 million who have no access to healthcare. So how do you treat them? And though this was more for ophthalmology and for eye, this very important concept which he brought about was McDonaldization of, of healthcare, of McDonaldization of eye care. So what he said was, McDonald's was started in the US with one aim of giving fast food for people who were on the move. But how could McDonald's make it the whole world, whether you go to a McDonald's in London or in Karachi or in Delhi or in Melbourne, it's the same standard. How can they provide it? And, Google was very grateful, and they put him once as a doodle on his birthday. So he gives these three very important points: affordability, availability, accessibility, the 3 A's of any healthcare system. You may be the best surgeon, you may have the best skills, you may have the best medicines, but any healthcare system which is not affordable, not readily available, and not readily accessible, especially in the developing world, it is bound to fail, or patients cannot get, the main person, the patient cannot get benefited by it. So now let us take the scenario of the NHS in the UK and Pakistan. So the healthcare system of Pakistan is similar to India and any Asian healthcare system, where majority of the payers are from the public, and in the public hospitals, it is really packed, and private hospitals also play a very important part in delivering adequate healthcare. Now, if we take the 3 A's, affordability, there's no comparison. As we all know, NHS completely government funded. There is cost is one of the last constraints which they have, and that is the last concern for them also. So that is a gray area for us to discuss. Whereas availability and accessibility, any healthcare system in the world, whether you're in Australia, whether you're in Africa, Asia, availability and accessibility has to be readily available. So why is musculoskeletal sarcoma different from any other sarcoma? Like, suppose breast cancer or colon cancer or lung cancer, they are all site specific. And like breast cancer, they are age specific, gender specific. Sarcoma is completely different. It's not site specific, it's not age specific, it's not gender specific, and it's extremely rare. So for example, if you see 100 cases in any cancer clinic, only 1 will be a sarcoma, whereas 35 will be breast, 15 will be lung. This is how the general spectrum of epidemiology is. And in a tertiary center, especially taking into relevance to the UK, these are the healthcare professionals who attend the MDT. It's an orthopedic surgeon, a radiologist, medical oncologist, a radiation oncologist. And as we said, because it's not site specific and age specific, there are these extended members. So there are nearly 7 essential core specialties who are all involved to give good musculoskeletal sarcoma care. So coming back to this clinical scenario case, which we had discussed before, this 6-year-old girl diagnosed as an osteosarcoma. Now, as we all know, she will need neoadjuvant chemotherapy, staging, then surgery, follow-up for about 10 years. Now, this is a huge cycle. So the management plan for her will include, like, especially this is in relevance with the UK. Once you get referred by the GP, you will need a biopsy. Following that, you will need staging investigations to see if the tumor is there anywhere else. You start neoadjuvant therapy, which takes about 4 cycles, then re-image her, plan for surgery, start adjuvant therapy, 3 essential MDT discussions. So by the time her initial treatment and the most important treatment is over, we are finishing nearly 30 weeks. And across this most important span is you have 14 hospital consultations involving 4 different specialties and 4 different consultants, and 48 admission days across 8 time points. And any delay in any part of this, you get a significant detrimental effect. And then following this, you need to have a 10 years follow-up at least to say that, the patient is in remission and disease-free. Now, such a huge planning thing, it's not possible by the surgeon or by the clinician, and especially in our place where we have lots of patients. So this is where exactly the role of a specialist nurse who is trained comes in. So if you see the challenges, as I said, regarding the long time period and all the different time points involved, these three aspects, counseling, scheduling treatment, and this aspect of decompression, like first, when you meet the patient in the clinic and when you tell them about osteosarcoma, it's like a time bomb or a nuclear bomb on the entire family. They're completely devastated. And back home, like for us in our cultures, a boy or a girl, especially girls, if they get this disease, it also affects their marriage prospects. There are so many questions which they have. Parents have to plan for the treatment. So you need, as what they say in the American Journal of Oncology, decompression time. Decompression time is very important, where you may have a 10-minute, 15-minute consultation, but then you need this decompression time. And this is also taken care by the nurses, where they have an extended session and it involves a lot of counseling. So in any system, you may have an oncologist, a radiologist, a pathologist, a physiotherapist, and an orthopedic surgeon. They form the main chief clinicians for any sarcoma service, but a specialist sarcoma nurse is where she gets involved in every different point, and they form the glue among the entire system. So in our healthcare tertiary center, we have the support of the Macmillan Cancer Group, where there are 3 specialist nurses. So how do they help us? The first thing is assisting in collaborative care. They come and sit with every consultation. They follow up the patient on their own. And during, as I said, the time of decompression after the diagnosis, they are also joined at diagnosis. It also helps in the legal aspect, and they also give their opinion. So they are part of the entire treatment planning, and they become a single point of contact. Now, the nurse-led clinics, once you finish, the main first 2 years of your treatment, every single time, the nurse who is trained, they can just do the staging, chest x-rays, see the patient, do a local examination. And as per statistics in our unit, in 2019, 351 nurse-led clinics of follow-up patients were done. And even during COVID, the number never came down, because cancer service was essential and it continued without any hindrance. So this is the exact effect, having a specialist trained sarcoma nurse has in your unit. Now, coming back to the Arvind Eye Care system. So today they are the largest eye care provider in the whole world. It's in South India. They have now, so how did they do? If you see the slide, they exactly, the founder, he says, you cannot train so many doctors. You have to empower people. And as we said, availability and accessibility, they brought in nurses at every single point of contact. So first day the patient sees a nurse, the consultant only talks about cataract surgery for 10 minutes. Every single thing, including the dressing, including the follow-up, including the complications, train nurses, and that's how they could become one of the most flag bearers in ophthalmology. So if we again come back, accessibility and availability, that is where the nurses really give their input. So more than that, empowerment of healthcare professional and owning responsibility. You have collective responsibility, collective wisdom, and they become the pillars where they give you a continuation of care with the patient and also form a bridge between the clinician and the treating family. So, as I said, the role of a specialist nurse is in delivering effective sarcoma care. You may do a very good surgery, you may give very good staging, very good chemotherapy. They are all one part, but that is good sarcoma care. To give effective sarcoma care, they become custodians of care, and they are essential in every single unit, even in the developing world. If we train them, they become part, and they also become very good allied healthcare professional in sarcoma. So in our article, which we had written, it was just a small narrative review. So as the Pope had said recently on the World Health Day, the role of nurses in patient healthcare is truly irreplaceable. So similarly, as today, like orthopedic surgeons and physiotherapists, their relation is irreplaceable. You have to be, if you have to be a good orthopedic surgeon or a good knee surgeon, you need a very good physiotherapy team. The relation between orthopedic surgeons and radiologists is also completely irreplaceable. Similarly, especially in cancer care, more so in sarcoma care, musculoskeletal sarcoma, a trained specialist nurse is irreplaceable in a sarcoma service. Thank you.
Thank you so much, Dr. Raja. And I think very rightly pointed out, we do struggle in our settings with following these large number of patients up. Obviously, we do not have many skilled doctors, especially taking up this difficult field of sarcoma. And I think centers who are now developing into large volumes and catering for large patients, and people who have been working in this field for a very long time, like Professor Suhail Hafiz, Dr. Masood Umar, and then Dr. Badr Sahito and Dr. Zishan Khan, associated with major public center units, and Dr. Khalid Masood also associated with a major army service we set up, potentially have got an avenue to look into. So any comments and suggestions by faculty? Z? Yeah.
Thank you, Dr. Rajasekharan. A very nice talk. No doubt this is a multidisciplinary approach, we all know. And for a dream team, you need all these key players. And unfortunately, we do not yet have the luxury of it, but to be honest, it's mainly excuses on our behalf. If we try, we can set up everything. It's as simple as that. I have seen the effectiveness and the care that these sarcoma care nurses will provide based on my experience abroad, and you guys are experiencing it now. And you know that they are the pillar for the patients and for you. They make your life easy and the patient's life even easier. They work as your coordinators. They work as your relay person to answer all the questions that those patients have, and they are available 24/7 to them. So their role is paramount. One cannot deny that, and it's high time, in fact, past time, that we should develop these sarcoma nurses. And they are not just nurses, they have to have broad experience and exposure to all these specialties. And this is one of the things which is on my shopping list, and hopefully in the very near future, I'm going to start training one, because it makes our life easy, as simple as that.
Yeah, I completely agree, Dr. Z, especially since you've also been for a significant amount of time in the UK. Now, actually, one of the centers, if I understand, Stanmore in London, they are training specialist nurses. And so, of course, the UK has got a specific triage system. So even the small benign tumors are completely seen, examined only by the nurses. They don't even come to the clinician because he's busy, and so the nurses are able, if they find something sinister, something worrisome, they just bring them up, because it helps even in. So the main point is they get so well trained. And if you just give them about 2-3 years, as you know, I quoted the Aravind Eye Hospital, they just say you have to empower them. You give them the responsibility, you teach them, they will be very good assets for your care, especially in countries like India and Pakistan, you know, where healthcare system has a lot of way to go, and they will be really very good pillars, especially in cancer care.
Yes, up until 2016, I remember we used to have a nurse consultant, and she used to do follow-up clinics with us, and she was as good as any senior registrar or a fellow. The only thing she wouldn't do was to see a new referral just because of medical legal issues. She would do hand-to-hand follow-up clinic with us, and as good as any.
Exactly, yeah. Just like how radiology, any good sports surgeon has got a physiotherapist almost, you know, they liaise very often. So same thing, I think, in sarcoma, if we have nurses, it's very, very useful.
Dr. Singh?
Yeah, I just wanted to say, although we don't have big numbers, but we have a proper sarcoma care clinic now, and we have one nurse slash navigator. So we call her the tumor navigator. So she knows all of our patients, and then this is for booking, for telling them when setting up their dates and everything. So this is one number that the patients have, that we have. that's the point of contact. We also have a sarcoma manager now in our clinic. So this is the one who's managing our clinics, managing the MDT. Also, we now recently started having a manager for MDT. So any case that anyone has sends to that person, he's the one who organizes getting the CDs for CT scans, the MRIs, the PET scans, and getting them bookings for the same, so that you can just ask them to do 1, 2, 3, and by the time this case is up at the MDT, all of this stuff is already done and present. We haven't gotten to the point of a sarcoma nurse. I think this is because of our availability. So we are available to provide all of these things for the patients at the moment. But as the number of the cases increase, I completely agree. A specific nurse or a set of nurses should be able to do that. I think the ones working with us now will be trained at that level, I think, as we go forward.
Yeah, definitely. I completely agree. Yes.
Dr. Masood, any comments from the system in AKU? What you have set up?
Thank you, Dr. Raja. A very nice talk, a very new concept to us who live in Pakistan and haven't had that chance of working outside. But I like your word decompression. Yeah. And so obviously, even as we as oncology surgeons need decompression. Yes. Oncology, you would agree, is sometimes a very depressing field. Sometimes you do an excellent job and there is a clot in the artery and the whole reconstruction failed and you have to amputate. Sometimes it's an excellent job, 3 years down the line, there is no recurrence and suddenly there is a spot in the chest. Yes. And within 6 there is hardly any survival. Depressing. Yes. And you are attached to the patient, especially if it is a child, you are very much personally attached. So I like the word decompression, but that should hold for surgeons also. Anyhow, we have a system of registry officers. I have a registry officer. I work in a private university hospital in Karachi, and most of the functions that you stated is being managed by my registry officer. She maintains a tumor registry. She organizes the tumor board, organizes their follow-ups, and most of the function except examining the patients themselves, because I am in a private institution. Patients pay to be seen by the consultant themselves. They don't want to be seen by anybody else. So those factors are also inherent in our social setup. I'm sure same are there in India. I see all the patients, but the groundwork is being done by the registry officer. So I fully agree with this concept. As we move forward, as we expand, I think we would need a more specialized person running at a lower level. Thank you.
Yes, sir. Completely agree. Completely.
It's really a dream to have this facility in our setup.
I want to make a comment, if you can hear me.
Yeah.
We have been working with a lot of pediatric patients at the Indus Hospital, and we have developed a school for the children inside the hospital. And we have a psychosocial team that is doing all the counseling when in case we have to do an amputation or disarticulation, and we have a good backup of the nurses. We have not actually named them sarcoma nurses, but if I can retract, our nurses have been doing the same process since my inception in the hospital since the last 4 or 5 years now. So we are in the phase of developing it, and I hope we'll be able to manage like the other developed parts of the world.
Yeah. No, even this concept till the time I came to the UK, of course, in India, my sarcoma training was very minimal. So till the time I came to UK, I never had any concept on this. So even, of course, in the UK system, they have nurses for hip clinics, they have specialist nurses, but in sarcoma, especially it's externally funded, these people are trained and so they know like the nurse knows very well, suppose the patient calls and says, okay, I'm having a little bit of a new swelling. She knows, okay, it may be recurrence. She organizes the MRI, gets it done. So they are very well trained. And as you said, even in back home and in places like India and Pakistan, if we just empower them, bring them as part of the system, make them equally responsible, they will in fact be one step ahead of us. They'll be more enthusiastic and they will communicate. They develop like a family relationship, with the patient's family, which is very useful.
Can I just mention just something completely off the subject, Dr. Masood and Dr. Attar. If you guys remember, we started having a good online surgical oncology MDT for a couple of months till you buggered off. Attar, I'm talking to you. Don't you guys think? Don't you guys think it's high time ke hame bhi apne decompression phase ki, like Dr. Masood said, meeting ko dobara shuru kare, because all of us are working in isolation in different hospitals and doing the work within our limitations. So should we not think about it whilst we're all here? Should we not consider restarting that at some point in the near future?
I agree 100%. Somebody has to take the responsibility, because I think for 3 or 4 general clubs that Dr. Attar managed to do Sunday morning, I remember it was early Sunday morning, so everybody was happy. We would conclude in an hour or 90 minutes. And the other project which has never seen the light of the day is National Tumor Registry also. So I'm also partly responsible for that, but sometimes we plan but we don't succeed. I think it's not to say that we should leave it. I think we should continue to work on it, plan it. This time the current update is General Saab knows the board has refused, we cannot have a registry officer. So it is a political issue within POA, and obviously the leadership of the Oncology Forum, the way it has been decided and the way it has been changed also speaks a lot. But obviously I hope we meet physically in the forthcoming OrthoCon. We have another day-long session being led by Dr. Badr this time, or 13th of November. So hopefully if we get time, we can have a business meeting also and decide on these key issues of collaborative research, sharing data, registry, as well as journal club, this tumor board, MDT. So those are key issues, I think, which we have to decide as a forum. Thank you.
I do intend to come to attend your con, but I can't appreciate अगर उसमें कोई virtual attendance का भी option हो. I don't know how to get there. If UK still stays on the red list, I can't get to Pakistan. But let's see. But I think a business meeting is required to rekindle interest and support for the projects that we have not been able to discuss at all through the pandemic. Maybe the pandemic, I'm using it as an excuse. Apologies.
Yes, you are.
If Z remember, one of the Macmillan nurses, I'll just show you the picture. You allow?
G? Yes. One of the very few. We used to have one for every clinic and one nurse consultant to the OPDs as well. So when you were there for us, if I remember correctly, we used to have 4 sarcoma nurses or the liaison nurses and 1 nurse consultant.
That's correct.
And 1 nurse.
He was started.
Yes.
There's lots of echo going on.
Yeah, I think Dr. Masood जब अपने आप को mute करते हैं तो वो echo खत्म हो जाती है. There is some hardware issue there, which I know from the beginning of the session, but we have not been able to sort it. So
ये
yes.
डॉक्टर मसूद की इलेक्ट्रोमैग्नेटिक फील्ड है जिसकी वजह से
So, Athar, what is the plan now? I think
concluding remarks.
Call it a day.
Yes,
General Sahib should
thank you
give
so
the
much.
concluding remarks.
The concluding remarks, General Suhail, if you should give.
Thank you very much. Wonderful time to meet, at least online. I would tend to agree. I'll take the last bit first. I think it is high time that we should start holding the meeting again. If it's not possible physically, maybe as we are just held a seminar, we can hold a meeting of the Oncology Forum. Masood has very rightly pointed out certain political stringing and everything vis-a-vis POA is concerned. I think we should ignore those things for a while. But as a community of oncology surgeons, we should stick together. Whatever form we have, or whether we are a forum or we are in any position, we should evolve a program as we used to do an annual program in which even if because of the pandemic, we can go for virtual meetings. So I would suggest that we should plan, number one, our annual general meeting. If everybody's coming in the OrthoCon, maybe physically. If people are not coming, then maybe an online meeting. Then a program for the workshops. We haven't done any workshop this year. And seminars, of course, they're very much there. So Masood and most of the senior colleagues understand the political things. We shouldn't be bogged down by those things. We should really stick together and take the forum in the direction wherever we feel appropriate. For example, nurses, sarcoma nurses is an important issue, but training the young doctors, training even the medical students about this particular important field. And then, of course, the general surgeons that are around us, whom take biopsies left, right, and center, and then they try to take the tumors out and then give us the complicated cases later on. So I would strongly recommend that we hold a meeting. Masood is the chair now, and he can plan it on priority. Now, coming to today's session, I think it was a wonderful day that we had. This has actually highlighted one important thing, that a regional approach to a complex problem, we are able to handle many issues together. So maybe instead of a disease-specific, we should continue to hold region-specific seminars or kind of activities. The first part given by Dr. Khalid Masood, Dr. I'm forgetting the hand, malignant and benign tumors, and then the amputations. They were very well done. I think the interesting bit was the different approaches after reconstruction in the proximal humerus. Everybody chipped in very well. I, for one, got excited by the cryosurgical technique. I may try to come to Karachi and spend some time with Badr. Yeah, it looks like a wonderful technique. The old age suspensions, the arthrodesis, the megaprosthesis, they are very, very much there. And of course, the scapulectomies and reconstructions that topped it off. A wonderful day. I'm so grateful to everybody. Athar, you organized it very well. I think we should give you further responsibilities. If you have done it so well, maybe MDTs, you might like to continue from UK. You'll have to wake up at 4 in the morning And maybe any other person can volunteer. We have youngsters here. Ali is here. Badr is here. Athar would be coming back soon. I'm sure. If he doesn't decide to get an immigration or a blue passport. For the future activities, I think we should pick up a young soul, Ali, Badr, even Jahangir can and Athar can all come in. And that is all I had to say. Thank you very much, everybody. The speakers were very clear, lucid, and I think I personally learned a lot during this session. Thank you very much.
Thanks so much, John sir. Just on the MDT that we used to have, a couple of issues that when we were doing it, I shared with Dr. Masood and yourself as well. And I think we did discuss it on the forum with WhatsApp messages. I think the frequency was probably, we started off with a higher frequency, which is probably not comfortable for everybody. So we might want to do it perhaps every fortnightly or every 3 weeks, as everybody thinks. And then in terms of hosting it, I think there are a number of people develop a rotation and have multiple people do it. I'm happy to contribute from here.
Can you unmute,
Ali,
unmute yourself?
Am I not unmuted? Am I? I think I'm unmuted.
Done.
I thought you were okay. It was Dr. Masood again.
Oh, okay. Yeah. Sorry, I'll just repeat quickly. So the frequency is one point that I was talking about. Maybe perhaps I suggest that we do it fortnightly or every 3 weeks, because every week it becomes a bit taxing on everybody. And I think we were also struggling to find enough cases and generate enough interest. To keep it interesting, we need to have people contribute their cases and come up with timelines, because everybody's got different workload. For example, people work in a high volume center, or people have got established practices like senior surgeons, and then there are juniors who are starting who don't have a lot of cases. Thus, obviously, then coming on every week, especially on a Sunday, might become taxing. Young लोगों को ज़रा ज़्यादा taxing लगता है. I'm not gonna dwell into why, but I'm happy to contribute from the UK. आपका जो suggestion है to involve Ali, Jahangir, everybody, I think we can develop onto a rotation system. एक दफा मैं करूँ, एक दफा Ali कर ले, एक दफा कर ले. Everybody can, sort of lead on it, because it does take a bit of, texting people or calling up people that we got cases, and once we've got enough cases, we can have a fruitful meeting, rather than everybody dialing in and then just having either 2 cases to discuss or too many cases to discuss.
I agree. We can take turns on the on the MDT. We can have I think it will be 12 people, 12 hospitals at least, if we include Mohsen and Athar, even from people from outside. So why not? Everybody can chip in 3 or 4 cases for his turn, monthly meeting, and we go from there. Why not? तो अतर साहब आप रोटा बना दें फिर.
इंशाल्लाह
रोटा भी बना लें, और साथ में ग्राउंड रूल्स भी बना लेना कि any case that has to be included has to have a learning point, either a diagnostic challenge or a surgical challenge or something that you did which didn't turn out according to your plan. So I think we need to have some ground rules.
And obviously, pre-operative cases will have to be evaluated an opinion for a case that needs
opinion mainly. Yes,
exactly.
जी सर, वो लास्ट टाइम इसी तरह हुआ था. पहली 2-3 मीटिंग्स अच्छी थी, फिर उसके बाद it went off to showing off our post-op cases.
Exactly.
That's what I was trying to say.
We can leave that to the coordinator of that session to decide what comes in and what stays out.
I'll design a
Nice to the coordinator.
and put some ground rules, a draft of ground rules.
I think we can do that, yeah, easily.
Design a performer, get a rota, so 3 documents we can work on, and then post it onto the WhatsApp group. We've got to support virtual, so we've got a nice forum to communicate. The good thing about the forum, about this forum, is it's a very nicely gelled up forum.
The number of cases we limit होने चाहिए 5 to 6 maximum एक meeting.
And that's why we're talking about prioritization.
So Dr. Athar, we have a WhatsApp group. I think we can continue our discussion on this issue over there, but I think it's high time that we conclude. We've had good 7 hours of continuous oncology with a 5-minute break. So I think
big decompression time needed now.
So for oncology surgeons,
very well. So I think great contribution by all, and we have had some new entries. Brigadier Khalid Saab, I think was new entry for this course, and very valuable talk from him. Dr. Mumtaz and Dr. Aisha also, I think, joined our group. So we are gradually expanding. Obviously, we won't expand so exponentially, depending on people's interest. And we have also been survived by 12 attendees so far since last 7 hours. So credit goes to them also. I hope they've had some good take-home session, take-home message, and some understanding of upper limb pathology and its treatment. So from my side, from the management of OrthoCon, Dr. Haroon and myself say goodbye and wish you all good luck, and hopefully see you on 13th November in OrthoCon actually, and then we would meet again formally on 13th November as the specialty day for oncology, inshallah, and Dr. Badr will be leading that session. So thank you from my side.
Thank you so much. Allah Hafiz.
Allah Hafiz.